Good morning, ladies and gentlemen. We would like to cordially invite all presenters and guests into the hall as the event will be starting any minute from now. Just a reminder to all, do kindly switch your phone into silent mode throughout this event to avoid any interruption. Thank you in advance for your cooperation and attention. Assalamualaikum and good morning, ladies and gentlemen. Welcome to UiTM Dental Student Scientific Symposium 2022. On behalf of the organizing committee, I would like to extend a very warm welcome to all of you here for today's oral presentation. I am Nur Bahira Atira, and it's my pleasure to be the MC for today's presentation. Ladies and gentlemen, first, I would like to invite our honorable judges and timekeeper to take their seats. Allow me to introduce to all of you our honorable judges for today's competition. Our first judge is Professor Dr. Seo Liang Lin, the Dean from IMU, as the Chief Judge. The second judge is Professor Fuad Hussein Al-Bayati from University Technology Mara. And last but not least, the third judge is Associate Professor Dr. Nurul Ashikin Yahya from University Kebangsaan Malaysia. And our respectable timekeeper for this presentation is Sofina Ratwan. Ladies and gentlemen, as a kind reminder, please lower down your voices and ensure that your mobile phone is switched off or turned into a silent mode to avoid any interruption. I would like to remind everyone to ensure that no guidance or prompts are given to the presenter, as this may disrupt the process of the presentation and the focus of the presenters. Your consideration is very much appreciated. Before we proceed any further, do allow me to explain a few house rules for the session. The time allocated for oral presentation is 10 minutes. The first bell will be rang at the 8th minute, and following the second bell at 10th minute. Followed by 5 minutes of questions and answers, Q&A session from the judges directed to all presenters. Another bell will be rang at the end of the 5th minute, indicating the end of Q&A session. Now, let us begin with the first pair of presenters, Raja Nur Nabiha binti Raja Amir Hamzah and Nurhaini Najwa binti Muhammad Mahmud, to present their research topic entitled The Impact of the COVID-19 Pandemic on Dental Practitioners in Malaysia. However, Nurhaini is unable to attend today.
be presenting our research entitled The Impact of COVID-19 Pandemic on Dental Practitioners in Malaysia. Here is an outline of our presentation today. The first COVID-19 outbreak was initially reported by WHO on 31st December 2019 in Wuhan, China. In less than a month, the first COVID-19 in Malaysia was detected in Johor from China tourists that travelled from Singapore. The sudden spike of local cases that emerged from the religious cluster has caused the government to impose a 14 days MCO, which to control the spread of the infection. During the MCO, MOH does impose a strict protocol to limit only emergency procedures, and they suggest to defer all elective treatment. With that, multiple guidelines have been published by WHO, MOH, and MDA to face the current situation. This has resulted in the reduction of patient flow, which can cause serious monetary implications, especially to private practitioners. A survey from ADA stated that 60.8% the respondents indicated that the influx of patient flow will reduce than usual within normal operation hours, while a study from IDA reported that 30% of practitioners have closed their practice either temporarily or permanently during this outbreak. However, dental regulatory bodies in the UK and Ireland does offer financial help and loan to the affected individual. UK government also provide financial plan to pay their rent, salaries, supplies or consumable items to the affected individual. This is some of the research that has been published recently. Based on this research, I can conclude that most of them agree that they are being selective to the procedure done, which is limited to emergency only. And most of the respondents mentioned that they believe that by reducing the treatment session and also usage of PPE can reduce the risk of getting infected. However, most of the respondents also mentioned that they had difficulty in providing the PPE due to the shortage in the early of this pandemic. I also found out that private practitioners are mostly affected during this pandemic as the guidelines provided are strictly prohibiting them from practicing. Therefore, here is our objective, which is to identify the factors affecting, to assess the dentist perception, and to compare the monetary issue among dental practitioners during this pandemic. Moving on to the methodology, this is a cross-sectional study done using convenient sampling method, and all registered Malaysian dental practitioners were invited based on the sample size calculated. From final samples recruited from this study was 468. Next, here is the flow of our data collection. A tick approval was obtained from UiTM Ethics Advisory Committee. And then the dental practitioner, we include those who registered under the MDC, either they were at the government or private clinic. After that, a validation of questionnaire was obtained through content and face validation. Then we proceed with an online self-administered questionnaire where it was created through Google Form and has been distributed among dental practitioners through various platforms, which is email, WhatsApp, with acquired consent prior to answering. This questionnaire consists of 4 sections, which is social demography and professional information, dental practice during COVID-19, dentist perception regarding COVID-19, and lastly, monetary issue faced by dental practitioner during this pandemic. This is some of the example of our questionnaire. The result will be continued by my partner virtually.
This table shows the demographic data of our respondents. As you can see here, most of them are female, age of 25 to 54 years old, many working in central zone and from Ministry of Health. This figure shows the dental practice during COVID-19 at the same MCO. From here, we can see that during MCO, almost 50% of the respondents opt to open for emergency only. Meanwhile, during our MCO, more than 60% open as usual, but with strict SOP. This table shows the dental practice during COVID-19 between different oral health sectors in Malaysia. All sectors experience decrease in number of patients, since their practice and phone fashion from almost better at Australia. They also follow the guidelines given, however the result is not significant. the financial effect among the practitioners. From this video, all value are significant except for the part of received financial assistance. As you can see here, private practitioner is the most affected during this pandemic. As for this video, it shows the experience of private dental practitioners during pandemic. Among all the experience stated, remunerated staffs and increased the use of PPE are the highly chosen. Based on the results, majority of our respondents were from government sector, which reflect the overall distribution of dental practitioners in Malaysia. Most of them are from Central Zone, which located in the red zone. Majority changed their practice and follow the guidelines given. This can be seen when 87.6% of government and primary dental clinics were operated as essential service provider. However, almost 400 private dental clinics have requested to close their clinic, while more than 200 of them requested to change the operating hours during MCO period. Because of regular sanitization and their own choice to opt for advanced treatment only, 80% of respondents experienced reduction of patients. According to a study done in California, teledentistry can reduce the clinical visits and determine the urgency of treatment. However, despite those good feedbacks of teledentistry, most of our respondents still disagree about the effectiveness of it. They claim that this kind of assessment, lack of gross observation, and may lead to misdiagnosis and wrong judgment in determining the urgency of treatment. Majority of respondents perceive that the guideline is useful, and they do expect changes in the current guidelines in the future. Their perception turned into reality when a new guideline was published and circulated following the new announcement of the RMCO to allow more people to utilize the oral health service. Previously, I've stated that our respondents disagree on the perception of reopening of dental clinics can spread the virus, and there is possibility of discontinuation of dental profession if pandemic persists. This reflects on their belief in the effectiveness of PPE in preventing virus transmission, where 93% chose to agree. Studies showed that only with the proper sequence of donning and doffing during the clinical procedure can cause the PPE to be effective. In MDS guidelines, they suggest to wear gown, mask or respirator with goggles or face shield, and head cover. However, a study by Al-Khalifa et al. Presented the best PPE where one should wear exactly like in MDS guideline with addition of rubber boots. On November 2020, Oral Health Program Ministry of Health Malaysia had published a compilation of nationwide report of Malaysian oral healthcare workforce involvement. It contains the chronology of COVID-19 outbreak, organizational planning and monitoring, the implications on oral healthcare services, and oral health involvement in public health activities. As for monitoring issues, 38.7% of private practitioners have difficulty in sustaining their practice due to additional protective measures, which lead half of them to use other sources of income. This is further worsened when 80% of dental business owners had decreased income, with 65% of them expected further reduction in the following years due to the struggles that had been faced by the dental practitioners and also economic crisis in the early pandemic. Malaysian government decided to help them by giving several stimulus packages. This is in conjunction with the help from MDA to ease the burden of rental and loan.
Our study does have limitation where it only represents 4.3% of total dental practitioners in Malaysia with uneven less proportionate sample. Thus, we recommend more systematic sampling technique which can be done by distributing an online questionnaire via electronic email to each member of each agency with equal distribution. We also recommend further research to be conducted to evaluate and compare the impact of COVID-19 in two different situations with different variants. From our study, we can conclude that most of dental practitioners continue to practice during the RMCO but limit to only emergency procedure during the MCO. They also incorporate additional measures prior to any dental treatment as they believe that the latest guidelines from the MDA websites are beneficial. Some of dental practitioners, especially private practitioners, are financially affected during this pandemic situation despite the additional measures taken. This is our references. With that, thank you.
Thank you to both pairs, Raja Nur Nabiha and Haini Najwa, for the interesting presentation. Now we'll proceed with the Q&A session.
Okay, hi, a very good morning. Thank you so much for a very smooth and informative presentation. I just want to know, you have both government and also private practitioners in your survey. So can you tell me what is the proportion first?
Actually, it's not equally proportionate because we obtain more respondents from the public mainly. Because it's quite hard to approach the dentists outside there to me. We do approach some MDA, but it will cost us 1,000 to email each of the dentists in Malaysia. So we just take initiative by approaching the dentists that we know to distributing the questionnaire.
So you actually obtain the results by hard copy?
No, through online questionnaire.
Through online questionnaire. So now I just want to know, I know it's difficult to get response from private practitioners. What is your proportion of government versus private? Offhand, do you know the figure?
This is, we obtain 111 for the private, and government is the rest, almost 300, more than 300.
So Ministry of Education,
1/4.
the working agency is 56% for Ministry of Health, right?
Yes.
Private, you have only 111. So you have drawn a conclusion saying that the remunerate for the staff and the income is the one that is most affected. Is that right?
Yes, because in the questionnaire we did a special section for only private practitioner. That's why we come to the conclusion that there is the remunerated staff and also regarding the income.
So, do you ask what are the challenges faced differently by MOH and also private practitioners?
We noticed that most of the respondents actually didn't know that the government has provided stimulus package to help ease their burden. And most of them mentioned that to overcome the financial issue, they had to use the KWSP and also other side business and also investing to counteract the financial loss.
Okay, thank you so much. You have mentioned about validation of your questionnaire.
Oh yes, we did the validation of questionnaire, which is content validation by 2 senior researchers, one from UiTM and one from IIUM. And for the face validation, we did give the questionnaire to 10 respondents prior to the access of the survey. And we do obtain the validity of this questionnaire more than 0.8.
Okay, so can you tell me what is the objective of doing content validity? I mean content validity and also face validity.
For the content, we just want to know whether this questionnaire is suitable for to be distributed. And for the face validation, we want to see whether the respondent can understand the question that we ask.
Okay, thank you.
Okay, thank you. I think I got maybe 1 or 2 questions. The first question, can you tell me how you collect your sample?
At first, we want to use a random sampling technique, but we decided to use convenient sampling because we want to obtain as many respondents as we can.
Yeah, I mean in this case, when we tell us practitioner in Malaysia, so this sample, the one you presented for us, represent all the states in Malaysia, or only in KL or 2 states?
It involves all the states in Malaysia, but unfortunately we couldn't get much from the Sabah Sarawak due to limited of our contact and all.
So in this case, if you really distribute it to all the state of Malaysia, how you collect the sample?
I think that one you can use the stratified sampling technique.
Okay, thank you.
Time. Okay. May I know how did you develop your questionnaire?
We actually adopt it from a study done in Iranian, which is by Ahmadi et al.
Okay. Can you tell me which variables collect the data on the financially affected, on the monetary problems?
I'm sorry, I don't really understand the
Okay,
question.
you're checking about a monetary issue, right? So can you tell me which question that ask about financially affected regarding COVID-19 among dental practitioners? What were the questions that you asked?
We asked about whether they are affected, yes or no, and then regarding the usage of PPE does increase their financial.
Okay, all right, thank you.
Thank you to
judges.
thank you to the judges for the questions. Tima Padil to present their research topic entitled Evaluation of Mandibular Condylar Changes Following Fixed Orthodontic Treatment in Class 2 Division 1 Malocclusion. However, Noha is unable to attend today. Please welcome.
Thank you for the MC. Assalamualaikum and a very good evening and a very good morning to honorable panels and also audiences. I am Nurul Qudratudina and today I will present a research evaluation of mandibular condylar morphology and structure following treatment with fixed orthodontic appliances in Class 2 Division 1 malocclusion. Malocclusion is defined as abnormal occlusion in which the teeth are incorrectly positioned together in relation to the jaw when they contact together. While British Standard Incisal Classification define Class 2 Division 1 as the lower incisor edges occlude posterior to the upper cingulum plateau, accompanied by increase in overjet and also proclined upper incisors. Clinically, the skeletal features appears to be prognathic maxilla and also retrognatic mandible, accompanied with discrepancy in dental-alveolar relationship and also facial aesthetic problems. Treatment modalities for Class 2 Division 1 malocclusion includes growth modification, orthodontic camouflage, and also orthodontic surgery. Treatment through orthodontic camouflage will utilizes fixed appliances in mild to moderate skeletal pattern, where the use of Class 2 elastics, Class 2 inter-arch elastics will help to produce dental Class 2 compensation in order to reduce the overjet and also to correct the overbite. The orthodontic camouflage treatment also will help to move the mandible forward. Temporomandibular joint is defined as a joint that acts like a hinge, which connects the jaw to the skull. It is formed by the articulation between the mandible and also the temporal bone. Any abnormalities to the temporomandibular joint is termed as temporomandibular joint disorder. The complex pathophysiology of temporomandibular joint disorders, TMDs, is still poorly understood. However, the generally accepted etiology for TMDs includes multifactorial, includes untreated malocclusions, unstable occlusion, stress, psychological factors, and also trauma. Patients that come with temporomandibular joint disorders can have signs and symptoms such as facial pain, earache, and also loss of normal function of the jaw, such as locking jaw and also jaw clicking. It has been reported that patients with Class 2 Division 1 had condylar morphological changes after completing orthodontic treatment. While these morphological changes causes symptoms of TMDs in some patients, some of the other patients reported no symptoms at all. Hence, this is why the possibility of orthodontic treatment as one of the etiological factors of TMDs has been widely discussed in the literature for over the years. Many studies have been conducted to establish the cause and exact relationship between those two. However, it is still not fully understood until today. Therefore, the objective of our study is to evaluate the condylar changes in relation to the treatment with fixed orthodontic appliances, and also to correlate the condylar changes with the length of orthodontic treatment. This study begins with sample size calculation. For the adjusted sample size, we acknowledge 20% of the dropout rate, and the highest sample size is 105 from Pearson's correlation. And then we continue with the patient selection, where we recruited patients who fulfill the inclusion and exclusion criteria as shown below. Next, we continue the study with the data collection, where we collected from the patient's iDerms. The record that were collected were demographic data and also the clinical data, including symptoms of TMDs, types of orthodontic treatment mechanism that was used, and also the length of treatment. The study is then continued with the radiographic image acquisition and assessment, where we retrieve the DPT, or panoramic radiograph, from the archive of the radiology department, where we will assess the height, width, and also the surface area from the DPT. And then the DPT will be analyzed based on those described by Momjan et al. By using digital image software ImageJ. First, RT Remus tangential line will be made to connect the most posterior part of the condylar head and also the ramus. Next, first orthogonal line will be made passing through the most inferior part of the sigmoid incisor. The second orthogonal line will be placed arbitrarily 0.25 mm above the first orthogonal line, and the third orthogonal line will be placed tangentially to the most superior part of the condyle. And then this green line represents, this green line established connecting from the OL3 to the OL2, representing the height of the condyle. The intersection between the line OL2 and also the anterior and posterior cortical of the condylar neck were then named CN1 and CM2 respectively, and the establishment of this line represents the width of the condyle. The outline of the condyle is then established as we want to analyze the condylar surface area and also the morphology. The morphology were then assessed as those described by Goemon et al. 2017. Next, we will continue with the statistic analysis. For the demographic data, we recruited 91 patients, where 60% of them aged from 18 to 25 years old, predominantly female and Malay with 78.4 and 92.8% respectively. For the evaluation of height, width, and also the surface area, it was done by using a paired t-test. Assessment of the condylar structure revealed that there was a significant increase of the right condyle pre and post treatment in terms of the height. There is also changes in terms of the width and also the surface area. However, the changes were non-significant. And then for the assessment of the morphology pre and post treatment, we are using Pearson's chi-square, yielded that the shape of the condyle changed significantly pre and post treatment. And last one, this is we used the independent t-test. We found a significant correlation between the left condylar height, width, and surface area, but all seen in the left condyle only. However, on the right condyle, there was no significant difference found. And this table shows the condylar morphological changes in relation to the temporomandibular joint disorders, where we found that 5 out of 91 patients presented with signs and symptoms of temporomandibular joint disorders, and we can see from the table, 2 reported changes in morphology, while 3 reported no symptoms at all. And then this one, there were significant changes observed in the life condyle pre and post treatment in terms of height, width, and also the surface area. And this is in accordance with a study published by Manavisagam et al., which reported the same results as well. For the radiographic alteration to treatment duration, the reduction of condylar height, width, and surface area was significantly correlated to the total treatment duration, which is more than 3 years. And from the results, we can see that the left condyle are more susceptible as compared to the right condyle. And then in terms of relation of the MD to orthodontic treatment, we only found 5 out of 91 samples, which correlates to the 5.5%. From this, we can conclude that the orthodontic treatment does not increase the risk of the MD and does not seem to be linked as an etiological factors of the TMDs. For the morphological changes of the TMJ, it was speculated that the morphological changes may be affected by the loading force from the glenoid fossa, from the condyle and also the glenoid fossa. And Ezel et al. Stated in his study that orthodontic treatment can actually cause changes in the morphology in a longer treatment of time. This study is limited by no baseline clinical data, where there is no data on dominant chewing side and also small sample size. As a conclusion, orthodontic treatment resulted in condylar changes in terms of height, width, and also surface area, and also morphology is correlated to the total amount of treatment duration, which is more than 3 years. Although the interarch elastics seems to give some kind of differences, however, it was not significant. The prevalence of the MDs is 5.5, possibly due to orthodontic treatment. The recommendation for further research is to increase the sample size and also adding inclusion criteria such as dominant chewing side and also using 3D imaging instead of 2D imaging. These are our references. With that, thank you so much.
Thank you, Dr. Dina, for the excellent presentation. Now we'll proceed with the Q&A session.
Okay, thank you for the very comprehensive presentation. I just want to know, how many of you do the calculation from the OPG?
2 of us do the calculation from the OBG.
2 of you. So how was the calibration process done in terms of intra and inter-examiner variability?
It was done, we done the intra and inter-examiner correlation with our with Dr. Hidayah, which is specialist in radiology, and it has yielded results of 0.1 which means that all our measurements actually correlate to each other.
What is the kappa value for the calibration process in terms of inter and intra-examiner variability?
0.91%.
0.1, which is very low. Kappa value, yeah. We normally accept kappa value of above 0.7.
Point 0.91.
Oh, 0.91.
Yes, 991.
Between you and the the specialist.
Yes.
Between you and your partner?
And also with the specialist.
No. Okay, you need 2 different or even 3 different kappa values. Between you and the specialist, between you and the partner, and between you yourself. Do you understand
Yes.
what is intra and inter-examiner variability?
Yes, we have done only 2.
So meaning you and the specialist and your partner and the specialist.
Yes.
Between you and your partner?
No.
between you yourself?
Yes.
Okay, thank you.
Okay, thank you. A few questions from me. Now, your age group from 18 to 35. Is there any effect of the age group on the condyle deformity or changes?
Yes, we want to make sure that all our sample does not have any other factors that can affect the condyle, which is why we choose 18 to 35, which means that the patient has already finished growing, 18 years old, and we want to make sure that there is no effect from the aging as well, which is why the maximum age is 35 years old.
Okay, can you tell me why the left condyle more affected?
From our research and also our reading, the most probably cause that affected only the left condyle is because of the dominant chewing side. When when someone dominantly chew only on one side.
So did you ask the patient about the chewing side, or you speculate this?
No, we does not have the patient on the chewing side, on
Okay.
data on the chewing side.
Okay, these X-ray are standardized X-ray.
Yes,
It is taken with open mouth or closed mouth or relaxation.
all with closed mouth.
Closed mouth. Okay. Okay. Thank you.
Yeah, I have a few questions as well. What is your study design actually? Can you explain about your study design? Because in your slides you never said, or maybe I missed, that you are actually evaluating dental records, right? So what is your study design?
Our study design is a retrospective study.
That is actually a type of, retro. What does retro means?
Retro means
Retrospective.
past.
Yeah, but what are you doing actually in this case?
We analyze the radiograph from patients who completed orthodontic treatment.
Okay. Do you actually get a consent from patients to actually use the data? And do you get any ethics for using these dental records?
We have ethics of using these dental records, as we cannot bring any information from this research, from the patient's profile data in the items out.
But were there any consent from the patients earlier on?
Yes.
Thank you.
Okay, thank you.
Thank you to the judges for the questions. Next, please welcome our third presenters for today, Umi Syahada binti Muhammad Hazan and Putri Shamira binti Azhar, to present their research title, Attitudes to the Use of Rubber Dam Between Malaysian and Indonesian Dental Undergraduates. Please welcome.
Assalamualaikum and very good morning to everyone. Today, I am Putri Shamira, along with my partner, Umi Syahada, will be presenting our study entitled Attitude to the Use of Rubber Dam in Dental Procedures, a survey between Malaysian and Indonesian 4th and 5th year dental undergraduate. These studies is supervised by Dr. Nur Ilyani and Dr. Muhammad Faiz. In relation to our topic, Attitude to the Use of Rubber Dam, what is important is the definition of rubber dam itself. Rubber dam is a thin, square sheet, 6 inches, that are usually made from natural or latex that used in operative dentistry to isolate the operative site from the rest of the mouth. The rubber dam was introduced in dental profession by Dr. Sanford Christie Barnum on 15 March 1864 in the United States. It has been recognized as a useful adjunct in dental procedures when performing an operative and root canal procedures. And rubber dam has a lot of purposes and advantages in dental practice that has been said in a study by Ibrahim Ali Ahmad, which are control of cross-infection, protection, improving treatment efficiency, and improve patient comfort. As shown in the bar graph on the left side of the slide, it is the result from a study by Iftikhar Akbar et al. In 2017, which shows the opinion of the student in regards to the value offered by rubber dam in dental procedures, which are provision of isolation and as aseptic working area, which gives 60.3% of answers, and then preventing of swallowing or aspirating of instrument, which give 31.5%. And lastly, prevention of ingestion of irrigants with 8.2%. And here are some reasons which made them neglect the use of rubber dam in dental procedures, which 88.4% students thought that the use of rubber dam will pose a difficulty in taking radiograph, which is it is the highest percentage of all. And then this bar chart shows that it shows a range of response by students, which when they were asked about a use of rubber dam for similar procedure in adult and children, which is extracted from the study Dr. William Ryan in 2007, and it appears that there is a slight preference towards adult with regard to the use of rubber dam, as 44% of students would use rubber dam equally in treating child and adult patient. As we all know that rubber dam usage give a lot of advantage. However, there is still negative attitude toward the usage of rubber dam. So the study was conducted is to see the factor that influence it. So our objective for this study is to determine the percentage of the usage of rubber dam in dental procedures and to compare the general attitudes towards the rubber dam application among Malaysian and Indonesian 4th and 5th year dental undergraduates. So move on to our methodology, which comprise a few phases. As this study, as a cross-sectional studies, it's conducted approximately 6 months, and it involved 4th and 5th year dental undergraduate from UiTM Sungai Buloh and Universitas Syiah Kuala, Aceh. Our total sample size is 302. A questionnaire is used as our study tools, which adapted from previous study by Saramala in 2009, and it is modified to a bilingual version. And this questionnaire consists 38 questions, which plus with socio-demographic variables, and it is distributed through Google Form and written anonymously and confidentially. And then the ethic approval is approved by UiTM Ethics Committee on 19th of June 2021, and then the questionnaire were distributed to UiTM Sungai Buloh and Universitas Syiah Kuala students. And then the data was analyzed by using SPSS 26.0 computer software. And then move on to our results. Upon analyzing our data, out of 302 total respondents, we obtained more female respondents compared to male respondents, which 245 female and 57 males from both universities. Next, we will use this table to show the use of operative materials for operative dentistry. A total 99.3% use composite for restoration anterior and posterior teeth. And then 8.3% use amalgam restoration to restore anterior teeth, while 32.9% use amalgam to to restore posterior teeth. Lastly, glass ionomer cement or GIC used by the students, 75.8% of respondents use GIC to restore anterior teeth, while 95.7% use GIC for posterior teeth.
So this bar chart is to show the use of rubber dam on adult and child patient, where 96.4% of the total respondents used rubber dam on adult patient, and another 20.2% did not use rubber dam on the child patient. And this table is to show the use of rubber dam in the operative dentistry, where 57.6% never use rubber dam while doing amalgam restoration on anterior teeth, and 48% never use rubber dam while restoring amalgam in posterior teeth, and another 6% never use rubber dam while doing composite restoration and anterior teeth, and 5.3% never use rubber dam on doing composite on posterior teeth. So this bar graph is to show the use of rubber dam in the root canal treatment, where 94% of a total respondent always use rubber dam while treating the root canal treatment in anterior teeth, and another 92.1% use rubber dam by doing root canal treatment in premolar teeth, and another 92.4% use rubber dam while doing root canal treatment in posterior teeth. So there's some agreement regarding the various aspects of the use of rubber dam, where can be seen in the pie chart here, and the highest percentage can be seen by the respondent that agrees that the rubber dam enables a clearer access when placing the restoration with 97%. And another 34.8% of the respondent disagree that the root canal treatment obturated without rubber dam are as successful as those isolated with rubber dam. And this result is statistically different with p-value of 0.209. And this, we also asked our respondent to imagine that they had been qualified and working in practice, and we asked about their opinion as well regarding the future usage of rubber dam, where 97.7% agreed that they will use rubber dam with adult patient when necessary. However, another 2% state that they will never use rubber dam when carrying root canal treatment in premolar and molar teeth. And this result shows there is a statistically difference with p-value of 0.001. And this is a total result of to see the factors that influence the future use of rubber dam in our respondent, where 78.1% said that it was due to the payment scheme, 97% said that it was due to the clinical procedures conducted, 94% said that it was due to the choice of material, and another 91.7% said that it was due to the ease of application. So, despite a huge number of respondents that acknowledge the use and the benefits of rubber dam, where we can see more than half of the respondents agreed and admitted that they will use the rubber dam routinely on the adult and pediatric patient. However, there are still a numbers of respondents that disagree to use rubber dam while they went out from teaching environment. So why does this problem arise? So the most frequent issue being addressed was it was being said that the rubber dam was difficult to apply, and this was confirmed with our data, which 65.9% of the respondents agreed that rubber dam is difficult to apply. And another one, they said that the rubber dam is technique-wise but time-consuming. So why? According to Ryan and O'Connell, it stated that the application of rubber dam, they perceive a time taken was wasted time rather than to adjunct their dam to complete their restoration. And lastly, some students said that the placement of rubber dam required a lot of practice. And a study by McCall et al. Also suggests that insufficient training leads to low frequency of rubber dam usage. And most of our students also agree that rubber dam placement give better visibility and longevity of materials that lead to some retention in retentive restoration with 89.1%. So for the conclusion, most of undergraduate students they use rubber dam in their clinical procedures, and most of the students also they acknowledge the benefit. However, there's still some negative perception, and they also mentioned that rubber dam application is difficult, time consuming, and also need a lot of practice. So this is our reference, and that's all from us.
Thank you to Umi Syahada and Putri Shamira for the great presentation. Now we'll proceed with the Q&A session.
Okay, thank you very much for a very interesting presentation. I note that you have mentioned amalgam is still used for anterior teeth. So, I mean, with the current minimally invasive concept and adhesive dentistry, I'm surprised to note that amalgam is still being used for anterior teeth. Can you explain that?
Okay, we asked that question because our questionnaire is adapted from previous study, and the previous study asked about amalgam restoration in anterior teeth and posterior teeth. That's why we use that question, and then we get the results and
So that's why we still include that question and result, because we literally adapted that question from the previous study.
Yeah, I do understand it is a standard questionnaire that you are using. What I am puzzled and surprised to find that we are using amalgam for anterior teeth. I think for the longest time we've never used amalgam for anterior teeth, and we have quite high percentage as well. If you can go back to the slide, I noticed, yeah, so I'm not sure. You know, my fellow judge was saying it may not be true. You see, it's quite high percentage, you know, 5% from UiTM is using. I'm not sure. But anyway, you go back to following slide. There's a slide that your percentage at the site is 50 and 60%, but you say it's 90-odd%. I can't remember one of the slide that says, yeah, okay, this one. On the site, your scale is 10, 20, 30, 40, 50. But your statistics state that it's 94, 92%. How does that tally? I cannot comprehend this. Like, can you just...
Because for this question, we gather the total respondent that said that they use rubber dam. So we combine the rarely, sometimes, often, and always result. So that's why it gave 94, 92.1, and 92.4 percentage.
Okay, so, well, you can't really combine in that sense because they are all different things. When rarely means entirely opposite from always. So you cannot combine and lump them together. Rarely means you hardly used it, which is a total opposite of you always used it. So your statistics of interpretation here is not accurate in that sense. You cannot tell people that, 94% of the respondent used it. Perhaps you may want to think about, 50-odd% always used it, and 20-odd% often used it, and less than 10% hardly used it, to give a more representation. Otherwise, you are misleading people. Because when I look at, 94 is really high, very good. You know, so you have to be very careful when you report your statistical finding. All right? Thank you.
Okay, thank you. A few questions from me. You concluded that there is more, the respondents is more female than male. Why? Can you tell me why? Yes.
Okay, as we said that we obtain more female respondent than male respondent because the total students in UiTM Sungai Buloh and Universitas Syed Kuala is more female than males.
Yeah, this is true. Can I go for the second? Okay, thank you. Now, your title is the using of rubber dam between Malaysian and Indonesian dental and
undergraduates.
yes. The sample represent all the undergraduate in Indonesia and in Malaysia.
Yes.
How? All the undergraduate student?
Fourth and fifth year. So in this slide, we didn't include the total respondent from UiTM and Universitas Syed Kuala, but in our
No, I mean you choose two universities, UiTM and one from Indonesia, isn't it?
yes.
So two universities cannot represent the countries. I mean, UiTM will not represent the country, so don't generalize this in your title, the uses of rubber dam between undergraduate student in Malaysia and Indonesia, because your sample is only from one university. I agree with Prof. Shea about the result actually. As far as when we supervise year 4 and year 5 and even year 3 in the clinic, we didn't see any amalgam filling in the anterior teeth. Totally, there is no, I assure you, 100%. 100%, no, this is not, it's not exist in UiTM. So I think there is a mistake in the response, or maybe the question should be from the beginning removed because it does not exist. And I'm sorry to say that this will give a negative impression, as well as in our practice, in our supervision. I'm periodontist, but you know we supervise in the CC all the group in year 3, 4, and 5. I didn't see any amalgam filling in the anterior teeth, especially in the anterior teeth. Even for the posterior, all of you, they use composite and rarely GIC. So please correct this because it's a big issue. I need to redo this. You need to look at this again. Okay? Thank you so much.
Thank you, Prof.
Can I add to the adapt and adopt questions tadi kan? Actually, your questionnaire, you said you adapted, right?
Yes.
So there is another type which is adopted. Adopted yang ambil anak angkat terus, dia ambil sebulat-bulatnya, okay? So adapted means you change a bit, you modify it. That is where when you could look at the questions and actually remove which is not relevant to your practice. And I think you know that, but you just don't do it because you might not, maybe you don't understand the concept of adapt. So that's what adapt is all about, right? And I see that rubber dam was used by 50% of respondents when performing root canal treatment, right? So 50% is like more than half, or half, is it? Half. So is it a student's choice to use rubber dam in clinics?
Yes.
It's not a compulsory thing? Lectures are here. Dah jawab eh? Do I still have time to ask? Do I have time to ask? Masih ada masa? Sikit lagi. Do you want me to move on? Okay, let's look at your slides. Yang ada table comparing of the questionnaires tadi. Okay, that one. Before that. Sebelum tu. The table. Okay, this one. Can you tell me how did you analyze this to get the p-value of 0.001 for all these
We use
opinions?
one-way ANOVA test.
What? Okay, why do you use one-way ANOVA?
To see there's any statistical difference between both school, UiTM and Universitas Syah Kuala. That's why we got 0.001.
Okay, isn't the use rubber dam with adult patients when necessary, is that a variable, one variable? How did you analyze this in the SPSS? Is that a categorical? What will be the answer for that? Yes, no?
Agree or disagree?
So this
The
table,
opinions.
this table is actually not self-explanatory. One is there's no title, and then satu lagi, yeah, we don't know the response whether it is a agree ke disagree, right? So it's quite confusing actually. So you can improve on this table. Okay.
Okay.
Thank you.
Thank you.
Thank you to the judges for the questions. Without further ado, please come to the stage the next presenters, Nur Irdina binti Nazmi Zahruddin and Shamim Ilya binti Ismail to present their research title, A Cool Play App as a Relaxing Tool in Dental Management Usability Survey.
Okay. Music is a therapy. It is a communication far more powerful than words, far more immediate and far more efficient. Assalamualaikum and a very good morning. I bid to the honorable judges, the precise timekeeper and members of the floor. I'm Shamim Ilya and my partner is Nur Idina, and we are supervised by Dr. Aimiza and Dr. Nirahayu, and today we are presenting our research entitled A Cool Play App as a Relaxing Tool in Dental Management Usability Survey. Arfid et al. Stated that dental anxiety lowers the pain threshold, which causes the patient to feel more sensory and affective distress during dental treatment. And dental anxiety may cause gag reflex. Gag reflex is a physiological defense mechanism which stopping any foreign materials from entering the trachea, larynx, and pharynx as stated by Kaur et al. And so distraction and relaxation technique, which is listening to music, was found to be more effective than prescription of drug to reducing anxiety before surgery as stated in Trends in Cognitive Science 2013. And this is where the AcuPlay app come in handy. The AcuPlay app was developed and it is an app that served the musical intervention and to manage patients with dental anxiety to ease simple and short dental procedures. This app contains 6 sections. The first section is author or developer, which has a background of each author. And the next section is introduction that has a brief explanation of this application. And next is the Let's Identify You, where the patients need to self-identify themselves and determine their anxiety and gag reflex level using MDAS and GAGS assessment that had been built into this app. And then the next section is Let's Listen, where the patients can choose the songs based on their music preferences, and they can listen to the songs throughout the dental treatment. This is the choices. And the last section is What You Say or Think, where the patient can give their feedback. Thus, the purpose of our study is to determine and compare the acceptance of clinicians and patients to the AcuPlay app to manage in dental treatment. Next. For methodology, Our study design is a cross-sectional study that was conducted at UiTM Dental Center, Faculty of Dentistry, UiTM Sungai Buloh. And our sample size is 32 dental clinical students and 32 patients. And the ethical approval was obtained from the Research and Ethics Committee, UiTM. And the data collected is that demographic survey and the modified user mobile application rating scale UMARS. And all the data were analyzed by IBM SPSS software package version 23.0, and the quantitative data was described as mean and standard deviation, and independent t-test was used to compare the mean between dental clinical students and patients, and also the mean between male and female respondents. And one-way ANOVA was used to compare the mean differences within the patient, between the patient's anxiety level. Next. This is our research activity flowchart. Our research is focused as pilot study with a total number of 73 subjects, which are 38 dental clinical students and 35 patients, and that fulfill the inclusion criteria. And the subjects were required to watch a 5 minutes video regarding the Akuplay app, and the UMARS questionnaire was distributed. Next. And moving on to the measurement tools. The first we use is demographic survey, which include the gender, age, race, marital status, education level, and also the occupation. The perception and acceptance of the Akuplay app was assessed using the modified user mobile application ratings skills, UMARS, which include 5 domains. The first domain is engagement, where the respondents will the apps is evaluated by how fun and interactive it is. The functionality domain, that how the apps perform, the performance of the app, and information domain, where the app's information and source of information is evaluated, and the aesthetics of the aesthetic domain, where the graphic and design of the app is evaluated. And there's another 2 domain with subjective quality and perceived impact.
Okay, so moving on to the results and discussion. Out of the 73 respondents, 53% of them were dental students, while 47% of them were patients. And from those 2 groups, 81% of them were female respondents and 19% of them were male respondents. The mean age of our respondents is 23 years old. So this is a bar chart that shows the mean score and standard deviation of each UMARS domain. Overall, the app quality mean score scored 3.96 based on 5 domains, which are engagement, functionality, aesthetics, information, and app subjective quality. The information domain scored the highest mean score of 4.14, while the app subjective quality domain scored the lowest mean score of 3.63. And as you can see in the bar chart, the perceived impact domain scored a mean score of 4.26, which was technically higher than the information domain. However, in the calculation of app quality mean score, the perceived impact domain was not included, as it is only used to obtain the information on the perceived impact of the app, of the user's knowledge, attitude, intentions related to the target health behavior. So in the information domain, this app's quantity of information recorded the highest mean score of 4.19, in which more than half of the subjects rated this app 4 out of 5, which means this app offers a broad range of information with some gaps and unnecessary details. And the low mean score of the app subjective quality domain may be due to the low mean score recorded by the willingness of the respondents to pay for this app, which was 2.99, in which 58.4% of the respondents rated this app 3 out of 5. Next, the engagement domain had the second lowest mean score, and 43.2% of the respondents rated this app 3 out of 5, which means that this app has basic customization to function adequately. In the engagement domain, however, the target group scored the highest with the mean of 4.19, which half of the subjects rated 4 out of 5. This shows that the respondents believe that this app is designed for the target audience, in which in our research would be patients with dental anxiety. The app's perceived impact scored a mean of 4.26, as I mentioned earlier, with awareness in this domain being the highest, with the mean of 4.32. The respondents believe that this app increases their awareness of the importance of addressing health behavior. Based on the high mean score, the Akuplay app is able to give an impact to the user's awareness, knowledge, attitude towards dental anxiety. So this is a bar chart showing the mean scores and standard deviation of the dental clinical students and patients. Overall, the app quality mean score of patients scored higher with 4.07 as compared to dental students, which is 3.86. And there was a statistically significant difference in the mean score of engagement and aesthetics. So this is a bar chart showing the mean scores and standard deviation of male and female respondents. Overall, male respondents required higher app quality mean score of 4.18 as compared to female, which was 3.9. There was a statistically significant difference in the mean score of engagement, functionality, and aesthetics. So based on our results of our study, 38.5% patients reported not feeling anxious prior to dental treatment, 35.4% were slightly anxious, 16.9% were fairly anxious, 7.7% were very anxious, and only 1.5% were extremely anxious. So this is a box plot of UMAR's domain according to the patient's anxiety level. The slightly anxious group scored the highest app quality mean score of 4.26, while the fairly anxious group scored the lowest mean score of 3.61. So music distraction is found to be the most effective management for moderately anxious patients, and Akuplay app is targeted to be used in patients who need short and simple procedures. Therefore, based on our study, this app is suitable to be used in slightly anxious patients. However, listening to music may not be effective to highly anxious patients, and they may need active engagement to enhance a sense of control. So before we come into the conclusion, we would like to talk about the limitation of our research. It was because of, due to the pandemic COVID-19, we had to conduct this research online. And the respondents only had the chance to get to know the Akuplay app via a 5-minute video that we have prepared and attached with the Google form. So our future plan would be to conduct another usability survey clinically with a proper use of tool such as modified dental anxiety scale to categorize the patient. Therefore, in conclusion, based on the high app quality mean score, the Akuplay app is believed to be highly likely to be widely accepted and used as a self-preference musical intervention in dental settings. So with the use of Akuplay app, short and simple dental procedures can be done at ease without causing any troubles to the clinicians and patients. That's all from us. Thank you.
Thank you to Nur Irdina and Shamim Ilya for the wonderful presentation. Now we'll proceed with the Q&A sessions.
Okay, thank you for the nice presentation. My question first is, how did you develop the app in the first place? Was there any theoretical framework, or you just suddenly create one?
We actually read a few papers on how musical intervention can help reduce dental anxiety and also gag reflex. So because there are other music streams like Spotify and other musical apps out there, so we decided to develop one musical app. But what makes it different from the other musical apps is that This app has modified dental anxiety scale and also gag problem assessment, in which can categorize the patient prior to dental treatment.
That is likely is your instrument to measure anxiety, right? But I'm talking about the app itself. How did you develop? How did you choose which music genre to put in the app? You know, what makes you decide on that? Is it based on something or just suka-suka je macam tu? Talking about relaxation kan? You're relaxing. So what kind of music? Takkan rock kot?
So for inside the app, the choices of music such as instrumental and relaxing songs that can calm the patient prior to the dental treatment. So for the app, is developed because the aim is to calm the patient. So we choose the songs that usually can causing calm to the patients.
Actually, you can also find in literature, through literature review on songs or musics that can soothe, people or patients. So that is actually your source of evidence that you can put in the app. That's what I want to know. Yeah, all right. So, what do you mean by slightly anxious patient? Yeah, highly anxious patient? Can't you use the app?
Because AkuPlay app was designed to ease the short and simple procedures with patients that have moderately anxious. Because high anxious patients may be not effective by using this app because they are anxious, so maybe they can focus to the music if we give them this app.
Okay, so last one. How would you make this app available? Is it in the clinic saja only, or how would you make it available? Accessible?
Our future plan was to make it available on the Google Play and also App Store. But however, it has not been published yet. So the public can use this app for their own goods.
No more questions for me.
Okay, thank you very much. A very interesting piece of work, especially developing the software. So did you develop it yourself, or you actually work with some software engineer to develop it?
Actually, our supervisors develop it with a software engineer, and this is just a continuous study.
Right, okay. So you have a total of 73 subjects, right? But out of which I notice half of them are dental students, only half of them are patients. But this app is meant to develop for patients. Why did you have dental student as the end user evaluator?
Because we would want to know if would the dental students practice it in their clinics with the patients.
Yeah, but they are not the one who will be using it. They are the clinicians. Your target audience is actually the patients. So I would discount half of the statistics that you present. Because by right, if you're using a usability survey, right? So the audience or your target participants should be the end user, which are the patients. So your sample size literally is only the patients. So you have included the dental students may mask the overall or skew the overall results. And I also heard that due to the pandemic, you are only conducting it online. So did these patients actually use it, then they answer your survey questionnaire?
No, because since this app is not available online, so we only got to attach a video of how this app works along with the Google form. So that is why our future plan would be to conduct another usability survey of a larger scale of participants, and the survey will be conducted clinically.
Alright, so it's actually a perception of the student or the patients on such app, whether they are helpful or not. Is that right? So it's not actually usability because they have not used it on a dental chair. So perhaps you need to relook at your title. It's a perception of patients using such relaxing tool, right? So, and also, maybe I'll pass it to Dr. Fat to.
Okay, thank you so much. It's only very short questions. Regarding what you show us, did you consider the pop as a relaxing music? Yes, Korean pop. You list, yes, the Korean pop.
Yes, maybe for some patients they think pop songs is relaxing for them, so we include the pop into the app.
Okay, thank you.
Thank you to the judges for the questions. Now, let us welcome our fifth presenters, Ahmad Izzat Arif bin Arif Amran and Muhammad Izzat bin Shaharum, to present their research topic entitled Cytotoxicity Effect of Simvastatin PLGA Chitosan Coated Scaffolds on Human Osteoblast Proliferation. Please welcome.
Assalamualaikum and a very good morning. I bid to honorable judges, accurate timekeepers and also members of the floor. So I am Muhammad Izzat along with my partner Ahmad Izzat Arif will present our elective research project entitled Cytotoxicity Effect of Simvastatin PLGA Chitosan Coated Scaffolds on Human Osteoblast HFOB's Proliferation, supervised by Dr. Nur Aliana Hidayah Muhammad. So this is our outline for presentation today. So as for introduction, a bone scaffold is a 3D matrix that allows and stimulates the attachment and proliferation of osteoinducible cells on its surface. And healing of bone defects can be conducted by using scaffold, which help natural tissue to grow and regenerate itself. And tissue engineering has introduced new hopes as a combination of cells, scaffolds, and also biofactors for bone regeneration. Statins are a cholesterol-lowering drug that prevents the conversion of HMG-CoA to mevalonate, which reduces cholesterol synthesis. And apart from being a cholesterol-lowering drug, simvastatin was found also to have a pleiotropic effects. So this includes bone stimulation, promotion of angiogenesis, and lastly, anti-inflammatory effects. To maximize the effect of simvastatin itself, encapsulation of the agent is needed. So encapsulation of agent provides an overall protection to the agent from harsh environment, improve its stability, activity, targeted delivery, and also sustain its release. While for PLGA is a biodegradable polymer that can be formulated into microsphere, which due to their size offer the advantage of allowing the potential injectable delivery to the defect sites. However, the brittleness and the brittleness of the simvastatin PLGA alone limits its uses in bone regeneration. So we have to add a coating material, which is in this case is chitosan. So chitosan is a biomaterial applied in tissue engineering because of its excellent biocompatibility in vivo controllable degradation rate, and tolerable mechanical properties. So the problem with current studies is that we are still lacking information on the cytocompatibility of injectable scaffold with chitosan as the coating materials of the microparticle with human osteoblasts. Therefore, our objective for this research is to compare the proliferation rate of HFOB treated with simvastatin PLGA coated microparticles and simvastatin encapsulated microparticles coated with chitosan using MTT assay. And the second one is to visualize the effect of the treated HFOB with simvastatin PLGA coated microparticles and simvastatin encapsulated microparticles coated with chitosan using immunofluorescence studies. So this is our outline for methodology. We start off with the preparation of simvastatin microparticle using double emulsion solvent evaporation methods, followed by HFOB cell culture, MTT assay and immunofluorescence study, and lastly statistical analysis. Okay. So for this particular first step, due to COVID-19 and time constraint, we are actually unable to conduct the first step. So we receive a prepared simvastatin microparticles from our supervisor and proceed to the next step, which is the osteoblast cell culture. So this is an overview of the simvastatin microparticles. So the image shows the microparticles viewed under scanning electron microscope. So the simvastatin is encapsulated in each microparticle as for T3. For T4, the simvastatin is encapsulated in each particles but is further coated with chitosan. So during HFOB cell culture, the cell were cultured with DMEM supplemented with 10% FBS and 1% antibiotic antimycotic. And then the cells were then further divided into 4 different group of treatment, which are simvastatin PLGA T1, simvastatin T2, PLGA microparticles T3, and lastly simvastatin PLGA with chitosan T4. And then these samples were then assessed with MTT assay at 3 different time courses, which are 24 hours, 48 hours, and 72 hours in 3 different concentration respectively, which are 1 milligram per milliliter, 2 milligram per milliliter, and 3 milligram per milliliter. And then the cell survival towards the treatment T1, T2, T3, and T4 were then further investigated using immunofluorescence study. So for immunofluorescence study, the cell were cultured with FIT-C, which stain the green color, and then it stain the cytoplasm. Another one is DAPI, which give the blue color that stain the nucleus. And then the data were then converted into percentage of cell viability. And then the statistical analysis was done using SPSS version 24. And the statistical difference between different group of treatment is done using two-way ANOVA to see the statistical difference between different group of treatment in 3 different time course and 3 different concentration for each sample.
Moving on to the results and the first bar chart. In 24 hours treatment, T1 showed significant increase in cell number in 1 milligram per milliliter concentration as compared to the treatment of other human osteoblasts with T2, T3, and T4, and concentrations of 2 milligrams and 3 milligrams per milliliter. Treatment of cells with simvastatin T2 seem to have lowest proliferation effects as compared to the other preparation of simvastatin that has been encapsulated in microparticles, which was in T1 and T4. Human fetal osteoblasts were further treated for 48 hours. The decreasing trends in proliferation of human fetal osteoblasts were seen for all treatments in all concentration of treatments. Although cell number was seen decreasing in trend, the proliferation rates of cells were still above 50%, indicating the cells survived. After 72 hours of treatment, T1 showed the highest cell production, followed by T3, T4, and T2 in the treatment with 1 milligram per milliliter. When concentration is increased to 2 milligrams per milliliter, treatment with PLGA microparticles alone without simvastatin T3 showed highest proliferation rate. Comparing T1 and T4, increase in proliferation trends was seen in both treatments as compared to proliferation rates observed in 48 hours treatment. However, the slow release of simvastatin treatment of T4 reduced proliferation rate of human osteoblasts compared to simvastatin treatment that encapsulated with PLGA microparticles T1. Yet, the mean percentage of human fetal osteoblast proliferation in both groups based on time shows significance. Overall, human fetal osteoblast cells that were treated in pure simvastatin T2 were observed with unaltered for both treatment concentration of 1 milligram per milliliter and 2 milligram per milliliter, but a slight increase of 5% in cell proliferation in 3 milligrams per milliliter concentration treatment. Generally, treatment with 3 milligram per milliliter seems to reduce proliferation rates of human osteoblast cells across other treatment groups. The table shows mean comparison between sample and time. Generally, in this study, it showed that T1, T3, and T4 induced proliferation and cell viability in human fetal osteoblast cell line. However, T2 were used as negative control in this research, showed reduction in cell viability percentage of 24, 48, 72 hours respectively. And the results of repeated measures 2-way ANOVA followed by pairwise comparison with confidence interval adjustments shows overall significant difference of mean percentage of human osteoblast proliferation within each treatment group based on time. Within group difference analysis, results showed significant difference for all treated groups from 24 to 72 hours of treatment following pairwise comparison with confidence interval adjustments, which further suggested overall significant difference of mean percentage of human fetal osteoblast cell proliferation within each cell of treatment group. And immunofluorescence results showed that number of cell proliferation were reduced obviously from 24 to 72 hours for all treatment groups. As observed in MTT assay, human fetal osteoblast proliferation extremely reduced in terms of proliferation on 72 hours. Immunofluorescence results were in accordance with results obtained from MTT assay for all treatment groups. Also, cell number decreased obviously from 24 to 72 hours, especially in concentration of 2 milligrams per milliliter and 3 milligrams per milliliter, suggesting that this concentration might not be recommended in the future because it might lead to toxicity of osteoblast production, which was also supported by MTT assay. At present, our research compares the proliferation effects using human fetal osteoblast cell line as osteoblastogenesis model for bone tissue engineering in different microparticles preparation. Particularly, formulated includes simvastatin microparticles T1, PLGA microparticles T3, and finally, formulation of simvastatin microparticles coated with chitosan T4. PLGA is one of the most widely used biodegradable polymers because it has gradual degradation, strengthens stimulation to new bone, promoting bone regeneration and bone structure remodeling, and has sufficient mechanical strength to adequately support defect bone area at an early stage. And in this study, it was clearly that PLGA's microparticles can induce bone regeneration as seen in proliferation studies supported by immunofluorescence studies. Interestingly, our study found that T1 showed higher proliferation rate compared to formulation of T4, and this is supported by Venkatasan et al. Significant new bone growth at circumference of polyethylene glycol block polysimvastatin disc were observed in 4 weeks in rat Cavarel onlay model. Results of this study suggest that simvastatin microparticles coating with chitosan is feasible and effective in bone repair and thus may provide a promising route for treatment of bone defect, which while observing concentration of preparation. Interestingly, in this study, only formation of 1 milligram per milliliter showed increasing trend in proliferation rate for 24, 48, and 72 hours treatment, whereas when treatment concentration increased, proliferation rates decreased. This further suggests that coating with chitosan has potential to induce proliferation of cell. Based on results obtained, concentration of microparticles needs to be observed for purpose of bone tissue regeneration, and higher concentration is not recommended as it further reduces proliferation of osteoblasts. Dear panel of judges, may I continue straight away to the conclusion and future direction of our study? Thank you. So most cells in the 4 different groups were stained with green and blue. However, distribution of counterstains started to proliferate in numbers as time increased. Cells proliferated well during the incubation in 1 milligram per milliliter in T1, T3, and T4 in 24 hours, while during the incubation in 1 milligram per milliliter with T1, T3, and T4 in 24 hours, suggesting that the concentration giving highest impact of formulation in bone cell proliferation, but seen to decrease obviously after 48 and 72 hours, especially in concentration of 2 and 3 milligram per milliliter, suggesting that this concentration might not be recommended in the future as it leads to toxicity of osteoblast proliferation, which is supported via MTT assay results. For conclusion, this study demonstrates cytotoxicity of newly fabricated microparticles which can be used as scaffold for the bone tissue engineering. Our investigations confirm that the coating material could possibly induce osteoblast production and proliferation, and owing a controlled localized release of simvastatin. Scaffold with controlled release mechanism would influence human osteoblast cell proliferation and osteoblastic differentiation in bone tissue regeneration. We hope that this fabricated scaffold will be fabricated into an injectable form, and further studies can be done on the concentration of 1 milligram per milliliter or less to find the accurate therapeutic dosage and have a potential usage clinically in the future. Thank you.
Thank you to Ahmad Izzat and Muhammad Izzat for the amazing presentation. Now we'll proceed with the Q&A session.
Okay, thank you so much. Very interesting work, very good research. I would like to ask maybe a few questions. The first one regarding the chitosan. Which type of chitosan use? Use a powder, isn't it?
Yes, it's a powder form.
The powder form. So can you tell me this powder is high molecular or medium molecular or low molecular? It's very important. The chitosan as a carrier, you should identify whether it is low molecular or high molecular or medium molecular to be as a carrier. So how you convert this chitosan? You convert it into gel or liquid or semi-liquid?
We pack the powder form into a scaffold and then combining with the microparticles, PLJ as a carrier, and then forming a scaffold.
Yeah, the chitosan is mucoadhesive. Yeah, it's
Yes,
mucoadhesive, but the particle, maybe you need to change the particle, I mean the powder, into a liquid form so it can be stick or attached to the particle, isn't it?
Yes.
So now in your group, I noticed that why you don't use the chitosan alone?
Because we wanted to test the chitosan as a coating material on the simvastatin microparticles.
Yeah, the simvastatin, actually I work in chitosan and simvastatin before, yes. But the chitosan got a lot of biological effect on fibroblasts, osteoblasts, healing. This is why it is used in medicine as a carrier for many types of drugs. And it's a very good carrier actually. But also it can induce this type of effect. So how you can differentiate that this MTT effect is due only to simvastatin or due to chitosan? So this is my questions. It could be more, much better if you can have a control group from the chitosan alone, so by which we can tell us that the MTT is not only due to simvastatin and alone, but the combination is there, and there is also MTT. There is a good effect also from the chitosan. Which type of negative control you use?
We use the pure simvastatin, T2, without any microparticles and chitosan.
This is the negative control. Now, I would like to ask you about the simvastatin. Is it a pure simvastatin or the one which is available in the pharmacy?
Can you repeat the question, Prof? Sorry.
The simvastatin, it is available in the pharmacies, and there is 10 milligrams, 20 milligrams, 40 milligrams. So did you use the one available in the pharmacies, or you order pure simvastatin without additives?
We use the simvastatin microparticles which were provided by our supervisor, because we didn't manage to conduct the preparation for the simvastatin.
Yeah, okay. Thank you so much.
Thank you.
Thank you for your presentation. Looks like a research that has great potential to it. So you have 4 groups. So I heard you say that the simvastatin alone is the negative control.
Yes.
And the PLGA particle is the positive control.
Yes.
Am I right? Then what about the other two groups? The other two groups are your test group. The simvastatin coating the PLGA and the one with the chitosan. Okay, so how do you compare these two in clinical application?
Because initially the simvastatin with PLG microparticles has a burst release when applying to effect of bony area. So we are looking for the cytocompatibility of the simvastatin with PLG microparticles when added with chitosan to reduce the burst release during the placement of the simvastatin microparticles with chitosan in the bone effect. So to avoid burst release of simvastatin, which have been seen to reduce proliferation rates in bone proliferation.
Okay, thank you. You have also mentioned the toxicity concentration. Did you evaluate different concentration to come up with this conclusion that at what level the concentration is cytotoxic? Because you only do one concentration, I notice.
We realized that the osteoblast cell viability were reduced when using a concentration of 2 and 3 milligrams per milliliter, and then seen after 48 and 72 hours of treatment.
So you actually have different concentration, because from your test group, there's only one test group with one concentration only.
Oh, we have 3 concentrations, as stated by my friend Mr. Izzat just now. We used 1 milligrams per milliliter, 2 milligrams per milliliter, and 3 milligrams per milliliter.
So you have tested these 3, then you come out with a choice of one of the concentration, then you used it in your actual T1, your test group 1. Is that right?
We use all 4 different treatment groups with all 3 different concentrations to evaluate the cell viability of the osteoblasts when treated with the samples.
So it means T1, T2, T3, T4 all have different concentration of simvastatin.
Yes.
Then how do you compare them then if all these have different concentrations? There are so many variables. First, you have a variable of concentration in this program. Second variable, you have the ones with chitosan and without chitosan. So how do you draw conclusion whether it's the concentration that makes the difference or the chitosan that makes the difference? You cannot have 2 variables in a test group.
We also added a plain or empty osteoblast inside the culture in the 96 well plate, and then we evaluated the number of cells viability of the normal osteoblast, and then we compare it as the control, and we compare it among the other treatment samples.
All right. Okay. Thank you, Dr. Nur.
Okay, one last question from me. All right, you said that you would do further studies on this as a future direction, right? So would it be another lab study, or are you going to move on to a human study? What would you suggest?
We were hoping that the future study would conduct for a lab study first to identify the therapeutic dosage of less than 1 milligram per milliliter, and then after we have obtained the accurate amount of therapeutic dosage, then we could proceed with the clinical trials.
All right, thank you.
Thank you very much.
Thank you to the judges for the questions. with no delay, please welcome our last presenters for today's competition, Nur Nabila binti Roslan and Nur Aina Shahada binti Muhammad Amin, to present their research topic entitled Beverage Sugar Content and Acidity and its Association with Dental Students' Consumption Behavior in Malaysia. Please welcome.
So, Assalamualaikum and a very good morning. I bid to honorable judges and members of the floor. I am Nur Nabila with my partner Nur Aina Shuhada. So our research topic is beverage sugar content and acidity and its association with dental student consumption behavior in Malaysia. Our supervisor is Associate Professor Dr. Nik Muhammad Mazwan Nik Muhammad Rosdi. And our research topic is also known as sugar and acid, a double whammy in beverages. So this is us, and this is our content for today. So we're going to start with introduction. So our study focuses on the properties of beverages which can cause two effects on the dentition, which are dental erosion and also dental caries. So chemical demineralization of teeth is caused by acidic attack through two primary means, which are dietary acid consumed through food or drink, and also microbial attack from bacteria present in the mouth. So beverages have two main properties which directly affecting teeth, acidity and sugar content. So these properties have a great impact for oral health due to their causes, either of two distinctly different types of lesion, which are caries lesion and also erosion. For the factors that can contribute to the acidity and relative erosivity are total acid level, pH level, type of acid, calcium, phosphate, fluoride concentration, viscosity, exposure time, and temperature. So the mean daily sugar-sweetened beverage consumption globally is higher in upper middle-income countries and lower middle-income countries than in high-income and low-income countries. So there are many types of sugar used in the F&B industry, mainly sucrose, which known as table sugar, is the most popular sweetener, and energy drinks had the highest mean sugar level compared to other sugar-sweetened drinks. And for our problem statements, for the first one is there are plenty of new beverages evolved based on current trends of social behavior. Second is public do not know the actual acidity and sugar content of these beverages. And the last one is we do not know the potential of these beverages to cause harm to the dentition. For our first research question is how many types of beverages available, and our objective is to catalog beverage in Malaysia. The second is what are the acidity and relative erosivity status of common and popular beverages in Malaysia, and our aim is to determine the pH level of beverages and associated relative erosivity. The third one is what is the sugar content of common and popular beverages in Malaysia, and our objective is to determine the sugar content of beverages. And the last one is what is the beverages consumption behavior of dental student, and our aim is to identify the beverage consumption behavior of dental student.
I will continue with methodology. So for our methodology, we divide it into two phases. For phase 1, we determine the pH value and sugar content of the selected drinks. And for phase 2, we determine the consumption behavior of dental students towards beverages intake. So this is our flow of methodology. We purchase all beverages purchased in Sungai Buloh area, and juices were prepared fresh from the resources. And we classify all the beverage into 15 types. We also determine the beverage acidity using pH meter, and then we identify the sugar content from packaging or manufacturer's website. And for the survey, after the ethics approval, we distribute beverage consumption behavior survey, and we did the result analysis. So this is the phase 1 and our work done in lab. So this is the flow for phase 1. We purchase, prepare, measure, record, catalog, and did analysis using SPSS. Then for phase 2, this is the flow of phase 2. The sample size calculation is based on the table below. So for phase 2, we distribute a questionnaire for our dental students to answer. We prepare question, frequency of beverage intake and volume of beverage intake. We adapted from Hedrick et al. 2012. So for the results, these are all the 15 types of beverage that we classified. So from our 167 beverages, these are some of the sample. We ranging from lowest pH to the highest pH. We relate them with the relative erosivity adopted from Larsen, 1999. So Schwab bitter lemon has the most acidic acidic pH, while FNN, Ice Mountain, has the most basic. So this is the sugar content from our samples, from the lowest to the highest sugar content per 100 milliliter. So for sugar content, based on WHO guidelines, it is suggested 12 teaspoons equals to 50 grams of sugar per day for an adult. 1 teaspoon of sugar is equal to 4 grams. One of our lowest sugar content, which is Calpis Zero, contain 1.5 gram, is equal to 0.4 teaspoons. And our highest sugar content is both Tetare instant drinks contain 71.8 gram, equal to 18 teaspoons, which has exceeding 1.5 recommended daily intake by WHO guidelines. So this is consumption behavior demographic. From our 363 respondents, 81.5% are females and 18.5% are males. Our highest respondents is from year 2, and from our respondents, 8% of them consume at least 2 cups of milk each day, and 4% consume 2 cups of instant drinks every day. So we are comparing the most consumed beverage by all the students, which is instant drink and milk. We are comparing them. So we found that year 1 and year 5 consume the most instant drinks, while year 2 consume milk the most.
So next, I'm going to continue with the discussion. So a study in the US by Reddy et al. In 2016 found that 100% of their tested beverages were potentially erosive, while in Australia, a study by Schmidt and Huang in 2020 found that 93.8% of the beverages were potentially erosive. So both of the studies were mainly looking at the can and bottle beverages. Meanwhile, our study only found 52% of tested beverages were potentially erosive. And our findings showed that dental students are consuming less sugar-dense beverages and opt for milk instead. So the number of however, the number of instant drink consumption is considerably high among them, and this is a common trend among students. Hamid et al. In 2018 also found that powder instant drink contain 20.63 gram to 60.30 gram per 100 gram of sugar, and ours are up to 71.8 gram over 100 gram of sugar. So this show that dental students are also at risk of dental caries due to high consumption of sugar-dense instant drinks. So our study found that milk was the most consumed beverages compared to other sugar-sweetened beverages, unlike other studies finding. Like a study by Attila and Chake in 2011 found that frequency of energy drink consumption was higher in students of arts and sports and in those who did not have breakfast on a regular basis, ever smoke cigarettes, drink alcoholic beverages, and regularly engage in sports compared with medical students.
Our study limitations are we could not find all the sugar content that is not packed. Second, our work done in laboratory is time consuming, and then also we targeted dental students. Given we targeted the public, it will represent the community more. So to conclude, high percentage of beverage in Malaysia has the potential to cause dental erosion. Most of dental students did not consume erosive beverage. However, they consume mostly instant drinks which contain high sugar. So campuses should consider to promote more healthier beverages among students. A strategy should be planned to curb the emerging lifestyle of drinking sugary and acidic beverages. These are our references, and that is all from the three of us. Thank you very much.
Thank you to Nur Nabila and Nur Aina for the amazing presentation. Now we'll proceed with the Q&A session.
Okay, wonderful slides. I congratulate you on that. And tengah puasa kan? Asyik minuman ni keluar, boba lah, juice lah and everything. Alright, okay, so my question, why did you choose dental students as your subjects? And then why do you say that dental students could represent the public for these results? Because it could be a bit of bias, don't you think?
Okay, so thank you for the question. We targeted the dental student because we wanted to know the most consumed beverages among our dental students are giving risk of erosivity to them. And correction, we did not say dental students represent more. Given that we targeted the public, it should represent the community more. So it is our study limitation.
Okay, so if you were to duplicate this study and to make the results able to generalize the targeted population, say, in terms of public health interventions, right? That's what you said. So how would you do that differently? Or who would you choose as your target subjects?
Okay, I would say that we would choose the young adults and also the children because intervention need to start at an early age. So it's better that we did the survey for the youngsters to find what the beverages that they consume the mostly and to start educate them about the risk that they can get if the result happen to show that they consume potentially erosive beverages.
Okay, thank you very much.
Thank you for the nice presentation. I thoroughly enjoy your slides. Very nice visual attractiveness. So you have chosen dental students, but you only include the dental students in your UiTM. But your title says that it's dental students in Malaysia. Why are you not including the dental students from other dental schools? Are you generalizing that your UiTM students representing all the dental students?
So first, when we started this study, it was during COVID-19, so it was quite hard. It's a limitation to reach other universities, so we're going to start off this study first with dental student in UiTM below, and if we see a positive result, then we can consider to expand more to get a better data for all the dental students across Malaysia.
So what type of sampling method is this called?
We are using descriptive analysis for this.
No, your sampling method.
We use convenience sampling for this.
Right, okay. Thank you very much. And also, you have mentioned that the students here generally consume instant drinks. Do you evaluate the whole environment here? Is it because there's a lot of vending machines around that enable the students to do so? How many vending machines are there in the whole building or in the hostel?
Okay, thank you for the question. Yes, we did survey the vending machine, and in the faculty alone, we had 2 vending machines, and we have 3 colleges. So the 3 of them, each of them have a vending machine. So, the availability is there. So that could be one of the factors that the students are consuming these instant drink beverages.
Right. So in future, you may want to include this variability in your questionnaire, because the environment itself may promote certain behavior.
Thank you.
Okay, thank you so much. I enjoy your presentation, I do. A few questions from me. Now, first of all, regarding the title, I think you need to modify the title. It's not in Malaysia. The second one, the conclusion, your conclusion. high percentage of beverage in Malaysia. It is not in Malaysia, it's in dental student. Potential to cause dental caries. You cannot generalize this because your group is only from dental student. My last question is, which type of milk you select? Milk.
For milk,
Yes.
we does not specify types of milk.
Why? There is difference between the normal milk, natural milk, or soya milk, and low fat, high fat, skim milk. Do you specify this?
From our questionnaire, we did not specify. We just stated milk, and so the answer is generalized. So I think the students answer the most consumed beverage is milk is because they did not know what type of milk. So maybe the type of milk include in the milk tea, or is it something that they eat with cereal milk? That's why it's the most consumed beverage.
Okay, thank you so much.
Thank you.
Thank you to the judges for the questions. Ladies and gentlemen, let's give a big round of applause to all the presenters to express our recognition of their well-prepared presentation. With that last presentation, all presenters have successfully presented their research. We have now come to the end of today's competition. On behalf of the organizing committee, we would like to express our thanks to all of you here for gracing your presence to our competition today. We truly appreciate it. With that, I end my duty as the master of the ceremony for today's competition with wabillahi taufiq wa hidayah. Wassalamu alaikum warahmatullahi wabarakatuh. Thank you very much, ladies and gentlemen. We will now have a short break and adjourn back to the hall for the opening ceremony at 10:50 a.m. You may now adjourn.
wear masks on throughout the event as to comply with the standard operating procedure. We would appreciate if all mobile phones are switched off or put in silent mode throughout the event. We would also appreciate if all guests would stand when we announce the arrival of the guests of honor and the faculty entourage. Your cooperation is highly appreciated. Thank you. Gentlemen, we are about to begin. Please kindly take your seat. Thank you.
announcing the arrival of Yang Berbahagia Professor Emeritus Tan Sri Datuk Sri Dr. Ibrahim Shah bin Abu Shah, Chairman of the Board of Directors, University Technology Mara, accompanied by Yang Berbahagia Associate Professor Surveyor Dr. Rosmadi Ghazali, Deputy Rector of Industry, Community and Alumni Network for the Selangor campus of University Technology Mara, Yang Berbahagia Datuk Professor Emeritus Captain Dr. Hashim bin Yaakob, our keynote speaker, Yang Berbahagia Professor Datuk Dr. Muhammad Ibrahim Abu Hassan, Founding Dean of the Faculty of Dentistry, University Technology Mara, and Yang Berusaha Associate Professor Dr. Hadlina Abdul Ghani, Chairperson of the 12th Dental Student Scientific Symposium 2022. Distinguished guests, ladies and gentlemen, please remain standing for the singing of the National Anthem Negaraku and Wawasan Setia Warga UiTM.
Distinguished guests, ladies and gentlemen, please be seated.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh, and a very good morning we bid to Yang Berbahagia Professor Emeritus Tan Sri Datuk Seri Dr. Ibrahim Shah bin Abu Shah, Chairman of the Board of Director, University Technology Mara. Yang Berbahagia Professor Datuk Dr. Muhammad Ibrahim Abu Hassan, Founding Dean of Faculty of Dentistry, University Technology Mara. Yang Berbahagia Associate Surveyor Professor Dr. Rosmadi Ghazali, Deputy Rector of Industry and Alumni Network Community. Yang berbahagia Dr. Professor Emeritus Captain Dr. Hashim Yaakob, our plenary speaker for this morning. Yang berusaha Associate Professor Dr. Hazlina Abdul Ghani as the organizing chairwoman, Deputy Deans, Heads of Departments, fellow academicians and staff, esteemed guests, beloved students, ladies and gentlemen.
On behalf of the organizing committee, we would like to welcome everyone to the 12th Dental Students Scientific Symposium 2022. I am Aminda Faizura.
And I am Muhammad Ishrafuddin Ismail.
And we will be the MCs for this morning's session. It is with great pleasure and an honor to have all of you gathered here today with us for the officiation ceremony of the 12th Dental Students Scientific Symposium 2022, organized by the Faculty of Dentistry, University Technology Mara.
Before we begin, let us usher this auspicious ceremony by calling upon Mr. Ahmad Abi Arfan, Chairman of the Dental Student Committee of the 12th Dental Student Scientific Symposium 2022 to recite a prayer. Please welcome Mr. Ahmad Abi Arfan bin Ahmad Rafizan.
Assalamu alaikum warahmatullahi wabarakatuh. Al-Fatiha. Bismillahirrahmanirrahim. Alhamdulillahilladzi bi ni'matihi tatimmu s-salihat. Wassalatu wassalamu ala rasulillah wa ala rasulina nabi wa ala alihi wa sahbihi ajma'in. Ya Allah, ya fa'alil lima yurid, we express our gratitude to you for allowing us to attend the opening ceremony of the 12th Dental Students Scientific Symposium 2022 on this auspicious morning. Ya Allah, we ask you for the safety of our religion and the welfare of our world. O Allah, Lord of the implementing authority, make the days that we have gone through starting with your mercy, continue with your blessing, and ended with thy forgiveness. And also make the days that we've gone through with guidance and with the victory of excellence. That our efforts as a means to enlighten and convince ourselves that the personal safety of people, outer and inner, is a prerequisite for achieving happiness and excellence in various fields. O Allah, grant us faith and strength in order to face the challenges of life during the transition period and in the face of life and this new millennium. Ya Allah, show us guidance and adjust our path and ways to achieve happiness and glory. Let us listen to people who like the good things. Let us avoid doing the bad and evil things. O Allah, bless our life in this meeting and gathering and prevent us from harm and unfortunate events. ربنا آتنا في الدنيا حسنة وفي الآخرة حسنة وقنا عذاب النار والحمد لله رب العالمين.
Amin, amin, ya Rabbal Alamin. Thank you, Mr. Ahmad Abid Arfan, for the dua.
Distinguished guests, ladies and gentlemen. The Dental Students Scientific Symposium, organized by the Faculty of Dentistry, University Technology Mara, was first held in 2011. This symposium is not only to showcase research outcomes from the Bachelor of Dental Surgery students, but also serves as a platform for other students to show their depth of knowledge and skill via debate competitions, table clinics, poster and photography competitions. This symposium involves students across the areas, including those in the postgraduate level. Today, the Faculty of Dentistry, University Technology Mara is proud to bring to you the 12th Dental Student Scientific Symposium 2022 with the theme, Inculcating Research, Embracing Knowledge. This symposium aims to expose and encourage dental students, especially Year 4 students, to participate in research and to build leadership qualities in students and encourage dynamic group practices.
This symposium also aims to enhance students' professional ethics and interaction between students and lecturers. As for the objective of this symposium, we hope to encourage the university members to partake in research and also for the academic excellence, as well as to publish or submit the abstract in an ISBN proceeding book.
Without further ado, we would like to invite Yang Berbahagia, Professor Dr. Muhammad Ibrahim Abu Hassan, our founding dean, to deliver his welcoming remark. Please welcome Professor Dato.
Yang Berbahagia Associate Professor Surveyor Dr. Rosmadi Ghazali, Deputy Director Industry Community Alumni Network for UiTM Campus, representing the Rector of UiTM Selangor. Yang Berbahagia, Yang Berusaha Associate Professor Dr. Hazlina Abdulghani, Chairman of the Organizing Committee for this scientific committee, Deputy Deans, Head Departments, lecturers, students, staff, and also the Organizing Committee of this 12th Dental Student Conference, and also our invited judges from our local university, as Cancer here, and also a few others from UiTM, from IMU. Nice to see all friends back in the faculty. Assalamualaikum and a very good morning. All praise to Allah Almighty, who has peace be upon His Prophet Nabi Muhammad sallallahu alaihi wasallam. I would like to welcome our chairman, our board directors, University Technology Mara, Yang Bahagia Professor Emeritus Tan Sri Datuk Sri Professor Ibrahim Abu Shah, who has some instrumental feeling towards this campus. Maybe Tan Sri will explain in her speech later on, because of Tan Sri, we have this building in campus. Also, to our guest, Associate Professor Dr. Rosmadi, representing, who has spent some time with here this morning, and also Captain Professor Dr. Emeritus Dr. Hashim Yaakob, and to be able to be here to our 12th Dental Symposium. As our MC has mentioned this morning, the objective of this conference, this is the 12th Dental Student Symposium that we have. Beginning since 2011, when we start off our first Dental Student Symposium, with the objective of initially to let our final year students present their research projects. That's what was we start off in 2011, the first conference in Shah Alam, where we were there temporarily for 9 years, although supposed to be 3 years, but in Malaysia, anything temporary can be also semi-permanent. We were there for 9 years, waiting till this building is ready in 2015, where we moved in September 2015. Alhamdulillah. So, as I mentioned just now, the objective was to let the final year students to present the research proposal, research output from their projects. Later on, over the years, as our MC has explained, we expand from just research of the final year to 4th year, to 3rd year, then later 2nd year, and 1st year. We get every year of the student to be involved in this symposium. Maybe, for example, we have table clinics for the 4th year during that time, and then poster or brochures for the 2nd and the 1st year. And then later on, we ask 1 year of the students to be the organizing committee so that they know how to organize a conference. So we teach them everything that they need to do as a student, not just studying dentistry, but also life about education. So then we expand, as I said, then later on we have postgrad. We also involve our postgrad to be involved in this symposium. See, initially we start with 1 day program, but as we expand, we have now 3 days. Because today and tomorrow is the 2 days, but we have another day last week where we have our pre-symposium to do some initial competition, but the results will be announced tomorrow, inshallah. So that's how we expand, and now later on, lately we have also invite international participants from our colleagues. We have MOU from Indonesia, from Cambodia, from India, who has participated in this meeting. And also this year, we have organized a bit more, whereby we have debate with international university. Not just among ourselves, of course we have a debate on our students, but we also have an international debate with our friends from Cook University on the 6th of April last week. So, and virtually, we did it virtually. So this is how pandemic has made us look differently at organizing conference. Okay. Now I'll go to the speech written after. That was from my heart. My heartiest congratulations to Chairperson of the event, Associate Professor Dr. Hazrina, and the organizing committee for having worked tirelessly to organize this event, despite the uncertainties imposed by the COVID-19 pandemic. However, we are in a transition to the endemic phase, and all learning activities to figure out as planned, and safety is in place. For the last 2 years, we organized this event virtually because of the pandemic. And this year, I said to Hazrina and her team, I have enough of virtual. I have enough of virtual, at least hybrid. At least hybrid. Okay, so I know that this room can accommodate at least 400 participants. So at least those who are participating, the students who are participating in the conference are here in the room, and the lecturers are here in the room, and also the judges. And there are many more who are online, the year 1, year 2, year 3 are online to see what's going on. Okay, what's going on? Because this is our annual big event by the faculty. So, and when we have, it's more, I mean, to me, it's more a bit lively. So I managed to convince Hazrina and team, yes, we have to have it virtually. Although many times she has come to me, are you sure you want to do it hybrid with operation? Yes, I said, if I do virtually, Tan Sri would not come. Tan Sri, yeah? Because the impact of doing things virtually, I mean, in physically is different from you doing a conference online. Sometimes you just switch on the camera. In fact, not just switch on the camera, you don't know what the other two are doing. But when you are here, you can see. But of course, we take all the necessary precaution on that also to make sure that we will not become another cluster. Inshallah, hopefully. We have come a long way since the first symposium. We saw in 2011. In the early years, the student presumed was focused on the fifth-year student, elective research work as part of the fulfillment of community health courses. However, over the years, we have included more activities, as mentioned just now, involvement of undergrad and postgrad to showcase their work and talent in the areas of research, health promotion, innovation, and various activities such as oral posters and table clinics, video and photography competition. We are also among the first dental school to introduce debate, as mentioned just now, as a key activity in the student symposium, and this aimed at the training students to form their opinions in the thought of provoking topics related to dentistry, as well as to build the confidence in public speaking. And we are proud that our debate team has become the 4th Malaysian Dental Intervarsity Champions in 2022. And of course, as I mentioned just now, we have the debate with Cook University last week, and we also emerged the winner at the international debate. With the judges are neutral, not from our school, but judges from Minister of Health and from the public sector and from the army, who has become the judge for that competition. And also one from Indonesia, the judge, one from Indonesia. Again, how virtual event can take place with judges from everywhere part of the world. We are proud to see that the research and health promotion of our students, with the guidance and encouragement of their dedicated lecturers, have won numerous awards, such as recently they won the first and second in the free paper comment presentation at the Cook Institute of Dental Symposium. And we hope that this trend will carry on and the work presented in this symposium to contribute to the wealth of data as part of evidence-based dentistry through publication in reputable journals and representation at both national and international meetings. It is hoped that the symposium will create opportunities for networking and for goodwill among the delegates for this. And we are honored to have our two good friends, Captain Dato Emeritus Professor Dato Hashim Yaakob, who I know him very well. Whilst I was at UM, I was his deputy for quite a number of years. I've learned a lot from him. And also my friend from UWA, Professor Mark Tennant, who will deliver his plenary. Mark Tennant and Prof. Hian Ngo, in fact, two speakers who will deliver the keynote or plenary tomorrow at 11 o'clock. Also, I'd like to extend our appreciation to all the international presenters from India and Indonesia, in the Faculty of Dentistry, Universitas Indonesia, Cook Dental Institute, Manipal College of Dentistry. This is Manipal, it's not Manipal here, Manipal in Manipal. And Savita Dental College for enriching, livening the symposium with their participation. Not forgetting Colgate and GSK, who generously sponsor and enable the event to be a memorable one for our students. Our Year 4 students faced a multitude of challenges as they started their elective projects at the height of the pandemic, whereby labs and classes were closed and all learning activities have to be conducted online. Despite these challenges, they have managed to complete their research project on time, alhamdulillah. And we hope that the experience gained here will be an impetus for lifelong interest and passion in scientific research as part of the career journey. Okay, I'm coming to the last portion of my speech. Before I end this speech, I thought I would like to share with you, this is not again in the text, about our two honored guests today. First one, Professor Emeritus Tan Sri Ibrahim Abu Shah. In 2006, he wrote to UM requesting secondment for me to go to UiTM as a dean to form the school, to form the dental school. And at that time, Emeritus Professor Dr. Hashim was the VC of And he said to me, Mat, he always called me Mat, but he doesn't call me Mat Ibrahim. I think instead of going as secondment to UiTM, you better go straight to UiTM, because as part of building the faculty, you won't be able to do research, publication, or research grant. It's a big job starting a faculty, and if you come back to UM, you will lose your seniority because you have no time to publish. So Dr. Ashir, let me go to UiTM permanently rather than secondment. And of course, Tan Sri Ibrahim Abu Shah said, they're even better. We have full-blown professor without even training him to become a professor. So this is how the two individuals play a role in my term as developing this school. Alhamdulillah, we have come to the 16 years of my term as dean, and then this will be my last speech as the dean, inshallah. Lastly, I would like to thank everyone for your participation in this event, and we hope that the activities of the conference will be mentally stimulating and enjoyable to all of you. Sekian wabillahi taufiq wal hidayah. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you, Yang Berbahagia Profesor Datuk, for the welcoming remark. Distinguished guests, ladies and gentlemen, sehabis merah daun yang sehat, dahan melebar mencium pasakan. Majlis perasmian mohon berehat, persembahan pelajar kita saksikan. To adorn this auspicious event, our students have prepared something for us all. We present to you a mesmerizing performance of Chat Lempong by the final year dental student of the Faculty of Dentistry UiTM. Please welcome our final year students. Thank you, final year students. Dari Kedah ke Kuala Perlis, singgah bersantai di tepi jeti. Persembahan pembukaan memeriahkan majlis. Semua hadirin terhibur di hati. Esteemed guests, ladies and gentlemen, now, we have come to the highlight of the event. On behalf of the organizing committee, we would like to invite Yang Berbahagia Professor Emeritus Tan Sri Datuk Seri Dr. Ibrahim Shah bin Abu Shah, Chairman of the Board of Directors, University of Technology Mara, on the stage to deliver his opening address and to officiate the 12th Dental Student Scientific Symposium.
Old friend, Professor Emeritus Datuk Hashim Yaakob, Yang Berbahagia Associate Professor Dr. Badrul Isa, Deputy Director, UiTM Selangor, Deputy Deans, my good friend Associate Professor Dr. Hazrina Abdul Ghani, the organizing chairwoman, lecturers, staff, students, ladies and gentlemen. Assalamualaikum warahmatullahi wabarakatuh, and very good morning to all of you. For sure, I have to take this opportunity to thank the faculty for inviting me to officiate the program this morning. As you know, as mentioned by your dean, this faculty is very close to my heart. I will take a short time to explain why I said that. Because if I have to tell the whole story, the story will never end. It's a long story. We have to struggle to get this faculty. And for sure also I have to congratulate. I'm very proud, very pleased to see this sort of program organized for the students and by the students, so that they are being motivated, encouraged and guided to do research. And as you know, UiTM aspired at one time to be a research university. In fact, in 2007, we were recognized as the university with the most number of research within comprehensive university. Meaning that if you put aside all the 4 RU, we were the number 1 in terms of research. And in fact, 2009, when I was the Vice Chancellor, when the Minister came to UiTM for me to present our case to be considered as Research U, UiTM was already given the green light to be a Research U by January 2010. But the idea, I don't know, for some reasons, it was not materialized, and we reach that level as a RU. So my aspiration, it doesn't matter whether we are RU or not. I'm very happy that we are active in terms of research today. In the year 2001 to 2004, increased research by 400%. From 2004 to 2007, we increased our research by 1,000%. That fact and figures I'll put in my book. Will be soon launched by June, insyaAllah. Tuan-tuan dan puan-puan, why I say it's very close to my heart. In fact, I have to do my promotion. You have to buy and read my book. It will be out by June. The title of the book, Tersinggung di Hujung Perjuangan. Ataupun tersinggung dalam perjuangan. And most of the content, I can say 70%, I'm talking about UiTM and ITM. Because I explain how I fight for your ITM when I was a student leader in 1970s. Yeah, how I fought for the recognition of diploma. And we got our first recognition of diploma during my time as a student leader. That's when I was a student leader. And then when I was appointed as Timbalan Dekan of Student Affairs, when I came back from the United States with my master's, at the age of 26, I was appointed as Timbalan Dekan in charge of Student Affairs to look after students and to make sure there's no more demonstration in ITM or UiTM. For your information, 1973 to 76, it was a very bad time for UiTM. Students were doing nothing else except demonstration. To the extent the Prime Minister then, the Minister of Education then, Tun Mahathir, has to amend the Act of ITM. ITM at one time was put under Ministry of Rural Affairs, was changed to be directly under the Ministry of Education because of that demonstration. And Act 1976, we call Act 173, where from there on, the instruction given to me as a new dean, deputy dean of students, is to make sure no more demonstration in the ITM, so that the student focused on what you are supposed to do. Meaning that will never stop students from doing anything good for you all and for your ITM. This is what I want to see. Yeah, I don't want to see students wasting your time demonstration and doing negative things in your life. You have only a few years here. So focus in your study, get the best result, get 4-point flat if possible, get involved in student activities, become a student leader, organize programs for the societies, organize academic programs such as this Symposium, especially focusing on academic work and research. This is what I want to see students of UiTM. I'm saying this not only as the former Vice Chancellor, the longest Vice Chancellor of ITM, but also as a student leader of ITM. In fact, I'm glad to see my old friend. He was together with me as a student. We have been friends for a long time. Yeah, Dato' Hashim was our product, for your information. He's the product of ITM. He himself is a product of ITM. Yeah, from ITM, he studied very hard, and he got his degree in dentistry. Meaning that during our time, we call ourselves Marakong. Not Vietcong, what we call Marakong, meaning that we are the type of person who are rugged. Rugged meaning that not rugged, action, tidak. Rugged meaning we are very hardworking, determined, and will do anything to succeed in life. So, you want to know more about Marakong, please read my book. Tuan-tuan dan puan-puan, talking about this campus, in the book there's a title, Perjuangan melalui struggle through blood, sweat and tears. Oh, susah tu blood, sweat and tears. Okay, I'm trying to talk about this particular building or particular piece of land. This land, when I got it from the government, the Commissioner of Land of Selangor and from the Kementerian, was meant for us here to build faculty of perubatan and faculty of dentistry. This particular, about 40 acres only, and not a very prime area. It is, I can consider, peripheral. So we got the land in writing, in black and white. So we offer open tender, yeah, contract, and we want to start the earthwork, clearing this whole piece of land, yeah, to build these 2 buildings of medical faculty and dentistry faculty. But suddenly I got a letter from the health ministry asking me to surrender this land. Yeah, they withdraw the ownership, meaning that UiTM cannot have this piece of land because they plan to build a commercial center on this piece of land. So I feel very bad because we already got the green light from the government. Everything is done accordingly. And we have offered a contractor, yeah, to do the work. But suddenly we got that piece of letter from the Ministry of Health. So we fought our case. I have to tell this story so that I want you to work hard. It's not easy for me to get the approval to have this medical faculty, dental faculty, pharmacy, and faculty of health science. Alhamdulillah, before I left, I got all these faculties approved by the government with really hard work through blood, sweat, and tears, really. Meaning that this piece of land, I have to fight, I have to bring this matter up to the cabinet, and I won the case. So, since I won the case, we start earthwork, yeah, clearing these 40 acres of land. And suddenly, I got the instruction from the other ministry, Ministry of Heritage. They say that this land is null and void. This land is going to be gazetted as warisan ataupun heritage. So, tuan-tuan, I feel very funny. Something is very funny. It's not an easy thing for me to be as a VC for 9 years. So, but my argument, the land was already given to us. Yeah, officially, I got the letter in black and white. So I start asking my workers, the contractors are ready to do the work. So I was there. I gave the instruction to start the work. We started at 9 a.m. on this piece of land. One day, we wanted to start the work, but this group of people, they consist of the workers from the nursery and some coastal patient. They barricade our, what we call it, excavator, not really tractor excavator. They barricade, they have a long line barricading our workers to start working. And we were there from 9 a.m. until about 1 p.m. We were in the heat. We were sweating like crazy, but we cannot move because these people are barricading. So what I did, I gave the instruction, start the engine and move. And langgar dia orang. And because of that, I was called by the Prime Minister. He said, Ibrahim, you know that it's something, I'm not talking about something die, no. It's something happened to this, especially to the coastal patient. I will never protect you, you'll be in jail for that. But I told him, it's my right, it's my piece of land. It was already approved. And they have, I think, around this area, even until today, I think I can see almost 1,000 acres more are not utilized. But they are farming grass lah, nursery lah, pokok bunga lah. But you take my 40 small piece of land, and I told them, my students, they have started the program. They need the faculty. At that time, Datuk Ibrahim was using faculty of computer science. Yeah, Datuk, even the dean of faculty was very upset with me. I don't have enough space. Why you give this to Datuk Ibrahim? So I need a new building. And it was approved. But yet the Ministry of Health, Ministry of Warisan, yeah, they wanted to gazette this piece of land. And even they gave me an injunction to stop the work. That's bad. Injunction means I cannot do anything. But to to shorten the story, what I did, the minister called me, Ibrahim, tomorrow is a cabinet meeting, you have to do something. You are going to lose, the land is going to be withdrawn, and you don't have your faculty, perubatan or dentistry anymore. The only way if you can call the Agong, the king himself. It was about 9 p.m. That time I was giving a talk in Cameron Highland to all the senior staff. I tried to get the Agong, Alhamdulillah I got him, and using the kuasa Raja-Raja Melayu, we got this piece of land, Alhamdulillah. So Tuan-Tuan, I have to tell you the story so that you understand. UiTM is a unique university. We are trying to help ourselves. In the country, we are the least, the most backward community, though we are the pribumi in this country. Yeah, and we don't blame other people, we blame ourselves. We blame ourselves for that. So what UiTM is doing is to make sure we will be at par with other people. So meaning that you have to prove our worth. Government has been spending billions. I remember when I fought for the case for this faculty and for the Puncak Alam campus and also for the hospital Puncak Alam. I have to fight with the 3 prime ministers just to get your Puncak Alam hospital and Puncak Alam faculty approved. It's not easy. It took me years. Yeah, budget for the hospital Puncak Alam, I got it just about few months before I left. And budget for this faculty, I got it tahun 2008, something like that, 2006, around that. Meaning it's not easy. We got so much budget approved by the government to help the least developed community, i.e. the Malays and the Bumiputra. So you must work hard. Don't blame other people. Blame yourself if you fail, if you cannot succeed. I want you all to be the best student. I want the faculty to be the best faculty in the country. I remember when we launched WCU, aspiration to be world-class university in 2006. It was launched by the Agong, by the king. Aspire to be world-class by the year 2020. My idea was, by the year 2020, we even, in terms of ranking, at one time, I was thinking about the top 50 in the world. That's my idea. At least the top 100. And at that time, even Dato' Ashim, I was thinking to beat UM anytime. Easily we can beat UM if we got the RU status. I can say it loudly because I can prove that given a few years, we reached the peak. We beat everybody to the extent we got the title Anugerah Quality Prime Minister in 2008. Out of hundreds of badan berkanun and government department, not within IPTA only, no, hundreds and hundreds badan berkanun and universities and government department. We were the only, the sole institution to be recognized, to be honored, the title of Anugerah Quality Perdana Menteri. Meaning that we are good. What I'm saying, if we reach that level as a research U, 210, if we're still around as a VC 210, we are already research U. If we are already research U, we will be at par with the other 5 research U, for sure. And we can be top 50 by the year 2020 in the world ranking. And I was very sure of that, because I've already calculated. We can do that. But still, I never give hope. I've talked to your new VC. We'll do it again. And we have the new hospital. And I've talked to all the deans, especially all the 4 deans. Yeah, I told you earlier that we got the 4 faculties, very important faculties, science-based, yeah, pergigian, dentistry, medical, health, science, and also pharmacy. These 4 faculties must work together under one objective and one aspiration. Hospital Puncak Alam should be the center. I've told everybody, nobody, no faculty should feel superior than the rest. Everybody must be the same. Work for the universities. There's no individual interest, but for the sake of the universities. That's my aspiration. That's, I hope the student in particular understand my aspiration and my dream to make this university to be the best in the country, not only at the national level, but also at the international level. We can do that. I can guarantee you, with my experience as VC, I've proven it. We can do that. Inshallah, with hard work, full dedication, with the assistance and guidance from the decan and the rest. Inshallah, we can achieve our objective and mission. Tuan-tuan dan puan-puan, research is a creative and systematic work undertaken to increase the stock of knowledge that not just takes the researcher into a world of discoveries, but at the same time helps the researcher to forge new ties, and find solutions that at a micro level enriches his or her life, and at a macro level ameliorates the human condition. Therefore, the theme inculcating research, embracing knowledge aptly goes with the training of the young and wonderful minds of our beloved students in this exercise, in addition to the fulfilling of the objectives of UiTM 2025, strategic planning of championing impactful research through a strategic ecosystem. The world has been through a couple of tumultuous years due to the COVID-19 pandemic, but through these dark times, we witness the emergence of great research, innovation, and human spirit. There is the application of the mRNA COVID-19 vaccine that has successfully controlled the spread and severity of disease. Novel antiviral drugs are now available to help those of highest risk of contracting COVID-19. And we also saw the application of guidelines in infection control practices and policies aimed at preventing transmission and reducing the human and economic impact of the COVID-19 pandemic. On the level of humanity, we saw the selfless sacrifice made by the frontliners and generosity of the rakyat as we lend a helping hand to contribute to those in need. At the university level, we saw the sacrifices of lecturers in developing a content such as MOOC, online assessment and treatment of patients with personal protective equipment to adapt to the new norm. We are seeing light as we approach the end of this dark tunnel, and it is our hope that with this resilience built from this experience, we can continue to scale a greater heights. I'm sure the dental students too have been similarly challenged by having difficulty to conduct their research projects during this period. But Alhamdulillah, I'm happy to know that all the students have managed to complete their projects on time. Since its inception, UiTM has enjoyed collaboration with established international bodies and schools. In the spirit of collegiality, it is hoped that this participation of international delegates and members of the faculty of the industry to this 12th Dental Student Symposium will help to establish new ties for a productive collaboration in the advancement of research that will further enrich the science of dentistry, build its evidence-based practices, create solutions, improve the provision of healthcare, and contribute to the economic growth of the nation. Ladies and gentlemen, before I conclude, I would like to wish the dental students all the best in their research presentations. In the words of Albert Einstein, strive not to be a success, but rather to be of value. I hope you will take this training and research experience and incorporate it into your career journey as students, as dentists in the near future. To all international participants, i.e. Faculty of Dentistry, Universitas Indonesia, Cook Dental Institute, Manipal College of Dentistry, Savita Dental College, and members of trade, I welcome and thank you for committing your time and energy towards this conference. To all participants, I wish you a pleasant day ahead. Bismillahirrahmanirrahim. I now declare the Faculty Dentistry's 12th Dental Student Symposium 2022 officially open. Wabillahi taufiq wa hidayah. Wassalamualaikum warahmatullahi wabarakatuh. Thank you.
Thank you, Professor Emeritus Tansi, for fixing for the opening matter. With your permission, Tansi, we would like you to remain on stage for the official launching of the symposium. And now we shall call upon Yang Berbahagia, Professor Dr. Muhammad Ibrahim Abu Hassan, Yang Berbahagia, Associate Professor Surveyor Dr. Rosmadi Ghazali, and Yang Berbahagia, Dr. Professor Emeritus Captain Dr. Hashim Yaakob, Associate Professor Dr. Hafizah.
Professor Emeritus Tan Sri Dr. Ibrahim Shah bin Abu Shah. Thank you, Yang Berbahagia Professor Emeritus Tan Sri Dr. Ibrahim Shah and bin Abu Shah and dignitaries for gracing us with your presence for the officiation of the symposium. You may all now return to your seats.
Distinguished guests, ladies and gentlemen, let us proceed to the next portion of the agenda, which is the keynote lecture by Yang Berbahagia, Datuk Professor Emeritus Captain Dr. Hashim bin Yaakob. Before that, allow me to introduce our honorable keynote speaker. Datuk Professor Emeritus Captain Dr. Hashim bin Yaakob graduated with his Bachelor of Dental Surgery from the University of Otago, New Zealand. He then obtained his Master of Science in Oral Pathology from the University of London, England, and also had fellowships in multiple bodies. In addition to this, he's also has a diploma in Islamic Studies from an international Islamic University, Malaysia. Is a chartered biologist from the Institute of Biology, United Kingdom, and has become a member of the Institute of Biology, United Kingdom. Datuk Professor has not only produced a myriad of papers and books as literary contribution to the field of dentistry, but he has also helped the Malaysian dental education gain its merit internationally. This achievement have gained him multiple accolades, such as a Lifetime Professional Integrity Award by Balai Ikhtisas Excellent Scientist Award from the Ministry of Education and Anugerah Tokoh Ilmuwan Bandaraya Kuala Lumpur by the state. Besides his love for dentistry, our speaker is a passionate poet, with his poems receiving a multitude of awards and have been translated to various languages as well, from being an editor in multiple local and international journals to the Vice Chancellor of Government and Private University. Our speaker is definitely an inspiration and idol in the world of dentistry. I hereby welcome Yang Berbahagia, Datuk Professor Emeritus Captain Dr. Hashim bin Yaakob to the stage to deliver his keynote lecture entitled Stand Up and Be Counted. Welcome, Datuk Professor.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Pokok tinggi. Pada usiaku 9, aku berdiri di sampingmu, di hadapan pokok ubi kayu. Di kursi rotan itu, kau kelihatan cantik sekali. Anakku, lihatlah pada bukti itu. Nampakkah kau pada sebatang pokok yang tingginya mengawal? Jadilah kau, anakku, pokok itu. Inilah bukit yang dirujuk oleh mak saya. He said there are a few tall trees that grew above all the rest. Be one of them. Pada usiaku 54, aku berdiri di sisimu lagi. Naib Chancellor Universiti Melaya, waktu itu aku. Di kerusi itu, kau tampak bahagia sekali. Mak, aku telah menjadi pokok tinggi kau itu. I have stood up and be counted. Itulah topik lecture hari ini. Stand up and be counted. Di sini angin bertiup kencang dan kejam, seperti mana yang dihadapi oleh Tan Sri, sahabat lama saya dulu, sewaktu dia mengendalikan UiTM. Di tempat itu anginnya bertiup kencang dan kejam. Tetapi Tan Sri bukan sebarangan orang. He is no ordinary person. He was able to solve all these problems. And today you have a very, very sophisticated, up-to-date, and a very established university. Part of it is because of Tan Sri Ibrahim's effort. And I am very, very privileged to be his friend. Sesekali aku goyah dalam ancaman. Tetapi emak, akar yang kau berikan padaku dulu bikin aku berdiri teguh. Hashim Yaakob, 2003. Yang saya muliakan Tan Sri Ibrahim Abu Shah. Dia kata saya tadi adalah his old friend, but we are not old yet. Tan Sri, let us grow together because better things are yet to come. So I would rather say Tan Sri Ibrahim and I have been friends for a long time. Not an old friend, but a friend that has been a long time. Profesor Muhammad Ibrahim, Abu Hassan, terima kasih kerana mengundang saya untuk berada di tempat yang gemilang ini. Saya tidak pernah ke sini, tetapi pada hari ini barangkali di dalam kehidupan saya dia akan menjadi satu sejarah yang akan saya catatkan bersama dengan pengerusi UiTM, bersama dengan tuan-tuan dan puan-puan sekalian, bersama staf sekalian yang kebanyakannya graduated from my school. How many of you graduated from UM? Can you please put your hands up? I just want to be 3 orang aja. Alright, okay. Profesor Rosmadi Ghazali, terima kasih Prof for attending this place. Profesor Hazlina, itu pun graduate daripada Universiti Malaya. Saya sudah tidak kenal because the jarak antara saya dengan Prof is so big. I am 73 years old today, and how old are you? Now, dan juga tuan-tuan, professors, pensyarah dan juga ananda pelajar sekalian. Hari ini, I will give you semangat. I am a part-time bomo. I'll give you semangat. If the physical manner doesn't work, then it will be my spiritual one, which you will remember. And most of the things which I'll speak to you will be my own experience, because I think if I were to quote other people's experience, you wouldn't know that. But if it is your own people, your own rakyat that said he can do it, then you will believe yourself even more that you can do it. If I tell you Donald Trump can do it, why can't you? You probably will say, that's Donald Trump. Dia gila kadang-kadang. But we are not. But if I say Hashim Yaakob can do it, then of course you will believe that you can do it. And I'll tell you, you can do it. Now, the bomohan is how you are going to develop yourself. Don't have to take notes because I will give you the soft copies later on if you really want to. Now, first you must have a high sense of priorities. First things is always first. Second thing comes second. And then the third one may not come. But give it a chance anyway. Like, for example, first things first. Your priority would be to come today for this meeting rather than going to buy groceries. So that is called first thing first. Coming to this lecture is first thing. compared to the second one, which is going to buy groceries. Why? Because once this is over, you will never get it again. Groceries will be there all the time. So you can do that. Things, list them. So you list them. What are the sense of priorities in your life? You list them. I had a long list of my priorities, and until today I have it in my diary. One day I probably will put in my memoir and it'll share with whoever wants to look at it. Clarity of vision. You must be very, very clear in your vision. What is it that you want? You must know precisely what you want. Don't go start looking at a very long list and trying to find what is your vision. How many of you, what is the vision of this university? I can tell you 50% of you don't know. What is the vision of UiTM? Don't really want to embarrass anyone. But being a teacher, I could just point out to one and ask, what is the vision of UiTM? But we're not going to do that. What is the vision of your faculty of dentistry? So know precisely what you want. Visualize the end of it. If you manage to fulfill your vision, you visualize what is going to be the end of it. Because vision creates reality. It's a vision, but it will create reality. If you have no visions, there won't be any reality. Mas Surrealis. Who is Professor Mas Surrealis here? Where is she? That's her. She had a vision that she will be the president-elect of the Malaysian Dental Association, which is your body here. And today she is the president-elect because you people went to elect her. And she visualized the end results. Next year I will be the president. Yes, that is visualizing the end result. And her vision would have created reality. Be very friendly with her now because she will be your president very soon. Now, personal resilience. Yeah? You must have personal resilience. What does that mean? It means that if you lose a few fights, it doesn't mean that is the end of you. I have sat for examinations many times, I failed. But I say to myself, examination is not going to defeat me. You can defeat me once, twice, 3 times. 4th time I will go there. I will be there, if not earlier. So therefore, losing a few fights would actually teach you how to tackle the next fight. Don't lose hope. Anything worth having is sometimes worth fighting for. If you think that is what your vision is, and it is something worth fighting, then fight for it. How do I do so far? How am I doing so far? You have got no energy. My students would have a lot of energy, but you are all dental students. You must have a lot of energy. You must be able to sort of respond, because if you don't respond in anything, you will lose. Tan Sri Ibrahim gave you a very good example just now, because if he had not fought and he did not respond with might and cleverness, he would not have this land here. Fight for your right. Anything worth having is something worth fighting for. And if you fail once, hell with it. Everybody failed once, twice. Who has not failed in their life? Tell me. All of us have failed in our life. But we didn't say, oh, that is the end of me, and I'm finished, and I will not go for it anymore. Personal resilience. the best habits for the habit of doing more. Don't kais pagi, makan pagi, kais pagi, kais, and so you can eat pagi, tak malam dan sebagainya. You won't be satisfied with, for example, with a master's degree here, if you are going to be a academic staff. You must get on with it. Habit of doing more. Maximize your potential. You have all the potential, maximize it. Have I achieved all that is possible? For example, you go out shopping. Have you bought all the bags? Hermes, Louis Vuitton, and all those things. Take all of them and go. So it means, have I achieved all that is possible? Stay busy, stay productive, and get the most each day. Then go back and sleep, to act again the following day. When I was a student, and later on I became a lecturer at University of Malaya. You were not born yet. That was in 1975. There were 25 lecturers, all with only BDS, because at that time there were no dentists, no masters, no nothing. So we all became. Tiada rotan, akar pun berguna. So there was no rotan, so akar with a bachelor degree pun jadi nekra. But we are not going to remain akar. We are going to be rotan very soon. I have 25 people. The dean was Ibrahim Yassin, the founder dean. He had a postgraduate. Professor Chin Tak Chiu had a postgraduate. He came from the government service, and so was Professor Lee Seng Guan. There were only 3 out of 28 who had postgraduate. And we worked so hard with only bachelor degree. And I wanted to beat the queue, because when I went to the dean, I said to him, when will I go to the to overseas to do my specialist degree? Because at that time we had no specialist degree, no master's degree in our place. The late Ibrahim said, 12 years time. Why? 25 divided by 2 is 12. We can send only 2 persons each year because we don't have scholarship at that time. Most is 3. So I said to myself, I will get my postgraduate only in 12 years, or easier, probably at best is 10 years. Then I said to my mother, who was a rubber tapper, he didn't have any much money. But for whole of her life, she has been keeping and saving and menabung money, thinking about one day the son might even ask to borrow some money from her. So I said, I want to go to England. I want to sit the FDS examination before everybody else does it. I will go on my own. I will sit the FDS examination primary while everybody else are waiting for their turns. When everybody was sleeping, I was already awake. This is what you all must do. So I went there very early in 1975, 76, and I passed my primary FDS. I passed my primary examination of the Fellowship of the Royal College of Surgeons of England. And I came home. I said to Professor, the Dean, I said, sir, I want to go next year. As he said to me, you can't, because there are a lot of your seniors before you, 10 years. Then I fetched out my certificate of the primary examinations. I said, sir, I'm better than any one of them because I have this primary examination certificate. So I'm ready to go for the final part when all the rest are not ready. Go, give it to me. And the dean was very, very pleased because I could jump the queue legally. Yes, so the following year I went on. This is something which I want to tell you. I.e., if you wait only for the normal thing to happen, you might die off before that. Other people who have been there before you, and you will not be the first to discover Mount Everest. Go. There are many ways of doing things. I like telling my younger people this because I think if I can find one of them will do the thing which is outside the normal, then I know this person will be successful. Now, life best habits 5, a strong feeling of self. No, when you look into the mirror every day, don't see a cat, which is weak. See a tiger, see a lion, see a dragon, see whatever. See Tan Sri Ibrahim Shah in the mirror. Tan Sri, I feel a little naked on the... Now, success or failure depends on your self-image, actually. If I were to come here in a terribly shabby dress today, I will fail. Why, you know? Simply because my confidence will not be with me, because I see that you are all smartly dressed, whereas I am shabbily dressed. Whatever I want to say will not come out of my mind and mind. So therefore, success or failure depends very much on self-image. Self-image does not mean your dress. It simply means all other things, self-image. The final parts of you. Now, success will come on how you feel about yourself. If you think you can do it, you can do it. So it is about yourself, what you are deserving of. For example, when I was in Standard 4, your father was not born yet at the time. It's quite true. I was in Standard 4. The teacher taught us, the little boy who says, I can, will climb to the hilltop. The little boy who says, I can't, will be at the bottom stop. Wah, itu Standard 4 cikgu boleh mengajar. So therefore, you build your resilience, you build your strength, you build your interest deeply and highly, climb up to the top. Don't say I can't. Because if you say I can't, you will not go anywhere. You will not move. Now, what did I say just now? I said, have a strong feeling of yourself. Be proud of yourself. Think that you can do something which other people hardly can do. Look at this picture. Do you know anyone there? I signed an MOU with the Oxford Center of Islamic Studies from the University of Oxford. And who is there behind me? Your previous Prime Minister, Dollah Badawi. And then it is Shafi'i Saleh, who was the Minister of Higher Education. And then on his right is Syed Hamid, who was the Minister for Foreign Affairs. And then Sabri Chik is another minister. I cannot remember what minister he was. And then the last one is the High Commissioner to United Kingdom. And I sat there, a rubber tapper man's son, signing an MOU with one of the foremost center. I didn't look at myself as a small chicken. I signed an MOU with Peking University. I tell you, one of the hardest things to sign an agreement with is with China. It's not easy. And with Peking University, the #1 university. I signed it. Behind me are all Chinese people. I'm the only Malay fellow. And I thrive on that. So we signed an MOU with Peking University, which is very difficult. Why I'm telling all you this? I'm telling you this, go for the highest. Go for the highest. If you can, start at the bottom and then just go up and up and up. Because once you start with the highest, there will be the recognition for you. So that was the hardest to sign. Signing MOU with Cambridge is not difficult. I signed an MOU with Cambridge, the University of Cambridge. This was when I was the Vice Chancellor. Carnegie Mellon, which is one of the Ivy universities in USA. All these universities, ITM, UiTM, must start doing these things so that you can come up and be counted. Now, of course, there are many more. I just show you a few to show that life is what is in the mind. And if the mind says, do it, reach for the stars, then you reach for the stars. If the mind doesn't say so, then you will not so. You will not do so. Renegade thoughts and behavior. Renegade thoughts and behavior, meaning be a rebel. If people do things the normal way like this, for example, then try and do it something else which other people do not do. So you are a rebel with a cause, not a rebel without a cause. So renegade, thoughts and behavior, meaning renegade your thinking as well as your behavior. Think about the impossible. Think about what you want to do, what you are going to do, so that you become the achiever of the impossible, right? Be willing to think extraordinary thoughts and take bold action. Being bold. I have always been bold. And you can. Never fear standing out. Never fear to stand out of the masses. Because you have something better to tell the masses. And you must be bold and being phenomenal. Be a phenomenal. Jangan a person becomes something else, you also take over, lepas tu jadi macam tu, you jadi macam tu, and start pushing pen. Throw away the pen and just use the mic. Or just being you. If you are progressive, that's what it is all about. So when I was 37 years old, I was the Dean and Professor of the Faculty of Dentistry at the University of Malaya. Every time I went overseas, including to my alma mater, they belittled my faculty. They asked me, who takes the medical history for your patients? Do you have Gracie's curate? What sort of impression tree do you have? What sort of qualification does your staff have? At that time, you know, I've got to explain to him, we have got many Gracie's curates. We have many. He doesn't believe. He won't believe it. So I said to myself, I am going to renegade myself and behavior, and I'm going to do an extraordinary thing. I tell you what is the extraordinary thing I did. Singapore University, BDS, has been taken back the recognitions of the General Dental Council of Great Britain. Its recognition. Taken back because the standard was not up to it. The medical faculty at the University of Malaya, the recognitions by the GMC were withdrawn because the standard was not good enough. And I said the dental faculty of University of Malaya will go for the General Dental Council of Great Britain for recognition. Because we were young at that time, nobody believes me. We won't get it. Singapore had been taken away. Medical faculty is much older than us, has lost their thing. So I went to Uncle Aziz, who was the Vice Chancellor at that time. I said, sir, I want to go to the General Dental Council of Great Britain and obtain the recognition for this faculty of dentistry. Uncle Aziz said, but you are a very young faculty. It was only about 15 years or less. The medical faculty has been there for ages. and we have lost it. What if you are not going to get it, said he. You know what I said to him? Which made his eyes go wide and gave me the approval straight away. I said to him, sir, we are dental surgeons and we are not medical officers. You must say this to yourself. Because all the time, the medical people have always think of themselves as being superior than you, dental surgeons. You know, I said to Uncle Aziz, sir, we are dental surgeons and we are not medical officers. Don't compare us with them. I was very bold. What, Hashim, if you don't get it, he said to me. Then, sir, I would have raised the standard of the faculty, of the BDS degree, up to almost the recognition thing. We will try again next year. But the fact remains, I would have raised the standard because we would have worked for it. And also I said, if we fail, you may wish to find a new dean to get it for you. Bold. And what happens? So we did it. We did it. And there it is. Dentistry course matches British standard because we got that. So every time I went abroad and they asked me, what do you have? Do you have graces? I will show him this paper. And I also bring the certificate that says so. Look at this. Dame Margaret Seward, who was she? Those of you would have read her, their husband's work. She was the President General Council of Great Britain. She said, in 1997, the school, which is the dental faculty of the University of Malaya, delivers a course of the highest standard to match the best in the world. I did not say this. Dame Margaret Seward said this. Well, what happened when we got that? My staff, my students, and me, and Uncle Aziz were in cloud nine. I was dean, so I could do anything. I said, make big posters about this and put it at every entrance, so that each time the students come into the lecture hall, they will read this, they feel very proud. Each time the patients whom you treat come up and look at this, they will have a lot of confidence in you. Every time external examiners come and anybody comes or whoever comes, they will have to read this thing if they are literate. And when they read this, you know what sort of pride you can have. What is this? Dentistry course matches British standard. And this person says, match the best in the world. So I went to Uncle Aziz and said to him, I've done my job, sir. And I would like to go for my sabbatical leave now. She said, no, there are many other jobs that you must do. Start the master's degrees for dentistry. Start the PhD degrees for dentistry so that your people don't have to go to England, America, anywhere. Waste of money. So I started your bachelor, I started your master's degree, any one of you who got it. And then later on, of course, other universities came along with us. Now then, if everyone is doing the same thing day in, day out, year in the same way, there is probably a better way of doing. All right? There's a better way of doing if people are doing the same thing all the time. You must move with time. Pleasing others does not work in the long run. I have found this because a lot of people think about what other people would think of them. You must not do that. Because I tell you about what you can believe if you think seriously about what people think about you. I don't care what people think about me as long as I do not do the wrong thing. Listen carefully to this one. If you were to hear about what other people say about you without them realizing that you are hearing every word that they are saying about you, you can really just fall down and dead. Because what other people say about you is so terrible, so horrible. Yang baik-baik dia tak pernah kata pun. Itu orang Asia macam itu tau. They don't say the nice things about people. They will say things about people concerning about the bad things about it. That's why I say, but they will not say in front of you because they are very cowardly. They will say behind you. So therefore, don't care about what people think about you as long as you are doing the right thing, you are following the law of this country, and you are following the cause of God Himself. Be a good person, then to hell with it. Dream unrealistic dream. Most barriers are self-imposed and a product of your imagination. You think, I cannot do it, I cannot do it. So you don't do it. You must dream. Because if you have no dream, it will never materialize. Dream of unrealistic dream. For example, if you are ambitious enough, dream to become a vice chancellor of UiTM. Professor Ibrahim is gone, he will not come back. When I was a student in Otago, New Zealand, I dreamt that one day I will become a specialist, and I became. I looked at every qualifications which my lecturers had, and I looked down. So saya tulis, bachelor degree 1974, master's degree 2 years later, fellowship later. Ada, sekarang pun masih ada dalam buku. Then when I came back and became a lecturer, I had a dream that I wanted to be the dean. I wanted to be the dean because I didn't like the fact that if I have no power, I will be sitting at the end of the line receiving the decisions made by other people. I want to make the decisions myself. I want to be in control. I want to be the dean. So I dreamed I will be the dean. I became the dean because, as I told you just now, if you work hard enough, pray a little bit. Don't pray so much but didn't do anything. Because God has said, aku tidak akan mengubah nasib siapa pun, sama bangsa mana pun, you all know this, unless that bangsa and orang itu sendiri yang mengubahnya. And then you doa kepada aku. Doalah kepadaku, nescaya aku kurniakan. But must work first. When you see yourself in your own dream, you can change your life for the better. And when I was the dean, you believe it or not, I dreamt that I would want to become the vice chancellor. And I became. Because I had a dream. When I had a dream, I had to work for it. Work hard. Work hard. Not working hard at downgrading people, but work hard at improving yourself at all levels. You remember you are a dentist and I am a dentist. How many dentists have ever become a vice chancellor in the whole world? The whole world. There are 30,000 universities in the whole world. There are only 3 dentists who ever became a vice chancellor. Kalau in this country, it's only 1. One in Australia. I am addressing a group of dentists. So, life is not just dentistry. Life is life. There are other things other than dentistry. Why do you think I can write a poem like that? I've written more. I even paint. I can play the shadow play. And I'm a captain in the Royal Malaysian Navy. Tauliah, not honorary. You can do it. So when you are involved in many things like that, then dealing with life is not going to be that difficult. Follow your dreams, transform your life through your dream. Tapi janganlah dream angan-angan, macam ada orang menyanyi angan-angan, siapa? Raja Emma menyanyi lagu tu. Angan-angan yang paling didn't get anything. Because dia berangan saja tetapi dia tidak. An attitude of invincibility. You must believe that you are very strong in doing your thing. Believe that you can and will accomplish whatever you have set your mind on. See the invisible and achieve what others consider impossible. Ni tak boleh buat, tak boleh. Prove them wrong. Do it. Right? And of course it is Mark Twain. I like this Mark Twain punya cerita very well. Never argue with stupid people, said Mark Twain. They will drag you down to their level and then beat you with their experience. They have an experience in stupidity and all sorts of things. You cannot. They will beat you like hell. And then you keluar, rasa lebih bodoh daripada tu. Why did I? If ever you nak pergi a fist fight, don't go and fight with the constable, or fight with the inspector general of police. Dan even if you lose, orang akan kata, oh dia lawan dengan inspector general of police, the number one police. Kalah pun tak apa. Tapi kalau pergi bertumbuk dengan polis private, you menang pun orang tak kata apa, dengan private boleh lah. Okay, there. So, an attitude of invincibility. My dean, Sir John Walsh, he was a dental and a medical graduate. So he was respected by the medical profession. When I came back, I am, of course, dentally qualified. Whatever degree I have, whatever fellowship I have from Royal College here, Royal College there, is still dentistry. And yet I am a pathologist and an oral medicine. Oral pathology writes report from the specimen biopsy. Oral medicine treats the patient, and he treats the patient with medicine. People will think that you are a dentist, so therefore they will not. So, I wanted to be invincible. I took the FRC path. I am a fellow of the Royal College of Pathologists of UK, which is a medical college, not a dental college. So now if I report, I only sign FRC path. Aku tak tulis dah benda-benda lain. Because we are dealing with something medical, invincible. Now, next. One day I was, what was I? I was an expert witness in the court. Somebody cut the jaw of somebody, one doctor, medical doctor, potong in his jaw without taking biopsy. They saw only the X-ray picture. So this patient asked a few surgeons and oral pathologists in NUS. NUS stands for National University of Singapore. They didn't want it. And then they approached the pathologists in the University of Malaya Dental Faculty. They refused it. Why? Because they cannot stand up and be counted. Ada degree tapi tak boleh. Because they cannot stand up. Too small. The mind is too small. So Professor Harris was our teachers to very many of you here from UK. Said, Hashim, you must do it. You must stand there in the box as a witness for this, to speak out for these poor patients whose jaw has been cut for nothing. I was the Timbalan Naik Chancellor at the time. I've left oral pathology for about 2 years. I took the challenge. What is the use of being a professor of oral pathology kalau nak masuk court pun you takut? When I go to the court, I am the master. You can question me anything, but I am the master. So I masuk court. This is the interesting thing. There were 3 or 4 lawyers kat situ who wanted to disqualify me. So the first question they asked me was, are you medically qualified to be testifying on a medical condition? I asked him, what do you mean by medically qualified? I asked him back, what do you mean by medically qualified? Because, and then he scolded me. He said, the lawyer said, 4 of them, you only answer yes or no in the court. Always like that, right? Yes and no. Then I turned to the judge and I said, Your Honor, there are times when people cannot say yes or no. People have got to explain. Otherwise, I'll be answering wrong questions. So I asked the judge, whatever it is, you must go through the judge. The judge said, Prof, go ahead and ask. I said, what do you mean by medically qualified? And none of the lawyers who interviewed me knew what was medically qualified. And I helped them. I said, do you mean that whether I have MBBS or MBCHB or MD or whatever it is, the medical degree? Oh yes, it was. I already beaten them. Once beaten, twice shy. They are beaten already, so twice they'll be shy. So I said, I don't have it, the medical qualifications. Then what did he say? Then I put it that you are not qualified to testify as an expert witness. Oh, I enjoyed this. I am a professor of oral pathology. No lawyers will ever beat me in my subject. Other pathologists may beat me, but not them, because they did not even study a day in oral pathology. I prepared myself. I dah tahu that this is what they are going to do. They are going to disqualify me. If you know that you are going to be ambushed, then get your guns ready. Ride in the armored car. And langgar dia seperti mana Tan Sri langgar. Right? So, I armored myself. In the court, I cannot lose because I'm a professor. I have a reputation to look after. So, I armored by myself. Macam mana? I got 10 books on oral pathology written by dentists. America, America, Britain, kan? When you read your oral pathology, it's not the medical fellows who write about your oral pathology book. They are the dentally qualified people. And then I got 10 top-notch papers on the case which they were doing, which is amyloblastoma. All right? Top. And then I make sure that it was written by dentists, dentally qualified people. And then I brought 10 calendars. Calendars mean university books. That shows that oral pathology is always taught in dental faculty, never in medical faculty. And then the last one was that I brought a record that I have been practicing oral pathology for the last 30 years. So they rest their case. And they were beaten. They said, Your Honor, we have no more questions, because they came there only with one question. They think that they defeat me. Aku professor betul tau. So then we came for the next sitting. In the next sitting, there were many questions which they have plan. But I will not tell you. There will be another lecture for this. And if you want to do your postgraduate type of thing, you ask me to stop already. You are not interested in this? She give me 1 minute. Never mind, I will follow you. Now, you must always think positive, right? Positive means in thought, in behavior, don't worry, I'll finish in your time specific. Your thought, your behavior, and what is the result. Now, if you say, I'm not good enough, I'm old, I'm too old, I'm too weak, I am whatever, I can't do it. So your behavior will be, you will not attempt to carry out any task. So what is the result? Nil. You get worse with time. And then you have inferiority complex because other people are achieving, yeah, you are not. And then you will be stressed, right? I am now I'm very stressed trying to finish the bloody lecture in 10 minutes. All right? So, okay. How many of you are under stress now? Not because of this lecture. Anyway. How many? Can you put your hands up? Now you are. I am under stress. Now, I tell you, I'm going to show you a very simple self-assessment stress test. Yes? You will look at my photos selepas ni. Now you will see that 2 dolphins are jumping out of the sea. Now if you notice any difference, any slight difference, that means you are anxious. If you notice bigger difference between the two, they don't look alike, then your anxiety is severe anxiety. If you see the more, then you are under stress. If you see most of it, then you are depressed. Right? So I want you to see, if you see any difference between the 2 dolphins, 100% difference, you are terribly depressed. Please keep it to yourself, don't tell anyone, because that is personal. Don't even tell me. I see there are 2 dolphins coming out of the water, so I'm not depressed. What do you see? Now, life best habits, I'm going to finish in 10 minutes. Now, most limitations are based on fear. Based on fear. Because you don't want to do it because you fear something. When your personal passion for a better life becomes greater than your own willingness to settle your life, to settle for the life you are presently living, you will become invincible. If you are, I am happy with what I am, I'm happy with it, of course you do. But if you want it to be better and better and so on and so forth, you will become better. I want to tell you about solving conflict. Yeah? We said just now, we have just said just now, most limitations are based on fear. This probably will be the last slide that you are going to see. Now, how you are going to overcome fear if you have fear? Who knows who this man is? It doesn't matter, all right, whether you know or not. It matters not. Do you know that man on the other side? Now, that 2 men were in conflict. He was a vice chancellor, he was only the dean. But the dean had no fear to speak out for what he thought was right. So what happens? What happens was, the dean had a wife, and the dean had parents. Both are illiterate. So he wrote this supaya dia rasa jadi macam kuat. He wrote it and then showed to his wife. He said, now that I am in trouble, I wrote this to her. Rambut gugur dari sangkar disita putri di kolam lama. Ribut taufan bumi terbakar, kita berdua tetap bersama. Yeah, you tell this to your wife or you tell this to your husband. Ribut taufan bumi terbakar, kita berdua tetap bersama. Meaning, come what may, both of us will stand firm and fight the bloody thing. You understand? I have been watching too much US punya movies. They use the word very often, so I can't stop it. Bloody is spelled B-L-A-R-D-I. It is not the one that you think so. So, now, yeah, the wife is there. So, I was a professor then, I was a dean then, but I did not know what to do. So I drove back to my hometown. And when I arrived in my hometown, I saw my father sitting on the staircase with his wife, and I told him, I am in big trouble and I do not know what to do. I have been removed from my deanship. My father asked me, are you guilty, Hashim? That is all an illiterate person can ask. He can't be asking you some sophisticated things like what I said in the court. Are you guilty, Hashim? I said, no. I am not guilty. I am not guilty, Ayah. Then my father said, go back to Kuala Lumpur and fight him. Then I said to him, how do you know that I am not guilty? I have just told you I am not guilty, but I have not explained to you in great detail. What my father said was greater than any award anyone can give me, because it came from my father and from my mother. What did he say? He said, put this thing nearer so that you can hear. Aku percaya sebab anakku yang menyatakan dia tidak bersalah. Dan anakku tidak pernah berbohong padaku. That's the highest award I ever get. It is because my son have told me that he is not guilty. And my son have never lied to me in his life. And I almost broke down and cried because, and I went home. I went home back to Kuala Lumpur and I fought. And I won, and I became the Vice Chancellor. Now, ladies and gentlemen, if you are being charged wrongly in your life and you are convinced that you are in the right, fight it. Fight it. You will win. Nothing beats the truth. So fight it, because if you live, you will live guilty forevermore. Summary. Become a hero of the world if you like. As a summary, they are just like you and me. Nothing different. We don't wear Superman or Batman sort of dress. They are just like you and me. They believe in deserving more. Not enough, aku buat lagi. They are willing to do whatever it takes to live a better life. I tell you about this story. There was a sparrow who fell down onto the earth. Fell down onto the earth because he heard a clap of thunder. Halalinta, dia jatuh, terkejut, buk jatuh. And then duduk naik ke atas tu, kaki ke atas langit. And he thought the sky was falling down. And he's going to support the sky with his scrawny little legs. That's why they duduk macam tu. And then came a mighty eagle and flew over him and asked him, why are you sitting, why are you lying down with your two scrawny legs upstairs? He said, I am trying to support the sky which is falling down. The eagle said, no, it will never be. And do you really think you can support the sky with your little scrawny legs? And the sparrow said, one can do, one will do one's best with what one's have. So the little sparrow taught the mighty eagle a lesson. I am a small fellow, but I will do my best. I will do my part. Jangan duk tinggalkan untuk orang besar-besar saja. Tak habis-habislah slide ni. They are fearless in the face of adversity and never accept the status quo as their destiny. Never accept their destiny. No, nothing great has ever been achieved by sticking with the status quo. Status quo macam itu. Nothing great can ever happen if you stick to the status quo. And if you want to create something new and different, risk-taking needs to be part of your repertoire. Take risk. You don't lose anything by taking risk. They are not afraid of taking chances. Take chance to live with consequences of their decision. Kenapa orang beli battery? They are taking chance. Beli lottery, I mean. Now, we are almost finished. They know that altered behavior is the link between that. So your behavior must be altered. You must change how you think, how you behave. Conclude. Create a list of your priorities. Clear. 1, 2. Kalau tak ada 3, 4, 5 pun just 1, 2. What is your priority? Shake up your life whenever necessary. Once in a while you really have to shake up your life. Am I doing the right thing? Am I what? It's just like scaling. Go and scale your teeth every 1 year. Shake it. Keep your goals high. Work harder on yourself. Be unafraid to go against conventional wisdom. Rebel. Right? Do whatever it takes to become a hero to yourself and to others. Adopt the habit of personal persistence. Persist. Don't give up. Finish. Taking back of life will be in the next lecture, probably next year. So, I mean, if you have got no life before, I can teach you how to take back your life. But not now, because my 10 minutes is up. Ladies and gentlemen, I thank you very much for having listened to me. And I hope that the time spent today with you has become a little bit, has become a little benefit to you, so that you would strive, you would believe in what I've told you, and you would strive for the better. You would strive for the better, for yourself, for your family, for your children to come. Assalamualaikum warahmatullahi dan terima kasih.
Thank you very much, Yang Berbahagia Dr. Professor Emeritus Captain Dr. Hashim bin Yaakob, for your insightful and motivating speech. We would like to kindly ask Dr. Professor Emeritus to remain on stage. Now I would like to call upon Professor Dr. Muhammad Ibrahim Abu Hassan, accompanied by Associate Professor Dr. Hazlina Abdul Ghani, to present a memento to our esteemed keynote speaker. Thank you, Dr. Professor Emeritus, Professor Dato, and Dr. Hazlina. You may now return to your seats. With that, we have reached the end of the opening ceremony of the 12th Dental Student Scientific Symposium 2022. We would like to wish all participants who are competing in the various events the best of luck until we meet again in the closing ceremony tomorrow. Before we end this session, we would like to invite all participants and invited guests to gather in the middle of the hall for the photo session. Please welcome our cameraman to the stage to capture this momentous moment. Ladies and gentlemen, shall we please move to the middle of the hall so we can get a nice picture? And we advise you to keep your masks on, please.
and the guests into the hall as the event will be starting any minute from now. Just a reminder to all, do kindly switch your phone into silent mode throughout this event to avoid any interruption. Thank you in advance for your cooperation and attention.
let us continue our symposium with the sponsor GSK promotional talk.
Hi, good afternoon to all the lecturers and also the students. My name is Titi. I'm from GSK. So I would like to talk about the dentin hypersensitivity, the prevalence of dentin hypersensitivity, and also what are the treatment options that you have in the market right now. So to begin with, let us take a look on the dentin hypersensitivity, the definition of the dentin hypersensitivity. Personal identity and confidence. So for long-term 6 months study, we have a baseline assessment of sensitivity and condition cure, and the patient will be given 1% of the weight at week 1, 2, 4, 8, 12, 18, and 24. So the result shows by twice daily brushing with 5% dopamine, it shows improvement of the dentin hypersensitivity management. And also by brushing twice daily with 5% dopamine, it can have a significant impact on the dental hypersensitivity patient, both clinically and oral health related quality of life. Means the patient can enjoy ice cream, enjoy the ice kacang without worrying there's something in it. So this is how the Sensodyne Repair Protective Implant looks like. We have 3 flavors, which is original, extra fresh, and whitening. I'm so excited to share with you on our latest commercial break in social media and also in TV. So enjoy the video. Sensodyne Repair and Protect Deep Repair yang baru ini menggunakan teknologi berbaloi, di mana ia boleh membaiki jauh ke dalam gigi dan juga membentuk lapisan pelindung yang menyeluruh terhadap gigi. Kini, semua orang dapat menikmati minuman ais tanpa merasa gigi ngilu. Ia akan meningkatkan kualiti kehidupan manusia. Saya ingin mengusulkan Sensodyne Repair and Protect Deep Repair yang baru. So thank you so much for your time. Hope to see you again. Have a good day.
The Dean from IMU as Chief Judge. The second judge is Professor Fuad Hussein Al-Bayati from UiTM. Last but not least, the third judge is Associate Professor Dr. Nurul Ashikin Yahya from UKM. And our respectable timekeeper for these competitions is Noreen Darwisha. Ladies and gentlemen, as a kind reminder, please lower down your voices and ensure that your mobile phone is switched off or turned into a silent mode to avoid any interruption. I would like to remind everyone to ensure that no guidance or prompt are given to the presenters, as this may interfere with the process of the presentations and the focus of the presenters. Your considerations is very much appreciated. Before we proceed any further, do allow me to explain a few house rules for the sessions. The time allocated for the oral presentations is 10 minutes. The first bell will be rang at the 8th minute, and the following last bell at 10 minutes, followed by 5 minutes of questions and answers from the judges. Another bell will be rang at the end of the 5th minute of the Q&A session. So now, let us begin with the first pair of presenters, Amir Razik bin Salihan and Nur Aisha binti Rosman, to present their research topic entitled A New Paradigm in Dental Education, Exploring Student Perceptions, Experience and Anxiety Level Amid COVID-19 Pandemic. Please welcome.
Assalamualaikum, very good afternoon to all honorable judges, lecturers and fellow friends. My name is Amir Razak. Together with my partner, Nur Aisha, we would like to present our research report entitled A New Paradigm in Dental Education, Exploring the Student Perception, Experience and Psychological Impact in the Midst of COVID-19 Pandemic. Under supervision of Dr. Nur Hafizah binti Kamal Effendi and also Dr. Nur Faizah binti Muhammad Bohari. Now, let us take a sneak peek to our research background. On 2019, the whole world was shocked with novel coronavirus disease, which is COVID-19. Later, on March 2020, after gradual increase of reported cases in Malaysia, our government enforced the Movement Control Order, also known as MCO, which restricting social isolation and closure of multiple sectoral activity. These also include dental educational institutions Therefore, the student had a sudden shift from normal face-to-face classes to virtual education. They also had to adapt with this new system instantly. Due to this MCO also, the students are found to have lack of motivation towards their study. They also have tendency to neglect their daily routines activity and frequently being haunted with uncertainty feeling. Along with educational pressures and lack of support from their family and friends, they are being pressured to learn everything more independently. Hence, this can contribute to possibility of university dropout. To add more, educational activity in dental school pose great risk of infection, especially for those in clinical years. This is due to the nature of treatment procedure that generating the aerosols and the coronavirus itself treating the aerosols as method of transmission.
Thus, the purpose of this study is to explore the dental students' educational experience, protocol consideration after the school reopening, as well as their concern on their physical health during COVID-19 pandemic. Secondly, it is to evaluate the psychological mental health of dental students during the COVID-19 pandemic through a generalized anxiety score. For the methodology, a cross-sectional study was conducted from all dental students from 13 dental schools in Malaysia from 20 June to 30th July 2021. Sorry?
Our questionnaire comprises of 5 structured sections.
Yeah. Then, after the respondents in the target population was recruited, using the proportional sampling according to the number of the dental students in the university, a sample size was calculated using the EpiInfo software by after adding 30% non-response rate. By taking p-value of 0.05 and confidence level of 95%, a total of 346 respondents were recruited for this study. After adding the 30% non-response rate, then the ethical approval was obtained from the UiTM Human Ethics Advisory Committee. After that, the questionnaire was distributed to the questionnaire hyperlink was distributed to the university representative, and the questionnaire was adapted for the research paper Manhu et al. 2020 entitled "In an Era of Uncertainty, Impact of COVID-19 on Dental Education," Journal of Dental Education. And as early as August 2021, the data collected was sorted in Excel to filter the invalid responses.
Our questionnaire comprises of 5 structured sections. All sections except the demographic are answered in a Likert scale style. The questionnaire started with demographic information, followed with their educational experience during the MCO. Next is their consideration regarding school protocol after reopening. And the 4th section is their concern regarding physical health during COVID-19. Lastly, to assess their psychological health, we use generalized anxiety disorder 7-item questionnaire. Regarding on how we analyze our data, the software used were IBM SPSS version 26. First is the descriptive analysis. The respondents' questionnaire data that is in continuous variables were reported as mean and standard deviation, while ordinal and categorical variables were reported as frequencies and percentages. Second is the univariate and bivariate analysis. We use Pearson chi-square test to explore any significant association between the socio-demographic factors to the level of anxiety. We also use simple logistic regression to provide preliminary factors towards anxiety, and then these factors are included into multiple logistic regression analysis. Moving on to the results we obtained from our research, based on the respondents, majority of them are Malay, female, and currently studying at public university. Moreover, they are mainly from M40 household income, followed by T20, and lastly, small portion of them are from B40 families. Almost all of the students never had COVID-19 infection, and mostly they are staying with their family throughout the MCO period.
Next is the result for assessment of educational experience. Various forms of teaching platforms were utilized by the students ranged from Google Meet, WebEx, and Zoom. Most of them were naturally comfortable with the online teaching and were concerned about the quality of it. They were extremely concerned about passing the examination and completing their degree on time. Furthermore, they nearly often have difficulty focusing on the schoolwork and finding motivation to study. For the effectiveness of the school response towards COVID-19, majority has neutral opinion and thought that their school somewhat effective in transitioning to online course. Meanwhile, opinions about lecturers' clinical experience during school closure showed a neutral response. Next, for the assessment of protocol consideration of the school reopening, when the students were asked about their willingness to replace the loss of educational experience by cancelling their break, only 15.3% were willing to do so. Moreover, only 7.5% were willing to attend the school for 12 hours per day to replace the lost session. When alternative of coming 6 days per week are suggested, 33.3% were probably willing to make up their educational loss. Apart from that, when the school reopened, they felt that everyone should always wear masks in school. For wearing gloves and even distribution were recorded was 24% thought that gloves should often be worn, and thought that 20.1% thought that it should be worn occasionally. Furthermore, opinions about testing COVID-19 also varied, with 36.6% thought that it should be daily testing should be done occasionally, and 23.1% often favored weekly testing. Next, for the result of assessment of physical health concerns after the school reopened, out of our respondents, 49.8% were concerned about their physical health, and more than half were extremely concerned that they might be contracting COVID-19 from providing patient care in the clinics. They were also extremely concerned about contracting the virus from attending face-to-face class and from interacting with the people in campus buildings.
This table shows the number of students with different level of anxiety. We have found that out of 333 respondents, that 57% of the students are affected by anxiety ranging from mild to severe level, while the other 43% of students are found to have normal psychological state. We also found that 10% of the students are affected by severe level of anxiety, and this number is quite alarming. This next table shows us the results of our Pearson chi-square test. At significant level of P less than 0.25, we found that four variables are highly associated with anxiety level, which is the gender, household income, students' type of university, and students' type of accommodation. The next table shows is regression analysis. For simple regression analysis, only 3 factors are found to be highly associated with anxiety level, which is the gender, type of university, and current accommodation students are living during the MCO. These factors are then included into the multiple regression analysis, and we found that only 2 variables are significant, which is the gender and student current accommodation. Based on the results, we found that females have lower odds of having anxiety compared to male, and those who are staying at campus has lower odds of having anxiety compared to other types of accommodation. Next, the first discussion we can make from our result is that regarding the educational experience, in general, the student has positive feedback of adapting to online learning. Despite of this positive feedback, they are negatively affected due to uncertainty thought regarding their clinical requirements and also passing the exam to graduate. Our results also suggested that the negativity thought contributed due to lost supporting network of friends and also non-conducive studying environment. Next, we would like to discuss on the protocol of school reopening. Majority of the students, we found that they are unwilling to replace their clinical session. The suggested method of replacement in the questionnaire are extended time of 12 hours per day, extra session on Saturday, and also cut off their semester break. These negative trends may be due to the uneven distribution of the respondent, which is mainly from public university, which we expect them to have receiving the scholarship and also having lower educational fees. Contradictorily to the public university, we may see positive impact because they want to avoid extra burden by additional fees.
Moving on to the discussion on preventive measures. So the use of masks was mostly preferred after school reopens, which is mostly similar to other previous studies. But the use of gloves and frequency of COVID-19 testing were less recognized as preventive measures. This could be influenced by the period of the study itself, where proper guidelines were not established yet for the students to understand the risk of the disease. Furthermore, the response might present information bias due to the non-availability of the self-testing that undoubtedly involve higher costs and inflicts pain during testing. Also, the respondents showed a negative perception about COVID-19 with mostly concern about the risk of getting infected. The fear of contracting the disease was similarly reported among dental students and dental professionals, especially when it is related to aerosol generating procedures. Next is the discussion on the level of the anxiety. The odds of anxiety was 57% lower among female students, which is contradictory to other previous studies where generally females has a higher risk to have anxiety in comparison to males regarding COVID-19. However, there is one report suggests that men tend to have more depression and anxiety compared to women on the impacts of COVID-19 to their life, especially in employment and loss of income, while women are more anxious on the physical symptoms of the disease. Moreover, females are more articulate with their emotions and feelings than males, which are more prone to avoid expressing their emotions. Apart from that, students staying in campus has a 46% higher odds of getting anxiety in comparison with those who stayed at home. This may be due to the concern of not be able to focus on their study at home due to the presence of other family members, as well as concern of contracting the virus to the other family members or infecting them and vice versa. As for the conclusion, during the pandemic crisis, a wide range of flexibility is required from dental students and also the lecturers, including learning new technology for the distance learning. As most dental students have positive feedback towards online learning, constant improvement is needed to ensure the possibility of hybrid learning even after the pandemic. Furthermore, physical and mental health of dental students should be a priority to ensure a smooth transition to the regular rigorous standards of educational and clinical training for dental education. And these are all our references. With that, thank you.
Thank you for the question. Actually, for this questionnaire, initially we are planning to do for both preclinical and clinical years, but due to the restriction, we only applied this questionnaire to those clinical years, which is year 3 and above, year 3, 4, 5. Yes. Actually, we do have one question at the demographic, which there are either year 1, year 2, year 3, or year 4, year 5 students.
So right now, you're telling me you do have one question saying year 1, year 2, year 3.
Actually, the results were included in the reports, but we did not include it in this presentation. We do have the each percentage of students from year 1 until year 5 during the analysis. Yes, I'm sorry because I have this confusion. Actually, we do include all of the respondents, which means that from year 1 until year 5 from each dental school in Malaysia in our analysis. Thank you for the comment. I think that is the factors that we can consider for future improvement in this type of research. Thank you.
Thank you for the questions. How we select the respondents? We use proportionate sampling where from the API info software, we decide to take confidence level on 95% and the total number is 346 students. Then from the 346 students, we divide by the total number of the students in one specific school, and then we multiply by the total number of the students in Malaysia. And we got the respondents for each university.
The lecturer and dental student. What do you mean by wide range of flexibility? In terms of what? In terms of not using the
wide range of flexibility in terms of learning technology, since mostly during our study, students are in online learning, and most of us have to learn how to use the Google Meet, for example, and that find online sources Terdapat
So I assume that you distribute the questionnaire before, during the MCO, and after that you distribute it 2 times, the questionnaire, when the school reopen? No.
No.
But you got one question here. Yes. So how you evaluate this?
Actually, this is for evaluation regarding preparation of next unexpected pandemic such as the COVID-19 itself. We are expected to already prepared on educational learning, and as from the results shown, the students have positive feedback into education, but due to other factors, their thought can be negatively affected.
Okay, thank you.
Okay, Amir and Aisha. You have found that 36 had severe anxiety, right? 36. About 10%, isn't it?
Yes, only 10% of the students.
So what do you do with these students who probably need help in terms of counseling? Is there any preventive measure or any counseling that you offered?
Actually, from the questionnaire, we only provide an open-ended questionnaire for them to be able to express what they are thinking throughout the MCO. But that is only for data collection purpose, and we do not take any further action regarding on what they have expressed or from the result itself.
Okay, what would you think would be appropriate as a action towards your findings? What would you suggest?
As we, as the researchers, know exactly who and how many the students have the severity from the dental school, we might provide this data to the administrator of that specific school, and you can suggest focus on these few students.
Okay, all right, fair enough. All right, I think that's it. Thank you.
Thank you to the judges for the questions. Next, without delay, I would like to call upon the second presenters, Siti Nur Fariha binti Muhammad Ridwan Rodriguez and Nurul Afika binti Azli Fitri, to present their research topic entitled Progressions of Periodontal Disease Among Treated and Untreated Patients During COVID-19 Pandemic, an Observational Study. Please welcome.
Assalamualaikum and good evening to all judges, lecturers and all my fellow friends. My name is Siti Nur Fariha binti Muhammad Ridwan Rodriguez, and this is my partner Nurul Afika binti Azli Fitri. So today we're going to present about our research, which titled Progression of Periodontal Disease Among Treated and Untreated Patients During COVID-19 Pandemic. So this is the outline for our research, and the next part will be continued by my partner.
So we start our research presentation with introduction. According to Newman, Take and Carranza 2018, periodontitis by definition is an inflammatory disease of the supportive tissues of the teeth that caused by a specific microorganism or specific group of microorganisms, which result in progressive destruction of the periodontal ligament and alveolar bone with increased probing depth formation, recession, or both. Periodontitis will be manifested clinically with clinical attachment loss, increase in probing pocket depth, gingival inflammation which will result in increased bleeding on probing, gingival recession, bone loss, tooth mobility, and tooth loss. A clearer understanding regarding disease progression, such as the time required to reach a certain stage of destruction or the likelihood of progression, is very important. According to previous studies, attachment reduction of population occurs steadily over time. And in a study of progression and regression of advanced destructive periodontal disease conducted by Reddy et al. 2000, 82.8% of the site did not show any improvement over the year, and 11.5% of the site did become shallower, and 5.7% of the sites became significantly deeper. So with better understanding with regards to disease progression, it may result in more appropriate prevention, management, and treatment in order for clinicians to control the disease. So our problem statements are lack of studies in periodontal site-specific disease progression in untreated periodontally involved teeth and in relation to tooth-based prognosis system.
So for the next part, for hypothesis, I will proceed with the hypothesis. From this 1 year of study, the hypothesis is null hypothesis as there is no noticeable differences in the disease progression for both treated and untreated group. So for the research objective, so our primary goals of conducting this research is because we wanted to compare the extent of periodontal disease progression in both treated and untreated group in 1 year period of time. And the rationale of conducting this research without any therapy at all, because we wanted to observe the purely the natural disease progression.
So for methodology, our study is a retrospective cohort study in observing the disease progression among periodontally involved teeth with absence of periodontal therapy and previously treated periodontally after 1 year devoid of treatment due to COVID-19 pandemic. And it is quantitative method through observation and secondary data analysis. And we use two data which are T0 and T1. T0 is patient data which recorded by the student prior to lockdown due to COVID-19 pandemic, and T1 is patient data which recorded a year after T0 data were obtained, and both T0 and T1 patient data record were collected through undergraduate and postgraduates integrated dental record management system, or also known as IDEMS. So our sample size is defined as unit per site, where sample size were calculated using effect size with assumed mean difference 40%, with a total of 140 sites periodontally involved teeth records were taken. There are 70 sites for test group, which are the teeth with absence of periodontal therapy, and also other 70 sites for control group, which are teeth that are previously treated periodontally.
So for the next part of methodology, which is the inclusion and exclusion criteria, so this part serves as a guideline for us to choose subject that's suitable for our research. So I will explain briefly the exclusion criteria, and the opposite of it will be the inclusion criteria. So basically, the research is conducted to observe the natural disease progression, as I mentioned before. So any factors that interfere with the natural disease progression will be excluded from this research. For instance, for the first exclusion criteria is those whose age below 36 years old. And this is because among this age, there's a risk of aggressive periodontitis. And for the second criteria is patients who had undergone periodontal therapy during the lockdown period, including scaling and also replaning. And the third exclusion criteria is patients with systemic disease such as diabetes, HIV and AIDS, TB, cancer, and many more. And this is because these systemic factors have an impact to the periodontium and interfere with the disease progression. For the next part of the exclusion criteria is those who consume medication that has an impact on periodontium, such as antidepressant, antihypertensive, and anticonvulsant. Next exclusion criteria is pregnant women because of the imbalanced hormone that cause increase in inflammation to the periodontium. And the last two exclusion criteria is a heavy smoker who smoke more than 10 cigarettes a day, and those on antibiotic therapy for the past 3 months. So for the data collection, actually there are few parameters involved, which is clinical attachment loss, periodontal probing depth, mobility, bleeding on probing, and also prognosis for T0. So for T0, the data was collected from the parameters prior to the lockdown, and T1 was collected 1 year later. And so from both T0 and T1, the difference of the parameters will be recorded and analyzed to study the disease progression. So for the statistical analysis, we are using SPSS version 25, and the next step will show the demographic data. So the data then will be tested using Shapiro-Wilk test, which is a normality test. A normal distributed data then will be tested using parametric test, which is an independent sample t-test, while for non-distributed data, will be tested using non-parametric test, which is Mann-Whitney U. But in our research, all data was normally distributed. So it is a parametric test, which is independent sample test.
So now we go into our result. So this is our demographic data, which sample size allocated to each group are distributed equally, with 7 patients of no treatment group with 68 tooth sites and another 7 patients for previously treated group with 64 tooth sites.
So for the next part of the results, so the overall mean PPD and CAL of no treatment versus SPT were recorded. So for the PPD, the mean value for no treatment is 0.54 mm, while for SPT group, there is gain in PPD for about 1.33 mm per year. For PPD group, there's significant difference with p-value equal to 0.01. Meanwhile, for the CAL, there's no significant difference were recorded. So the mean value for no treatment for CAL is 0.6 mm per year, and for SPT group there is gain for about 0.36 mm per year with p-value equal to 0.51. For the specific assessment of PPD 3 mm, 5 mm, and also 7 mm, the only significant difference recorded is for PPD 3 mm, while PPD 5 and 7 show no significant difference. So for PPD 3 mm, the score mean for no treatment is 1.2 mm, while for SPT group, there is gain for about 0.33 mm. For PPD 5 mm, the score of mean for no treatment is 0.13 mm, while for SPT group, there is gain for about 0.1 mm. Lastly, for PPD 7 mm, the mean score for no treatment is 1.27 mm, while in SPT group, there is gain for about 0.3 mm per year. For tooth loss, the mean score for no treatment is 1.43, while for SPT group is 0.57.
Okay, now we move on into our first part of discussion. So based on this study, the mean rate of clinical attachment loss for non-treated is 0.69 mm per year. So by comparison, a study conducted by Low et al. 1978, average attachment loss for various teeth in both jaws was slightly lower, which ranged from 0.2 to 0.24 mm per year. And mean rate of clinical attachment loss for stable or previously treated shows gain 0.36 mm per year. Next, according to the result of previous studies over a 24-month follow-up for stable or previously treated patient conducted by Nomura et al. 2017, at the patient level, 32.3% of the patient had only stable sites, and 26.7% of the patient had both improved and progressed sites. So this discovery is similar with our finding, as the mean PPD for stable or previously treated patient with sites 3, 5, and 7 mm for our data reveals an improvement in PPD level with a mean gain ranging from 0.33 to 0.35 mm annually.
So for the next part of the discussion, there are significant differences recorded in site level progression for PPD 3 mm compared to PPD 5 mm and 7 mm. So this is our findings, and this is continuous with the previous study conducted by Low et al. In 1986, where it shows a huge percent measurement of attachment loss among 1 to 2 mm compared to 5 to 10 mm in the moderate progression group. So this result is shows that annual periodontal maintenance is more successful in preventing the disease progression at early stage. For tooth loss, the mean annual rate of tooth loss for no treatment is 1.43 tooth loss per year, and it also shows that untreated periodontitis patients lose more teeth within a year compared to SPT group. So, for the conclusion, it is in a nutshell, the PPD at baseline were an important determinant of the PPD changes, because as we can see from our result, different PPD yields different results. With PPD 3 mm, it shows a significant difference, whereas for 5 and 7 mm, it shows no significant difference. So these all are our references. That's all from us. Thank you.
Thank you to Siti, Nurhaifa, and Nurabika for the excellent presentations. Now we'll proceed with the Q&A session from the judges.
Hi, Siti and Nurul. Thank you for your presentation. I'm a little bit confused here because your title state that treated and untreated group, right? So you have one group that you stated as doesn't didn't receive treatment for that 1 whole year period. The other one you classify as previously diagnosed group.
Previously treated actually, doctor.
So previously treated.
Yeah.
And then within that 1 year, did they receive any treatment?
First of all, thank you for the amazing question. So regarding your question, actually our research is on periodontitis patients, and we do not, for the subject that we choose, all of them did not receive any periodontal therapy at all, which is no treatment at all, within that 1 year period, because we want to observe the natural disease progression, which means without any treatment. But regarding your question, there are treated and untreated. Treated actually refer to the patient that has been periodontally treated before the lockdown, before the 1 year period. So for the untreated patient, they don't receive any therapy before and after the lockdown. So actually both groups did not receive any periodontal therapy at all in 1 year. But for the previous treated, there has been received the periodontal therapy before the lockdown.
Okay, so that means these two groups, one is being diagnosed but never received any treatment at all.
Actually, both group has been diagnosed with periodontitis.
Okay.
It's just that we divide it into two, which is one has been previously treated before the lockdown, and another one has never received any treatment at all.
Okay, so you diagnosed the disease and didn't give any treatment?
Actually, because during the lockdown, our clinic did not open, so the patient cannot come and did not receive any treatment. So, sorry, can you repeat that question?
Yeah, that's why I'm trying to think. You diagnose a patient with periodontitis, but you didn't give any treatment. Is it right or not? Because when you diagnose a patient with a disease, then you should provide treatment.
Actually, it is not intentional. It is the subject is not intentionally neglected by us. Actually, they don't receive treatment because they don't receive the treatment yet because of the lockdown. Because
Okay.
the lockdown occurs, so those who have been presented to the specialist and have been diagnosed with periodontitis, but they do not receive the treatment yet, which is 1 year later, after we have collected data and all, they already receive the treatment. And actually our data is not collected by ourselves. We are collected the data through the undergrad student and also postgrad student, which means, so we are not collecting them directly.
Okay, so I'm a bit also confused on your PPD gain as well. The periodontal pocket depth gain is not a good thing. That means you actually have deeper pocket. So the way you interpret it, PPD gain is not a good thing as compared to CLA gain. You get what I mean? Not? Because if you tell me PPD gain from 0.33 to 0.5, I think it's, yeah. So it's actually supposed to be reduction or it's a gain? Because if it's a gain, that means you have deeper pocket, which signifies that there is progression to periodontal loss, periodontal breakdown. So you go back to your slide and see, because you say PPD gain.
Actually, the term is a bit confusing. Actually, increase and gain indicate different things. For PPD, so if we say that it is increased, means that the pocket is getting deeper, which is the disease has progressed more. But when we say it gain, means the PPD has improved, which means the pocket gets shallower. Yeah.
So what are you trying to say? Because now you have stated PPD level with a mean gain ranging from 0.3 to 0.35. So that means there is a pocket reduction.
Sorry, can you repeat the question again?
Okay, you read your slide. It tells me there is an improvement in PPD level with a mean gain ranging from 0.33 to 0.35. If it is a PPD gain, that means you have deeper pocket. It's not improvement, it's deterioration.
Actually, as I mentioned just now.
Let me explain this actually. It should be gain attachment, gain in the attachment, not in the periodontal pocket. Yeah. So,
I'm a bit confused.
yeah, it's not clear actually, because I think you misunderstand what is meant by clinical attachment loss and gain in attachment. I have many questions actually. If you, regarding your title example, progression of periodontal disease. What do you mean by periodontal disease? Periodontal disease is gingivitis and periodontitis, isn't it? No. Yeah, when you classify periodontal disease, you classify it into periodontitis and gingivitis, isn't it? So I think you in this research you focus only on periodontitis. So you need to specify that this is a progression of periodontitis. Now my questions: how you calculate the clinical attachment loss and the gain of attachment? How you calculate it?
Sorry, how we calculate the gain or the
CAL, how you calculate CAL? CAL is a clinical attachment loss. How you measure it, how you calculate it, and how you measure it, yes.
So actually for the CL, we measure it from the CEJ to the deepest pocket.
From the CEJ to the base of the pocket.
Which is quite different with the
Yeah.
PPD we measure it from the top.
So did you find in our clinical setup for undergraduate and even for postgraduate, in your charting there is no CAL. There is no CAL. There is pocket depth, recession, mobility, bleeding, isn't it, furcation. So how you calculate this? How you come out with this figures?
For the CAL, because it is from CEJ, so we measure it, we refer to the recession. So if the patient has recession, so we will...
If you don't have recession, how you calculate? If you don't have recession?
I mean, how we get the CAL, we summarize the...
But you didn't see did you see this patient clinically?
No.
No, this is from the items, isn't it? Yes, from the record. From the record, we don't have the clinical attachment loss. Yeah, there is no clinical attachment loss. There is pocket depth, and the visit. The other visit, you evaluate the probing pocket depth, whether it is a decrease or decrease. So clinical attachment loss, you have to identify the CEG. And when you identify the CEG, from CEG to the base of the pocket, this is what we call it, clinical attachment loss. And you can compare it before and after. Now I am confusing with one thing. Actually, your targeted site or teeth?
Actually, our research is based on site, which is more site-specific.
So site. So site per tooth, we have the buccal, lingual, and mesial and distal. So which site? We have the mesio-buccal and we have the mesio-lingual site. So which site you target here? Because I didn't see in your presentation which site you are targeting, and then accidentally you talk about the tooth. So please, you need to maybe specify this, which type or which site you evaluate. You combine undergraduate student and postgraduate student.
We collected the data from both undergrad and postgrad students.
So the type of treatment which is provided by undergraduates until which level?
Sorry?
Until which level you provide the treatment for in undergraduate?
Sorry, Dr. Can you repeat the question?
The question in your clinic, you can do E&D, isn't it? Yeah. Motivation and oral hygiene instruction, scaling and root debridement, and review. But when you move to the postgraduate student, they can do the same thing, but in addition, they provide surgery for the patient. Yeah, they did a lot of surgery, open flap debridement, GTR, etc. So when you compare between, when you took this record from the postgraduate, actually the result will be completely different. Because the types of treatment, the modalities of treatment provided by the postgraduate is totally different from the undergraduate. Okay, I think time's up, but just one question. Did you consider 3 millimeters periodontal pocket?
Yeah, and in our research we include 3, which is 3 mm, 5 and 7 mm.
3 mm is not periodontal pocket. The normal depth of the gingival sulcus from 1 to 3 millimeters. From 1 to 3 millimeters. So 3 millimeters, it is not considered a periodontal pocket actually.
Actually, for that question, yes, 3 mm is not considered periodontitis, but because we choose based on subject, so that the person has already been diagnosed with the periodontitis, so among all the teeth, for that particular subject, they also have PPD with 3 mm. So in terms of the subject, the person have periodontitis, have been diagnosed with periodontitis, but they also have not just 5 to 7 mm, but also 3 mm. So that is how we take the
I'm sorry, I need to comment on your project anyway. Because
I'm so sorry that we have exceeded our time.
Sekejap je, comment ni. This is a clinical data that you're collecting from records. So I think a few of your studies are doing this as well. Be concerned that there should be a study protocol before you did your data collection, because there won't be any standardization in terms of when you're collecting data. There will be various level of data that will not synchronize. Dia tak sama. There's no calibration done. So there's validity and reliability of the data that you get can be in doubt, actually. Faham tak? Yeah, right? Thank you.
Okay, thank you to all judges.
Thank you to the judges for the questions. And next, please welcome our third presenters for today, Muhammad Ammar bin Abdul Hakim and Fatima Munira binti Muhammad Mahyudin, to present their research titled Clinical and Radiographic Assessment of Endodontic Disease Progression, a Retrospective Study During COVID-19 Pandemic. Please welcome.
Test.
Assalamualaikum and a very good evening. I bid to the honorable panelists, doctors, lecturers and fellow friends. My name is Fatima and my partner Ammar are standing here today to deliver a presentation of our research, which is the Clinical and Radiographic Assessment of Endodontic Disease Progression, a retrospective study during COVID-19 pandemic. These are the table of contents for our presentation for today. Let's start with the introduction. So apical peritonitis is an inflammation and destruction of the apical periodontium that is of palpal origin with or without clinical symptoms, which appears as an apical reticent area. It is often to be a response of the host inflammatory defense system to the microbial infection of the root canal space. It can also be caused by the traumatic injury, iatrogically from endodontic materials, chemicals, and also instrumentations which cause irritation to the periodontium. So the microbes that have already established their habitat in the necrotic root canal cannot be completely eradicated despite the activation of the host defense system. It is because apical peritonitis is not self-limiting. Hence why we want to update our knowledge on the endodontic disease progression to emphasize the need of the treatment to completely eliminate the source of infection and also to impede the microbes from reinfecting the root canal space through obturation procedures. So the pathogenesis of the endodontic disease has long been known, and it is important for us to understand. However, there are only a few classical studies that have been conducted on the endodontic disease progression. Therefore, there is a need for a better understanding of the endodontic disease progression to improve the understanding and comprehension of the dental practitioner and also to emphasize the patient the need to do root canal treatment. Moving on to the objective for our research, it is to observe the clinical changes in teeth with apical peritonitis within 12 months to 15 months in pulp-expected teeth and teeth without treatment, and also to measure the radiographic changes detected in teeth with apical peritonitis within 12 months to 15 months in pulp-expected teeth and teeth without treatment. So the 12 to 15 months is the duration from the first visit of the patient or the first treatment of the patient to the next expected visit due to COVID-19 pandemic. Moving on to our methodology. So the ethical approval for our research was approved on the 1st of July 2021 by the UiTM Research Ethics Committee. So the approved time frame for the data collection was from the 1st of July 2021 until the 15th of September 2021. So our research is a retrospective cohort study using secondary data of the clinical and radiographic data that were obtained from the items and also EasyDance of patients that were treated by the final year undergraduate students. For the samples, we receive it using the convenience sampling, and the analysis of the data, we divided it into two, which is the clinical parameter and radiographic parameter as listed in front. So this is the flow chart. From the 3 samples, we managed to obtain the clinical and radiographic data where we split it into 2 groups, which is 15 being the extirpated pulp and 15 being the non-extirpated pulp. So the data from the 12 to 15 months were collected from the respective group and were analyzed using the SPSS version 23.0. We made sure to collect our samples according to our inclusion and exclusion criteria. For the inclusion criteria, we include those patients that were registered at UiTM Dental Center, had completed their END, had preoperative and postoperative radiograph, the single-rooted teeth that were not obturated, and also not an abutment of any prosthesis. For the exclusion criteria, we exclude those patients who had not completed their END, multi-rooted teeth, and root-treated teeth with complicated cases, and also patients that had no preoperative or postoperative radiograph. Besides that, we exclude those that had received treatment in between the clinics and recalls, and also patients that have been prescribed with the antibiotics. We also, for our research, had done the inter-examiner calibration using the 20% of the samples that was supervised by our radiologist supervisor. And the coherence kappa value that were found, it was 0.83, which shows a good inter-rater reliability agreement between the inter-examiner. And again, I would like to emphasize that the halt of the treatment for our research are not purposely done, but is hindered due to COVID-19 pandemic.
Okay, so moving on with data collection. As mentioned before, we collected secondary retrospective clinical and radiographic data from items and EasyDen. The sign and symptoms was collected from the patient's progress notes, and from the radiograph images, we collected the diameter of the lesion along with the periapical index of the patient from the visit before the MCO and the visit 12 to 15 months after. So we followed the methods of Kim et al. 2016 to measure the diameter of the lesion, where a straight line is drawn on the teeth following its long axis, and the second line is drawn perpendicular to the first line at half of tooth length. the diameters were then recorded, ensuring parallelity to the drawn lines. The PAI, however, was obtained following the methods of Ostavik et al., where they have included a diagram showcasing the stages of PAI. For our results and discussion, for this research, majority of the patients are females, comprises 60% of the samples, while the other 40% are male, which can be seen on the pie chart. The highest frequency for the age group is 10, which are between the ages of 40 to 49, and the median age is 43. The most significant value found was pain for the non-extirpated group with p-value of 0.016. Pain for the extirpated group was relatively less significant with p-value of 0.063. This might be due to the long time interval of 12 to 15 months from the first visit, causing pain not only for the non-extirpated group, but for the extirpated group too. This long time interval can cause the apical peritonitis to transition from its acute phase into the chronic phase. Moving on, the clinical parameters in our study is tended to percussion, presence of pus, and swelling. All the findings were not statistically significant, which might be due to our small sample size. Next is analysis of the radiographic data. Independent sample t-test was used for the coronal apical and mesodistal diameters. We computed the difference in length for the coronal apical and mesodistal diameter in order to run the normality test. So, as you can see on the table above, table 3, the Shapirovic significance for both CA and MD is more than 0.05, which means that the data is normal, normally distributed. And the p-value for the independent sample t-test is both less than 0.05, which means that the data is significant. So, for the difference in length of CA and MD, the mean was calculated for both the extirpated group and non-extirpated group. For the extirpated group, there is an average mean reduction of coronal apical diameter of 0.627 millimeters, and in MD diameter of 0.620 millimeters for after 12 to 15 months. Meanwhile, the non-extirpated group show an average increase in CA diameter of 0.780 millimeters and in MD of 0.287 millimeters. This is evident that even in initial treatment, there's already some reduction in the lesion diameter. Next is, this is table 4. The periapical index of PAI was analyzed using Wilcoxon sign rank test. From the raw data, we can see that the extirpated group shows a negative rank of 5 or 5 cases of reduced PAI score, while the non-extirpated group only has 1 negative rank or 1 case of reduced PAI score. On the other hand, the extirpated group has a positive rank of 2 or 2 cases of increased PAI score, while the non-extirpated group has a positive rank of 3 or 3 increased PAI score. To simplify, the extirpated group has a PAI net reduction of 3 cases, while the non-extirpated group has a PAI net increase of 1 case. While the raw data indicates undergoing initial treatment will show improvement healing-wise after a period of time, the statistical analysis yielded for both groups shows no significance. In conclusion, it is found that in this study there is lesser endodontic disease progression that was found both clinically as well as radiographically in the pulp extirpated group compared to the patients who did not undergo initial endodontic treatment. So for our clinical significance, even initial treatment or emergency pulp extirpation will result in clinical and radiographical changes. But we still need to emphasize that endodontic treatment should be done as soon as possible. As for our limitations, we use 2D radiographic images. So in future researches, we highly recommend the use of cone beam computed tomography, CBCT, to ensure greater accuracy in gathering radiographic data, according to Saidi et al. 2015. That is all for our presentation. Shown above is a QR code that all of you can scan to access our list of references. Thank you.
Thank you to Muhammad Ammar and Fatimah Munira for the great presentations. Now we'll proceed with the Q&A sessions from the judge.
Okay, thank you for your very nice presentation. You have categorized as apical, the diagnosis is apical periodontitis, but you didn't tell us that whether is it symptomatic or asymptomatic. It may make a difference because symptomatic, obviously there is active infection going on as compared to asymptomatic.
Thank you for the question. For that, actually, because we are obtained from the secondary data from the items and incident, and because the objectives are to know the clinical changes and radiographic changes.
So the data we collected from the items already during the visit, they complained of pain. So I'm assuming that every subject, every sample that we have already have symptoms on the first visit.
So all the 30 subjects are symptomatic apical periodontitis. Okay, so then here you have stated in your title that you are doing clinical and radiographic assessment on the progression, right? So where is the clinical data? You dwell mainly on the radiographic findings. So the clinical data is only pain?
Only pain is significant because the other parameters yielded, the p-value is more than 0.005, so it's not significant.
So this is progression, right?
Yes.
After how long?
After the duration is 12 months to 15 months.
Okay, so your clinical findings, it's pain on percussion or just patient tell you pain or not pain?
Thank you. So for the clinical parameters, the pain indicates on the sinus symptoms, such as that the patient, actually the one that says that they are in pain. Well, we actually had another for the clinical parameters where we had the data for the tendon to percussion. And also swelling and also pus.
Okay, so this is the clinical findings. So pain on percussion and also swelling. So any improvement or it remains the same because there's no significant difference, right?
Yes, because from the data that we collected, it is found that the clinical parameters, there's no significant difference before and after for the tendon to percussion, swelling and pus because most of the patient during the examination and diagnosis, most of them are asymptomatic, but during the examination and diagnosis, but they actually came when they first registered in the clinic in the UiTM Medical Center, they are in pain, but when they are being called as patient, they have already lost pain.
So that is presumed that all 30 samples that you collected, the clinical notes are comprehensive and complete. So do you exclude any that don't have complete data?
Yes, to answer that question, yes, we do exclude those who have, as seen in our inclusion-exclusion material, we exclude those who did not have an incomplete ND, meaning like they didn't state in the progress notes, they didn't state any like valuable data, like they didn't report breast pain or there's also no pre-op or post-op radiograph of the patient.
So what do you mean post-op? After completion of RCT?
For the post-op, it means that for the pulp aspirated group, it is after the pulp aspiration procedures, after the 12 to 15 months, meaning that the pulp aspirated group first came for the first END, had already undergone the pulp aspiration procedure. Then for the second, we took the post-op after 12 to 15 months because of the movement control order, the patient could not came on time. But for the non-aspirated group, because we only the pre-op and also post-op too, it means that the pre-op it means that the patient did not undergo any pulp aspiration procedure, but after for 12 to 15 months, then the patient came and did another post-op radiograph. And yes.
Because after pulp extirpation, there is no reason for you to take post-op. You haven't started the RCT. Why is that a need to take post-op, unnecessary exposing the patient to radiology exposure? Because you have already extirpated the pulp. What you need to do is just continue your RCT.
I understand.
For both the groups, in fact, you have already made a diagnosis that you are going to do RCT. After 12 months, 15 months, even 1 year, 2 years, if your treatment plan has been to carry out RCT, there is no reason for you to take a radiograph prior to your RCT anymore. Probably you will take a radiograph for working length and for obturation status.
For that, we believe that there's long time interval between the first visit and the next visit, and because most of
Yeah, I understand there is a long time, but what difference does it make? You still have to do RCT. Even you take a radiograph, there's no diagnostic value to it. You have already decided that treatment plan is RCT. You know, there is no reason why post-op radiograph is required prior to your RCT.
Okay, maybe one question for me. In your exclusion criteria, did you exclude any X-ray, any clear X-ray?
Yes, for the question, we did remove any samples whose X-ray was not clear.
Not clear.
And also X-ray that did not reach until the apex or did not show the crown of the teeth. We exclude those X-rays.
Okay, thank you.
Thank you, judges.
Thank you to the judges for the questions. Without further ado, please come to the stage the next presenters, Alice Farhana binti Mahsudi and Nur Kamalia binti Nurizan, with their research title, Treatment Preferences and Trends for Restorations of Endodontically Treated Teeth, a Clinical Audit.
Test.
To conduct a research is to see what everybody else has seen, but to think what nobody else has thought of. Assalamualaikum and a very good afternoon I bid to the panels, dear lecturers, and all members of the floor. So before we proceed, let us first introduce ourselves. My name is Alice Farhana.
And I am Nur Kamalia,
And standing here today, we are going to present on our research project entitled Treatment Preferences of the Restoration of Endodontically Treated Teeth, a Clinical Audit. Ladies and gentlemen, Faculty of Dentistry UiTM has been established since the year 2006. And since then, our faculty have grown stronger and has offered multiple types of treatment to the patients. These include root canal treatment and also restoration. So, ladies and gentlemen, here comes the problem statement for our research, which is what are the trends of definitive restoration placed on the endodontically treated teeth by our faculty throughout the years. Next. So, ladies and gentlemen, first of all, what is ETT? ETT, endodontically treated teeth, are the teeth that have undergone endodontic treatment. So according to Wagner in 2006, endodontic treatment has caused the teeth to lose their mechanical strength. So generally, there are two types of definitive restoration placed on ETT. First is direct restoration, for example, like composite restoration and amalgam restoration. And second, indirect restoration, for example, like crowns, onlays, and inlays. So a study in 2017 has found that indirect restoration has higher survival rate, up to 5 and 10-year survival compared to direct restoration. However, ladies and gentlemen, it is difficult for us to conclude the best way to restore the ETT because every teeth need to be individually assessed. Next. So, ladies and gentlemen, these are the objectives of our study. First, it is to determine the treatment. It is to determine the trend of definitive restoration on endodontically treated teeth from the year 2008 until 2020 by our faculty. And the second, it is to evaluate the influence of clinical and demographic parameters on the treatment preferences of ETT. So, ladies and gentlemen, relate to our research title, our study is a clinical audit. Hence, our study was conducted according to the clinical audit cycle. So the first step would be the setting up the standard. So only those which fit into the inclusion criteria were included in the data analysis. And as for the data collection, clinical records such as students' progress notes and also the pre- and post-operative intraoral periapical radiograph were used to determine the trends. However, ladies and gentlemen, since this is just a 1-year period of research, it is impossible for us to carry out all the phases within just 1 year. So we only carry out the research until data analysis, and we will see if there are any changes that need to be implemented or any improvements that need to be done. Then perhaps the research shall continue in the future.
So ladies and gentlemen, so here comes the research results. As you can see, 260 of ETT were retrieved from the year 2014 until 2021. So this figure shows you the type of definitive restoration that plays on ETT throughout the years. As we can see, composite restoration is leading with a total number of 110, followed by PFM crown, all ceramic crown, and so on. Okay, the next slide will show you the definitive restoration placed among gender. So, a total number of 102 male and 158 female who age above 18 years old have participated in the study. We can see that the composite usage in male is higher than female, and all ceramic crown usage is higher in female compared to male. So this slide will show you the tooth type and definitive restoration. Tooth type are classified into incisor, canine, premolar, and molar. The blue color indicate composite restoration, while the yellow color indicate PFM crown. We can conclude that composite restoration is highly restored in incisor and canine, while PFM crown is highly restored in premolar and molar. Dear members of the floor, this is the trends of definitive restoration on ETT throughout the years, from 2014 until 2021.
As we can see here, there is a marked decrease in the use of amalgam, the red line in color, as amalgam has been prescribed in 2014 and 2015 only. And this could be due to patient aesthetic concerns and also due to mercury allergy. And then, as we can see, the metal crown, the dark blue line, it is only prescribed in 2015 and 2018. And there is also the lack of data recorded in 2020, and this is due to MCO, whereby the students were not able to continue the treatment, and the treatment was delayed and the cases were passed down to the juniors. All right, this slide will show you the correlation of demographic and clinical parameters with definitive restorations. Gender and tooth type have significant correlation with the definitive restoration. And the following slide will show you about 61 definitive restoration with post placement. This figure shows you about the crown ratio and definitive restoration with post. We can see that 1:2 crown ratio was recorded the highest. And this figure shows you about quality of obturation and definitive restoration with post. Unfortunately, unacceptable radiograph was recorded the highest by 32.8%. And this figure shows you about post-dentin ratio and definitive restoration with post. And 1:4 post-dentin ratio was recorded the highest, and followed by 1:2, and so on. And these last slides for the results shows you the correlation of clinical parameters and definitive restoration with post. Variables such as crown ratio, quality of obturation, and post-dentin ratio have significant correlation with definitive restoration with post. So now, we all know that the highest number of definitive restoration placed on ETT is composite. So it is a worrying situation because we know that direct restoration is not sturdy as indirect restoration. Based on the recent study, that indirect restoration have 5-year survival and 10-year survival compared to direct restoration. And this situation might be worrying, but we must accept the benefit of doubt and accept it because we did not assess the ETT clinically. And then the treatment preferences on ETT restoration is different among female and male patients because female choose all ceramic crowns compared to composite because according to Ferrier in 2010, dental ceramic provide better color stability, mechanical strength, clinical longevity, aesthetic appearance, and compatibility with periodontal tissues in comparison with composite. Hence, female are assumed to have more awareness regarding restoration choices compared to men. So ladies and gentlemen, throughout this research, we have found that 100% of post-encore cases were placed with fiber post. So there are also other alternatives that can be used. Hence, why are only fiber posts being used in UiTM? So we have come up with a few assumptions on why the student place fiber posts in post-encore cases. One of it would be the specialist preferences. Second would be ease of use. And the third would be due to availability of the materials in the clinic. Next. So ladies and gentlemen, before we consider the implications of the finding, we need to consider the strength and the limitations of the research as well. So these are the limitations that we faced throughout the study. So the first point, yes, ladies and gentlemen, this is due to the transition of our faculty from Shah Alam campus to Sungai campus. And another possible reason would be the change in the system where previously we used manual patients folder and now we have changed into the digital patients folder, which is IDERM. And the second point, yes, ladies and gentlemen, the data retrieve process was made difficult because the information that was written by the students were not specific enough, and also it is very disorganized. And for the third point, ladies and gentlemen, the number of students admission every year has affected on our data collection and also the data recorded for every year. So the last point would be, although MCO has affected our data research very much, because as we can see in the data 2020 and 21, the data were very insufficient. So, ladies and gentlemen, to improve the current situation, here are some of our humble recommendations. So, as we all know, poor quality of obturation will lead to the failure of ETT. Hence, we recommend to retreat the ETT with poor obturation quality to prevent the risk of failure. And the second one is to reconduct another clinical audit in at least another 5 years to improve the teaching method and also to improve the current situation. Within the limitations of our study, ladies and gentlemen, this is the conclusion. First, the highest number of definitive restoration placed on ETT would be composite, followed by PFM crown, all ceramic crown, PFM bridge, all ceramic only, metal crown, amalgam, and resin bonded bridge. The second one would be tooth type was determined to be the most significant factor that affect the treatment preferences. So with that, thank you.
Thank you to Alice Farhana and Nur Kamala for the wonderful presentations. Now we'll proceed with Q&A session from the judges.
Okay, thank you for the presentation. Can I look back at your conclusion slide? Okay, so you have concluded that the highest number of definitive restoration will be composite, followed by so on and so on, right? Okay, so what would you suggest to the faculty from your findings in terms of treatment protocol for ETT?
Okay, Assalamualaikum, and thank you for the question. So, one of the recommendation for the faculty involving in regards to the trend would be that we can suggest that to reconduct another audit in another at least 5 years to improve the trends, because we know that composite restoration is not the best restoration to be placed on ETT due to the
Yes, you have done your clinical audit now, right? So you have got the findings. So what would you suggest? Maybe from composite to do?
To do maybe all ceramic crown if it involves the anterior teeth, or PFM crown if it involves the posterior teeth.
Exactly. All right.
Yes.
Thank you.
Okay, thank you very much for a nice presentation. I am actually concerned that you say it's very worrying to see more composite has been placed. Now with the advancement of adhesive technique and improved composite, that is what we are going for. You know, so I don't think it's very, in fact, I'm very happy to see that composite has been used a lot, which is less invasive in comparison to a full coverage restorations. What I am not clear is why should there be a difference between the male and the female in terms of the ETT. Because you do not evaluate in terms of the gender of the patient. You evaluate the suitability of final restorations for ETT according to your evaluation of the tooth itself, whether there's enough remaining tooth structure, whether it's going to be used as a bridge abutment, whether there is high occlusal load on that particular tooth. Why should a gender be a significant factor?
Thank you for the question. So according to our second objective, we would like to evaluate the influence of clinical and demographic parameters on the treatment preferences of ETT. So gender is categorized as demographic parameter. So so we would like to see if there are any if there is any influence among gender with the definitive restriction.
Yeah, I know. But then your finding is the female is different from the male, right? In terms of the usage. Yeah. To be honest, I'm not so convinced because I think it could be the number of male and female patients that you have. You know, because when you do evaluation for restorations for ETT, it's mainly based on clinical findings. Another thing is, this is a clinical audit. You have one of the parameter as crown root ratio. So in your record, is it a must that it needs to be recorded down as crown root ratio? That students need to put this data?
So for crown root ratio, we only evaluate among the teeth that have been that have post placement.
Yeah, how do you get this data? Because this is retrospective, this is clinical audit. So how do you get this data of crown root ratio? From the notes itself or from the radiograph that you measure or what?
Alright, so okay, I understand. So the crown root ratio was determined by the pre and post periapical radiograph of the EDT with post placement through our
crown root ratio has got nothing to do with the post. Crown root ratio is the amount of periodontal support for that particular tooth. So how do you get this data of crown root ratio? It's mainly the periodontal support, right? And you need to get it from the notes itself. What I'm trying to say is it standardized that students need to provide this data in their clinical record? Otherwise, how do you get this crown root ratio?
So we retrieve the data for crown root ratio from our software EasyDent, and we measure the crown root ratio from the periapical radiograph. So crown root ratio, there is a study that shows that the minimum crown root ratios.
I know what is crown root ratio. Okay, because what I'm seeing here is there's no radiograph. 42% has no radiograph. Right? So how do you get the data for crown root ratio? Is it extracted data from the notes or, you know, I'm just trying to see how do you get this data out?
It is actually from extracted data from the progress note and also from the...
So for the progress note. So altogether, how many cases you have for this whole research? And
so a total of 260 endodontically treated teeth, but for teeth with post placement, only 61 data are treated.
That's what I'm trying to say. Crown root ratio has got nothing to do with the post. If you are looking at the one with post, it's actually post-crown ratio. Crown root ratio tells you how much of the root is being supported by the alveolar bone. So there is an indication of the periodontal support for that tooth. It's got nothing to do with your post at all.
Okay, doctor, thank you for the comments.
Okay, thank you so much. Nothing left for me. But did you include the postgraduate student? I mean, the work from postgraduate or only undergraduate?
So one of our inclusion criteria is that all the extracted data must be treated by undergraduate students.
Undergraduate only.
And we
Okay.
exclude postgraduate and specialists.
Okay, can you go to the your slide recommendation? Yeah, the first one. Can you elaborate more or explain to me? Is it accepted by the lecturer to sign and to approve an acceptable obturation?
Okay, so we do not know if if it is accepted by the lecturer or not, but most of the cases, since we are referring from the radiograph and also from the progress note, and also we have a look at the radiograph with post-placement, majority of the radiograph will classify into unacceptable.
Majority.
Yeah, and also we refer from a paper from March in 2004 when we are classifying the criteria for the radiographic.
No, because it's very hard to come out with such a recommendation. I mean, we need to be really aware about this when you come out with certain recommendation. You have to be totally aware about this type of recommendation, because the X-ray cannot tell you everything. Okay, so I suggest maybe rephrase this statement in a way to be more acceptable. Okay, thank you.
Thank you for the comments. We will take note and perhaps propose it in the next research. Thank you.
Thank you to the judges for the questions. Now let us welcome our fifth presenters, Melissa Muhammad and Jasmine Amira binti Abdul Jamil, to present their research topic entitled Effect of Denture Cleanser on the Surface Roughness and Color Stability of the Polymethyl Methacrylate PMMA denture-based resin, an in vitro study. Please welcome.
Test. According to NOSA 2010, almost half of the population requires oral prosthesis. Thus, denture care is an important topic for us to discuss. Assalamualaikum and a very good evening. I bid to all panel judges and all attendees that are present in today's event. I'm Jasmine. I'm with my partner Melissa. We are going to present our research entitled The Effect of Denture Cleanser on Surface Roughness and Color Stability of the Polymethyl Methacrylate PMMA denture-based resin and in vitro study. As we are all informed, acrylic complete denture is an economical, friendly treatment to rehabilitate edentulous patients, as it can restore patient many needs, such as self-esteem, aesthetic, mastication, and as well as improve their phonetics. However, the nature of its surface will able to provide an environment for the bacterial and color adhesion. Thus, denture cleaning plays an important role, such as mechanical and chemical, where one of the common chemical techniques is by using denture cleanser. However, it is the sodium perborate content in the denture cleanser can cause surface roughness and color changes on the denture base. Meanwhile, there is no study that shows that this rough surface will affect the color stability of the denture base and could contribute to more staining of the denture base. So in this study, that coffee is used as our main staining elements, as color changes can occur through intrinsic and extrinsic factors. Coffee is a yellowish brown color and it contains tannic acid with the pH 6 to 6.4, and coffee can stain acrylic resin through absorption and adsorption.
Thus, the objective for our study are to compare the surface roughness and color stability of the PMMA denture base before and after immersion in the denture cleanser in a different period. Second, to evaluate the effectiveness of the denture cleanser in removing stain. In this study, we are using Polydent antibacterial denture cleanser (PADC). Okay, so this is a simplified form of our methodology. We will go one by one. First is the preparation of the sample. 30 disc-shaped denture base were prepared by the mixture of the acrylic resin, were made and packed into a stainless steel mold with a diameter of 10 mm and thickness of 2 mm. After the denture base has been processed, they will be divided into 6 groups, 1 control groups and 5 test groups. Each group will have 5 denture base. And then all the samples were immersed in distilled water at 37 degrees Celsius for 48 hours prior to baseline measurement, recorded as T0 for the color stability and also the surface roughness using the profilometer and spectrophotometer. And later on, all the samples will be immersed in their respective immersion solution. For the control groups, will be immersed in distilled water every day, while for the test group, will be immersed in denture cleanser 8 hours daily according to their allocated time. For group 1, will be immersed in 1 day per week. For group 2, will be immersed 2 days per week. Group 3, 3 days per week. Group 4, 5 days per week, while Group 5 will be immersed 7 days per week, meaning that Group 5 will be immersed in denture cleanser every day. At the end of the week, the data for the surface roughness and color evaluation were taken. And these steps were repeated for 8 weeks. Thus, we have reading for T1, T2, T1, T2, T3 until T8. Okay, and then after 8 weeks, control groups and 2 test groups were selected. For test groups were selected based on the surface roughness, the lowest and the highest. Group 3 has the lowest, Group 5 has the highest surface roughness. All the groups for the control, Group 3 and Group 5 were immersed in the thermocycline coffee standing challenge for 192 cycles. After they had been subjected to the coffee, they were immersed in denture cleanser for 8 hours. And then the color measurement was taken before and after the samples is subjected to the denture cleanser. And then these were repeated for 4 times, and all the data collected for this study were statistically analyzed with using the repeated measurement ANOVA. Moving on to the results.
Okay, this is the result of the surface roughness of the denture base after 8 weeks of denture cleanser immersion. This is the bar chart showing the surface roughness of the denture base, comparing between baseline and the after 8 weeks of denture cleanser immersion. The result showing a trend of increase after the denture cleanser immersion, with significantly different within Group 4 and Group 5 with p-value less than 0.05. The highest surface roughness seen in the study was 0.133 micrometer and after the denture cleanser immersion. According to Bolen 1997, the surface roughness value with below 0.2 micrometer is considered safe from plaque accumulation and bacterial adhesion. Thus, the surface roughness value produces in our study give very minimal effect on the plaque accumulation and bacterial adhesion. Next is the color changes of the denture base, where this bar chart showed a significant increase of the color changes of the denture base, comparing between baseline and after 8 weeks of denture cleanser immersion. Based on the National Bureau of Standard, NBS, it is the value of critical color difference remark has been quantified as NBS units and can be calculated through a formula. And in our study, we could appreciate that the NBS unit of the color difference has increased for test group from group 1 to group 5, where it is still within the slight changes range. Thus, the color difference of the denture base in our study produces was still within the clinically accepted range.
Moving on, this is a bar chart showing off the mean color difference of denture base, coffee stained denture base after immersion in denture cleanser. As you can see here, there's a significant reduction of the color with p-value less than 0.05. Thus, we can say that the denture cleanser able to remove stain. This is agreement with a study done by Hollis et al., where he found that denture cleanser able to remove stain from the denture base. And also, we evaluate the we assess the surface roughness, relation of the surface roughness with the color changes. Thus, the group 3 with a lower surface roughness compared to group 5 showed higher color difference. Hence, we say that there is no relation towards surface roughness and color absorption towards after coffee immersion. Okay, we faced a few limitations as this is a laboratory studies. We highly depending on the machine and also lab technician. First, short of experimental timeline due to MCO. This caused the delay when the machine is broken, so it delayed the repairing of the machine. Second is non-contact profilometer was unavailable, thus we need to use the contact profilometer. This will cause micro scratch on the denture base, thus may produce less accurate reading. Third is only single brand was used for the denture cleanser and denture base. Fourth is this study was unable to replicate exact oral environment as we are lack of human saliva and also dental biofilm.
Okay, we have concluded from the study that after the denture cleanser immersion, it produces an increase of surface roughness. Meanwhile, there is minimal effect on color changes seen on the denture base. Secondly, the longer the immersion period of the denture cleanser, the greater the surface roughness value were produced. Thirdly, there is a significant decrease in color changes when the denture base were exposed to coffee after the denture cleanser immersion. Lastly, we could say that there is no significant relation of the degree of coffee color absorption towards the surface roughness value. Okay, last but not least, we would say that this is a novel study as we are the first one to experiment the different period immersion of the denture cleanser frequencies, and as well as we use this thermocycling machine to produce more accurate aging produce. And then this study also able to recommend denture wearers in terms of denture appropriate care and in terms of the immersion frequency of the usage of the denture cleanser. Other than that, we could say that this data of the research could be used as a guideline for the clinicians as well as the dental hygienists to advise their patient in terms of the usage of denture cleanser. That is all from us. Thank you.
Thank you to Melissa and Jasmine Amira for the amazing presentations. Now we'll proceed with the Q&A sessions from the judges.
Okay, thank you for the beautiful presentation. Nice slides. Can you tell me why did you choose coffee over other stained beverage?
Okay, thank you for the wonderful question, Doctor. So we chosen coffee as our main staining elements because according to NOSA 2010, the most consumed beverages for elderly is coffee in Malaysia.
Okay. Would it be any different in terms of your results if you use tea instead?
Okay, there are other studies also done on the other beverages also. As we know, tea is also acidic. It could produce staining as well, but other studies have also done on the beverages.
So it could have the same effect, more or less. Yeah. Okay, thank you.
Okay, thank you so much. Very nice presentation and good work actually. I have a few questions, and one of the questions may be very strange, but no. So, why you adjust 8 hours to immerse the denture in coffee? Why not 1 hour, 2 hours, or 3 hours? And you choose only 8 hours. Why?
Okay, Prof, thank you for the wonderful question. So actually, in this study, we are using Polydent antibacterial dental cleanser as the most commercial dental cleanser in Malaysia. According to the Polydent, it should be immersed for 3 minutes. However, we put 8 hours for this study because of previous study also did for 8 hours. And then the 8 hours is to get more significant results. If in the future we have the opportunity to pursue this study, we can follow the exact manufacturer instruction. Thus, we'll get more accurate results.
No, I'm asking this question because assume that, alhamdulillah, I didn't wear any denture. So if I am wearing a denture, so the coffee will stay in my mouth for 8 hours if I...
Okay. Based on our methodology, the coffee will stay for 192 cycles. 192 cycles equivalent to 1 week in vivo. So the coffee stays 1 week. We assume that patient were drinking coffee for a week, and then thus after the patient drink for a week, then only they will immerse in the denture cleanser for 8 hours.
Okay. Now, which type of coffee you use? 2-in-1, 3-in-1, or pure coffee?
For our studies, we are using the tin can so we can maintain the concentration of the coffee. We are using Nescafe Coffee O, black coffee.
And the concentration of the coffee?
I'm not sure the concentration of coffee, however, the concentration is maintained because we're using tin can coffee.
Yeah, because it affects the color also if you use a certain concentration. So I assume that you are simulating the oral cavity, isn't it? Simulating the oral. So why you immerse the sample in distilled water rather than artificial saliva? Yeah, if you want to simulate the oral cavity. So why you choose distilled water, not artificial saliva?
Because, thank you for the question, because if you want to use the human saliva, you're going to cost a bit. So instead of using human saliva, we use distilled water instead.
Okay, I got one strange question actually. I'm very curious about this. I saw my friend names is here, Dr. Raja Azman. Dr. Raja Azman, he is periodontist. Yes, periodontist. And you know, for us, when there is no teeth, we don't touch the patient. So he is periodontist. So how you can explain to me this?
Thank you, Prof, for the question.
Yeah. What's his role?
We include his paper, we refer his paper for our study, is to relate with the dental biofilm. As we mentioned, that surface roughness will cause accumulation of the dental plaque, which may induce inflame of the mucosa.
But you immerse it in distilled water. This is why I ask you. If you immerse it in saliva maybe it could be a little bit logic. Okay, thank you so much.
Yeah, thank you so much. I'm actually a bit confused on your study design. You have group 1, 2, 3, 4, 5. So I assume all these 1, 2, 3, 4, 5 will be subjected to thermocycling first and then immerse in the denture cleanser. And then out of this 1, 2, 3, 4, 5, at what stage do you evaluate them for surface roughness and also for color stability?
Okay, thank you for the question, Prof. So, our study, first we divided into control and test group, 5 test groups. Our study is like different from the other studies because we immerse in denture cleanser first and then only in coffee. Why? Because to answer our first objective, which is and
the
also
surface roughness.
Yeah, the effect of the denture cleanser on surface roughness and color stability. That's why we immerse the samples in denture cleanser first, and then at the end of the week, we took both color and surface roughness evaluation each week. Yeah, for
Okay.
8 weeks. Then only we immerse in coffee just to relate is the roughness of the denture cleanser can the effect of the color absorption.
Okay, because we know coffee is acidic, right? So when you have a change in the surface roughness, how do you know? Is it due to your coffee or is it due to your denture cleanser? So how, because now you are mixing up all this, again, I mean, I have brought it up previously as well. When you are testing a test group, there can only be one variable. You cannot have two variables. When you have two variables, that become a confounding factor. So how do you determine which is which? Whether the surface roughness changes due to the coffee, which is acidic, there is a possibility that would affect the PMMA or your denture cleanser.
Alright, thank you for the question. As you mentioned, for the first we first subjected the samples into the denture cleanser and then we took the color and the surface roughness. However, after the 8 weeks involving the coffee, we don't calculate the surface roughness. We just calculate the color changes. That's why it won't influence our results for the surface roughness of the denture piece.
So for all the 30 samples, you calculate the surface roughness?
Yes, for the first one, we calculate all control and all the groups from group 1 to group 5, just to see does the denture cleanser has effect on the surface roughness and the color. And then for the second one is we want to relate the surface roughness have been reobtained from the previous steps, and then does it has relation to the color absorption? Does it affect more on the color absorption? Does the surface roughness reading will not confuse as we get it from the coffee or the denture cleanser because we didn't calculate the surface roughness for the second steps.
Okay, so what is the difference between 1, 2, 3, 4, 5 then?
Okay, for this one, as I mentioned, this is just to see the effect, the effect of the denture cleanser alone to the PMMA denture base. So, thus all the samples will be immersed. However, our second objective is to assess the effectiveness of the denture cleanser in bloom stain and also to relate the surface roughness and the color changes, surface roughness and the color absorption. From this one, we can obtain the surface roughness for all samples. Thus, we pick the lowest surface roughness and the highest surface roughness just to see is there any obvious difference between the highest and the lowest surface roughness regarding towards the color absorption of the coffee, which is this one. That's why we picked group 3 and 5 only, as 3 has the lowest and 5 has the highest surface roughness.
Okay, so your surface roughness can be due to your sampling preparation, variation. It may not be due to your denture cleanser, right? So when you pick 3 and 5, I'm not sure whether is it a valid method to do so or not. Because mainly your surface roughness is how you have polished your specimens.
Okay, I'm sorry that we have exceeded our time. Thank you to the judges for the questions. With no delay, please welcome our last presenters for today's competitions, Muhammad Ashrani bin Asban and Nur Shafia Aina binti Muhammad Saleh, to present their research topic entitled Perceptions of Interprofessional Education Among Clinical Healthcare Students at University Technology Mara. Test.
Booker Washington, an American author, once said, "If you want to lift yourself up, lift up someone else." Assalamualaikum and a very good afternoon. I bid to the honorable panel of judges, lecturers and also my fellow friends. I'm Nur Shafia Aina binti Muhammad Saleh and my partner,
Muhammad Ashrani,
will be presenting on our elective research project entitled Perceptions of Interprofessional Education Among UiTM Clinical Healthcare Students. Okay, so question might come across your mind. What is IPE? WHO in 2010 defined that interprofessional education, IPE, is an experience that occurs when students from two or more professions learn about, from, and with each other. So, the goal of IPE itself is to teach students on how to work together in an interprofessional team in order to improve patient care and also have outcomes. So as IPE has been introduced in many countries, its implementation in Malaysia is not thoroughly explored. Previously, reported by Ahmad et al. In 2017, there are various difficulties in establishing the program. So these challenges include, the first one is inadequate facility, the second one is lack of educational experts, the third one is silo nature of healthcare practice, and the last one is overloaded curriculum. So diagram on the right side shows the effect of IPE adapted by Homya et al., which to optimize the value of IPE, it can be achieved by patient and professional level where knowledge and skill exchange have to occur concurrently. Based on previous literature review, there is a lack of study on the perceptions of IPE on healthcare students in Malaysia. Hence, our objectives are first to investigate the perceptions of clinical healthcare students at UiTM on the current implementation of IPE, and second objective is to explore perceptions of clinical healthcare students at UiTM on the future implication for IPE. Moving on to the methodology, so the study design is a descriptive, quantitative, qualitative, cross-sectional study involving final year UiTM clinical healthcare students from Faculty of Medicine, Dentistry, Pharmacy and also Health Sciences, with the total of sample size of 420 calculated by EPI info. So the students involved in this questionnaire were selected via simple random sampling. The online questionnaire utilized is developed based on the existing literature review, which is by Ahmad in 2017 and Yun in 2020, consisted of 3 sections. The first one is demographic characteristic of the subject, the second one is current training and also perceptions of IPE. So the instrument will content validated by panel of senior academic researchers, and following this, phase validation was done. Prior to the data collection, a written permission was sent to the deans of respective faculty to conduct the online questionnaire. So the distribution of the questionnaire was linked via their official university email to the students. Further analysis of the students' perceptions of IPE, items in section C were grouped into respective category, which is the important, effectiveness, and also preference of IPE. Quantitative data collected and statistically analyzed by SPSS. Categorical data was done by chi-square. Numerical data was done by ANOVA with significance p-value less than 0.05. Qualitative data was analyzed via thematic analysis. Moving on to the result.
Ladies and gentlemen, let's take a look at our result. We managed to achieve an overall response rate of 91.2%, and the diagram on the right shows the breakdown of response rate by each program. So, in the study, we found a very compelling result. This table shows the percentage of agree by students for each item in the questionnaire. Participants show an overall highly favorable perceptions toward all items. In exception, there was a significant difference in responses among the students on agreeing to attend lectures with students from other healthcare fields, which is item number 9, and their preference in having lectures taught by lecturers from other healthcare fields, which is item number 10. The table on the left shows the mean perception on importance, effectiveness, and preference category for IPE. The students show an average perception of 4.587. As anticipated, there was no significant difference in mean score among the students, and they show positive perception towards each category. The right table shows the domain of additional perception cited by the students. So let's dive into their opinion on IPE. For the first domain, IPE was cited as a great platform to know about each other's role in a multidisciplinary team. For the second domain, IPE gives them the opportunity to learn with students from other fields. For the third domain, IPE allows them to know others' perspective on management handling programs. And then for the fourth domain, IPE was perceived as a very beneficial as it can add new knowledge and relate to their own course. This chart shows the participation of students in various teaching and learning activities involving IPE. Out of all students, 63.2% have experienced IPE during their study. Webinar is the highest learning activities, followed by lecture, community engagement activity, workshop, PBL, clinical training, and tutorial. Participants cited others as sports event, co-curriculum, and competition. This chart shows the barriers perceived by the students to the implementation of IPE. There was no significant difference in responses among the students. Time constraint was perceived as barriers the most by the student, followed by communication difficulty and lack of skills. Other challenges expressed by the students include cost, lack of awareness and interest, differences in understanding others' responsibilities, subject, commitment issues, language barrier, internet connection, and social interaction with unfamiliar people, especially in a large crowd. Let's put our heads together about the result. This study found IPE-related activities have been experienced by the majority of the students, mainly involving webinars, lectures, and workshops. Online webinars have been found to be convenient and accessible, resulting in increased participation over the years. However, fewer percentage of students in this study reported having experienced IPE via community engagement activities. On the contrary, studies by Mofu in 2014 and Stahl 2016 in other universities, they show that IPE were conducted via community engagement activity involving mainly underserved population, individuals with disability, and medically compromised patients. It is very encouraging to note that the students were positive about the implementation of IPE in their programs, with many opting that it should be constituted as one of their educational goals. The students believe that IPE will provide a positive impact towards their future career as a healthcare professional, and they are willing to participate in IPE-related activity, despite a number of students still prefer lectures without students from other healthcare, and they are not taught jointly by lecturers from other healthcare fields. This result is supported by a previous study in 2020. Time constraint, communication difficulty, and lack of skill were perceived as the main barrier by the students in undergoing IPE activities. So integration of IPE into service learning measure, university towards society program or SULAM could therefore fulfill the students' request for opportunity to participate in IPE-related activity. Hopefully, such an approach could address concerns regarding time constraint, cost, and commitment issues which were perceived barriers by the students in this study. Although there is a significant difference in our opinion among the students regarding the involvement of students and lecturers from other healthcare fields, the support from the majority of this individual provides positive implication for such activities to be conducted in the future.
Okay, after hearing all the after hearing all the interesting data that Ashani has stated, let me summarize the
study. IPE has been experienced by many students, mostly via lectures and also webinars. So students provide positive feedback on various aspects of IPE, and they agree that IPE is important and also effective. Students cited time constraint, communication difficulty, and having lack of skill as main barriers toward implementation of IPE. Hence, the recommendation that could be emphasized on is to do a small group discussion to address issue with communication difficulty, lack of understanding and awareness of each other's roles, as well as lack of skill expressed by some students in this study. An ice-breaking session could be conducted where they can share experience and information of each other's professional scope of practice. Helen Keller once said, "Alone we can do so little, but together we can do so much." With that, I end my speech. Thank you.
Thank you to Muhammad Ashrani and Nur Shafiq Aina for the amazing presentation. Now we'll proceed with the Q&A session from the judges.
Okay, thank you very much for a very lively presentation. So I just want to know, how did you conduct your questionnaire survey?
Okay, so for the online questionnaire, since the method that we use is simple random sampling method, so actually we contact the administrative office of all programs, and then we ask for help for them to distribute the online questionnaire based on the response rate that we have already collected based on the EPI info. So actually the administrative office will help us to distribute the questionnaire via their official university student email.
Okay, so there is no briefing whatsoever that has been conducted to the intended participants.
Yes, that is one of our limitations, because we could somehow meet them in virtual, in physical meeting, so that we could explain what is IPE itself. But based on the questionnaire that we have distributed, there's already the definition and what is IPE, so that students can read from that and they will somehow know what is IPE.
Yeah, because from what I see, the perception of IPE is very different from what we know of IPE. Attending lectures together between dental student, medical students and pharmacy student is not considered as IPE. IPE needs to be focused on patient care, that the students of various faculty that is related come together and put in their planning and management of a patient to enhance the patient's treatment outcome. That is IPE. So sitting in the same webinar and lectures alone is not IPE. So that's why when I look at your finding, I think the students may have a different perception of what true definition of IPE is. Another thing is, you have mentioned that there is a quantitative and also qualitative as well. So you have also done a focus group discussion as well?
For focus group discussion, there is no focus group discussion. For the qualitative part, we only ask the student if there is any other comment that they would like to add on. So
that is not considered as qualitative, because I see that you have put quantitative and also qualitative, means it's a mixed mode type of research methodology. So that's why I'm waiting for the findings from the focus group discussion. So you cannot put there as a qualitative because you have not done a focus group discussion. Yeah?
Okay, Prof, thank you.
Okay, thank you so much. Interesting work. I have two questions actually. The first question is, how you randomize the sample?
For the sampling, we contacted the administrative office, and they will randomly select the final year student.
Yeah, how randomly? Yes, this is what I want to know actually. Yes, you randomize or they randomize and how they randomize the.
Actually, that is on their part. They randomize the number of students selected from the list of names that they have.
How they randomize it?
How they randomize?
Yes.
We give them just the number of students needed to answer the questionnaire, and they actually choose the students selected by themselves. So, as for example, the first name and then the third name, which is done by themselves.
Okay, good. Now, one of the most important difficulties is in communications. Can you tell me why? Why the majority they said that there is difficulty in communications.
I think, in my opinion, in our course we have our own jargon that is not easily understood by other students in other courses. So there was communication difficulty between in between courses.
Communication between student or student and lecturer?
In between students.
Between the student?
Yes.
Okay, thank you.
All right. Your conclusion, you said that student support for IPE provides positive implications, right? So what will be the positive implications that you mean?
Could you sorry, Prof?
Okay, your conclusion. You stated that student support for IPE provides positive implications for future implementation, right? But if you see your results, you can see that most students have a lot of challenges in terms of time constraints, like communication skills, like Prof. Wan said. So where is the positive implication part?
What we mean by the implication of this study is this study would provide a important information on the future implementation of IPE in this university. So the IPE will improve improve patient health outcome.
Okay, so how would you answer back your objective, which is the study aim to investigate the perceptions of clinical healthcare students? So what is your conclusion based on your objective study?
So the objective is to find out whether the students are ready to undergo IPE activities. So this data can be used to develop IPE in all universities.
Okay, I think that's it. Thank you.
Thank you to the judges for the questions. Ladies and gentlemen, let's give a big round of applause to all the presenters to express our recognitions of their well-prepared presentations. With that last presentations, all presenters have successfully presented their research. We have now come to the end of today's presentations. On behalf of the organizing committee, we would like to express our thanks to all of you here for gracing your presence to our event for today. We truly appreciate it. Now, I would like to call upon our Dean, Professor Datuk Dr. Muhammad Ibrahim Abu Hassan, accompanied by Associate Professor Dr. Nur Hazlina, to give tokens of appreciation to our honorable judges for today's presentations. Please welcome. So now I would like to welcome all the judges to come to the stage. The first judge, Professor Dr. Xiao Liang Lin, the Dean from IMU. The second one, Professor... The second judge, Professor Fuad Hussein Al-Bayati from UiTM. And the third judge, Associate Professor Dr. Nurul Ashikin Yahya from UKM. Thank you to Professor Datuk Dr. Muhammad Ibrahim Abu Hassan and Associate Professor Dr. Hazlina. With that, I end my duty as a Master of Ceremony for today's competition with wabillahi taufiq wal hidayah. Wassalamualaikum warahmatullahi wabarakatuh. Thank you very much, ladies and gentlemen. You may now adjourn. See you tomorrow.